Các kỳ đại hội tim mạch của Hội Tim mạch Việt Nam đều là những sự kiện rất lớn trong cộng đồng tim mạch. Nhưng lần này sẽ rất đặc biệt. Dấu mốc lớn chính của đại hội ngày hôm nay là Hội Tim mạch Việt Nam trang trọng 30 năm ngày thành lập hội.
30 năm, đó là một chặng đường dài đầy ắp những kỷ niệm, những đôi bề gian khó với vô vàn khó khăn. Cho đến ngày nay, chúng ta đã thu được rất nhiều các thành tựu đối với ngành tim mạch Việt Nam.
Hội Tim mạch Việt Nam từ khi được thành lập, giai đoạn đầu tiên rất khó khăn, nhưng hôm nay chúng ta đã có cơ ngơi cả bề thế. Đó là những cái thành tích về kiến thức y học về tim mạch. Chúng ta đã hội nhập sẵn sàng vào các quốc gia ở trong khu vực Đông Nam Á, và trong một chừng vực nào chúng ta sẽ đã có tiếng nói, sẽ có tiếng nói nhiều hơn trong cái thời gian sắp đến.
Đã thành thông lệ, Đại hội Tim mạch toàn quốc luôn quy tụ những chuyên gia, những nhà khoa học hàng đầu trong chuyên ngành tim mạch trong nước cũng như quốc tế, đem tới những chuyên đề mới nhất, cập nhật nhất và nóng nhất cho các bạn đồng nghiệp trong nước.
Đến với đại hội lần này thì chúng ta không chỉ tham gia những phiên khoa học hết sức bổ ích, mà chúng ta còn có dịp gặp nhau để ôn lại những kỷ niệm hết sức xúc động của Hội Tim mạch học.
Chào mừng đến với Đại hội Tim mạch toàn quốc
kỷ niệm 30 năm Hội Tim mạch học quốc gia Việt Nam.
Alo.
Alo, chưa. Alo. Good morning. To start this session, welcome everyone to this wonderful session. Today we have a conference on cardio-oncology. I would like to introduce the first speaker, Dr. David Linker from the University of Washington Medical Center. Dr. David Linker is a leading expert in cardiology and in echocardiography and cardiac imaging. He was trained in Stanford University and many and he is expert in many fields of cardiac imaging. He will speak on left ventricular function by echocardiography for oncology patients, when and for whom.
Ladies and gentlemen, let me first thank the organizers for inviting me to speak with you today. My topic is left ventricular function by echocardiography for oncology patients, when and for whom. Why should we assess left ventricular function in cancer patients? The reasons are many. The first is that many chemotherapy agents can be cardiotoxic. Also, baseline LV function is part of the risk assessment in planning chemotherapy. Surveillance evaluation during therapy helps find problems early and allows adjustment of the chemotherapy regimen if necessary. Post-therapy evaluation identifies those who have sustained injury in higher risk protocols. The recommended surveillance depends upon the chemotherapy protocol being used and the baseline risk of the patient. The guidelines are based on expert opinion. Fortunately, detailed guidelines were just published in August 2022 from the European Society of Cardiology. The majority of the talk today is based on those guidelines. They have recommendations for the baseline assessment, including some general considerations. They feel that echocardiography is recommended as the first-line modality for the assessment of cardiac function in patients with cancer. 3D echocardiography is recommended as the preferred echocardiographic modality to measure left ventricular ejection fraction. Global longitudinal strain is recommended in all patients with cancer having echocardiography if available. A special case is those who are prior to potentially cardiotoxic therapies. And then they say baseline comprehensive transthoracic echocardiography is recommended in all patients with cancer at high risk and very high risk of cardiovascular toxicity before starting anti-cancer therapy. They also have recommendations for what should be included in the baseline evaluation. This is the diagram of their recommendations for right ventricular and right atrial evaluation, left ventricular and left atrial evaluation, and other structures as well. It also includes their recommendations for cardiac magnetic resonance evaluation. The guidelines are stratified based on patient risk and protocol risk. There are a large number of protocols, and we will look at some of them. Probably the most important is for anthracyclines, because they are quite cardiotoxic. A close second is HER2 targeted therapies, and then there are VEGF inhibitors, breakpoint cluster region Abelson oncogene locus inhibitors, proteasome inhibitors, immune checkpoint inhibitors. Then there's the question of risk stratification. This is often done using the Heart Failure Association and International Cardio-Oncology Society risk stratification protocol. This classifies patients into low, medium, high, and very high risk. Those are the categories that we used in this presentation. One of the measures that's recommended is global longitudinal strain. So what is strain? Strain is a term for the deformation caused by an applied force. In this context, it is a way to approximate myocardial fiber shortening. It is measured by tracking ultrasonic speckle in the myocardium. It requires specialized software, which is proprietary for each manufacturer, careful image acquisition, and review of the automated measurements to make sure that no errors have occurred. It ends up with a measure of percent shortening, so the numbers are negative. Less negative is worse, meaning worse function. The most commonly used measure is the average peak global longitudinal strain, abbreviated GLS. Normal is less than minus 18%. For example, minus 22% is completely normal. Borderline is minus 18% to minus 16%, and abnormal is greater than minus 16%. For example, minus 12% is greater than minus 16% and would be abnormal. This illustration shows how this is calculated. My apologies, it doesn't seem to be playing right now, but what happens is the software will look at the endocardium and trace the endocardium and calculate the strain on 3 different views. There are also a number of other calculations which are not necessary for our uses. The key point is just the numbers in the lower right corner. And in fact, there's only one number that's important. And that is circled by the yellow oval. To make it easier to see, we can have a close-up of those numbers where we have the strain calculated from all 3 views and then the average at the bottom, circled in a red oval right here. It is only this number that we use. In this case, the patient had a average peak global longitudinal strain of minus 19.2%, which is completely normal. If we look at the recommended protocol for anthracycline chemotherapy, then there are a couple of points that we will be seeing repeatedly on all of these protocols. It is classified into patients who are low risk, moderate risk, and high or very high risk. In addition, the different timings have different colors. At the bottom, we see the code, which is that green is class 1 recommendation, meaning very strong recommendation. Then there's a yellowish color, which is 2A, which means that the majority of the experts agree. And then the orange color is class 2B, which means that it was not a majority of the experts, but some of the experts felt this was a good idea. What we can see is that all the experts agree that with anthracyclines there should be a baseline evaluation and a evaluation at the end at 12 months post-therapy. They also all agree that for high and very high-risk patients, there should be periodic evaluations during the therapy protocol. There's some disagreement about the other patients, whether they should have an intermediate evaluation. For HER2 targeted therapy surveillance protocol, There is generalized agreement that there should be surveillance throughout the evaluation, stratified based on the baseline risk. For VEGF inhibitor surveillance protocols, there's some more disagreement among the experts. All agree that those in the high and very high risk category should have a baseline evaluation, and most agree that those in those risk categories should have periodic evaluation during therapy. But then there is some disagreement for the moderate risk category. For the breakpoint cluster region Abelson oncogene locus inhibitor therapies, this is much more complicated and depends upon the particular agent that's being used, seeing that for one agent all of the experts agree that there should be a baseline evaluation, whereas for other agents then there's some heterogeneity about what the recommendations are. For proteasome inhibitors surveillance, there is general agreement that at baseline all of the patients should have an echocardiographic evaluation, whereas there is some disagreement in terms of what should be done during therapy. For immune checkpoint inhibitors, there is agreement for the high-risk patients that they should have a baseline evaluation, but there is not agreement for the other patients, with some experts feeling that they should have an evaluation. So, in conclusion, echocardiography is the preferred way to assess LV function in patients undergoing cancer care therapy. 3D echocardiography and strain should be used if available. 2D left ventricular ejection fraction is acceptable if 3D is not available. The frequency of evaluation is based on the patient's risk and the treatment plan. Expect the protocols to be refined with further experience. Thank you very much and for your attention.
Hello. Thank you so much, Dr. David Linker, for your interesting presentation. And next present, I would like to invite Dr. Marta Anhama Beluto from Harborview Medical Center, Sydney, WA, USA. She will present the paper titled Money Modernity Imaging to Evaluate Coronary Risk for Oncology Patients. When and how? Please.
Hello, my name is Marta Alama. I'm one of the general cardiologists and echocardiographers at the University of Washington in Seattle with a special interest in cardio-oncology. And it is my pleasure to present today this very interesting topic, multidisciplinary imaging to evaluate coronary risk in oncology patients, when and how. I have no disclosures. Cardiovascular patients with cancer, but normally when we think about coronary cardiovascular disease in this patient population, we think about heart failure. But the fact is that coronary artery disease is also quite prevalent, and this is due to different factors. First, both diseases, coronary artery disease and cancer, they share risk factors: older age, suboptimal lifestyle, and in general inflammatory states. But also there are cancer therapies that can increase your risk of myocardial ischemia, and you have a quite comprehensive list of the biggest offenders. And there are studies showing that a diagnosis of cancer with chemotherapy plus minus radiation increases your chances of myocardial ischemia by different mechanisms: vasospasm, endothelial injury, arterial thrombosis, and early atherosclerosis. On top of that, these patients actually have suboptimal care and therefore worse outcomes, mainly because they don't receive revascularization despite it is indicated and there is good data that they benefit cancer patients, or they may be on suboptimal medical therapy for their coronary artery disease. So patients tend to have higher rates of myocardial infarction after debuting with coronary artery disease. They have higher risk of bleeding, potential discontinuation of their cancer therapy, and higher rates of mortality. So it's important, since we are going to all encounter these patients in our clinic, to be familiar with this cancer patient population and try to focus our attention on prevention and early diagnosis. And I would like to start with these two patients from my clinic, Miss K. She's a 63-year-old female who is having this chest pain on exertion concerning for angina. She has metastatic breast cancer, has received many therapies, including radiation to the chest twice in the left, and she has also other classic cardiovascular risk factors. And then we have Mr. R, who is a 46-year-old male with history of ischemia at a very young age, revascularized with normal EF, has T-cell lymphoma, and now he needs clearance for his allogeneic stem cell transplant. And he also have significant amount of cardiovascular risk factors. So how do we approach these kind of patients? Let's start with when do we evaluate with non-invasive techniques for coronary artery disease. Well, if the patient is symptomatic, we do exactly the same as with non-cancer patients. The main difference is that we need to speak with the oncologist and everybody else involved in the care of that patient to see what is the risk of cardiovascular complications versus the potential risk of stopping or delaying important cancer therapy. But other than that, same indications. Other indications in cancer patients: exercise intolerance that persists more than 12 months after the conclusion of cancer therapy. We need to think that maybe this is an angina equivalent. Asymptomatic high-risk cancer survivors, and these are mainly patients who have undergone radiation to the chest. Classically, we offer a screening in patients that had received at least 15 grays of mean heart dose, or a total of 35 grays when the heart is in the radiation field. But nowadays, we also know that older patients with less radiation exposure and more prevalent cardiovascular risk factors are also at higher risk. So we should start screening those patients after 5 years of conclusion of the radiotherapy, and then every 5 to 10 years, depending on their risk profile. And the way to go in these patients is with functional testing. Other indications are more controversial. For example, those asymptomatic patients that are on high-risk cancer therapies, mainly platinum-based agents. Should we test them all or not? We still don't know. How about patients like Mr. R that have significant cardiovascular history or cardiovascular risk factors, and they need clearance for high-risk cancer treatment? Well, here there is no one recommendation that fits all patients. We have to balance the risk of cardiovascular complications with that treatment versus the risk of delaying necessary cancer treatment. So again, multidisciplinary conversation between cardiology, oncologists, and everybody else involved in the care of the patient. And the general rule of thumb is to act similarly to what we do for those patients that require preoperative cardiac evaluation, where we take into account functional status, presence or not of symptoms, cardiovascular risk factors, and how time sensitive that cancer treatment is. And then finally, how about asymptomatic patients that have coronary artery disease in non-cardiac CT? What do we do with those patients? So actually that has been looked at. This group looked at the prognostic value of coronary artery calcifications, or CAC, in patients that are undergoing surveillance oncologic PET CTs. And they compared that value with that of metastatic disease and the classic priming and cardiovascular risk factors. And what they saw is that those patients, in these patients, the highest predictor of all-cause mortality and cardiovascular events are actually metastatic disease and CAC, on top of, independently of the rest of cardiovascular risk factors. Or in other words, those patients who have non-metastatic cancer, CAC is the strongest predictor of all-cause mortality and cardiovascular disease and cardiovascular events. What they also saw very interestingly is that half of those patients will meet a criteria for statin use just based on that PET findings. So we have there a very good opportunity to start prevention measures in patients in order to improve outcomes and decrease cardiovascular events. And what is more important is that data is there for us to look at. I will encourage you to open your patients' CTs done for other causes to look for vascular calcifications, because you may have an indication for statins there that otherwise will be missed. In terms of stress tests in cancer patients, is there one better than other? And there is very few data. In general, the recommendations are the same than for patients with that don't have any cancer. And this small study was done in Hodgkin disease patients, and they compared different modalities of stress tests. And what they saw is that nuclear SPECT had the highest sensitivity compared to treadmill stress test and stress echocardiography, mainly exercise echocardiography, but that came at a cost of low specificity or very high rate of false positives, which in this patient population makes a lot of sense because many have received radiation to the chest and these patients have microvascular disease. So they may have perfusion defects with normal epicardial coronary arteries. This will apply for PET as well, right? That can also diagnose microvascular disease. But other than that, we all know the indications and the limitations of the different modalities of stress tests and are exactly the same for patients with cancer. In terms of other techniques, cardiac MRI, we could look for coronary artery lesions, but CT has much better spatial resolution, so we don't use it for that purpose. We are familiar with perfusion cardiac MRI with the use of vasodilators. We can look at wall motion abnormalities and LV function as we do with echocardiogram, and with the use of gadolinium, we can look for first pass perfusion defects during vasodilatory stress, or for late gadolinium enhancement, looking for a scar and viability. No difference between cancer patients and non-cancer patients, but where cardiac MRI may be helpful in this specific population is looking for different patterns of late gadolinium enhancement in patients that come with cardiomyopathy. For example, classic example would be myeloma, multiple myeloma patient with low ejection fraction, and then the reason for that could be either coronary artery disease, and if that's the case with the late gadolinium enhancement, we are going to see subendocardial enhancement. It could also be cardiac amyloidosis, and if that is the case, we are going to see patchy infiltrates that many times affect the atria, or it could be related to the previous cancer treatment with proteasome inhibitors that many times don't even give you any signs of late gadolinium enhancement. There are other cardiac MRI techniques such as T1 mapping and extracellular volume that can help us to distinguish myocardial ischemia from other causes of cardiomyopathy, and you have there acute myocardial infarction patient will have a very high T1 and very high extracellular volume pattern. And others, such as, for example, T2 mapping, looking for edema, that can tell us about the amount of myocardial at risk of a scar or microvascular dysfunction that is, as we said before, important in patients who have received radiation, and that sometimes we can miss with gadolinium. Coronary artery calcium, we mentioned before, patients that are asymptomatic who have non-cardiac CTs for other reasons, but how about ordering specific cardiac CTs in these patients, where in the general population, we know that it's a very easy, very reliable, not expensive test. And we know that higher calcium score is associated with higher cardiovascular events. And we also know that the number needed to treat is quite low for those patients who have a CAC above 100. We just need to treat 12 patients with statins to avoid one event. So it's a great example of how medical treatment impacts outcomes significantly. The same applies for cancer patients with just one extra indication. As we said before, please review the oncologic CT scans or any other CT that the patient has had, looking for vascular calcifications, as we may have the indication for statins right there at low cost. We don't have to put the patient under another expensive test. Similar to the general population, in patients with intermediate atherosclerotic cardiovascular risk, when the results will affect management, CAC with cardiac CT is indicated, but also in the low risk ASCVD patient with other non-classic cardiovascular risk factors based on their previous cancer treatment, either radiation or any of the therapies that we mentioned at the very beginning that can also increase your risk of myocardial ischemia. And finally, we have coronary CTA is a great alternative to invasive coronary angiography with really good diagnostic accuracy. It can assess total plaque burden, and it can help us to characterize the plaque composition and tell us about some high-risk features that increase the risk of acute coronary syndrome in some patients. In radiotherapy patients can be helpful, as many times these patients have very eccentric lesions. For example, in that image, you have a patient with breast cancer with a very eccentric, large, diffuse plaque that is not that easy to assess with invasive coronary angiography. So in those patients, coronary CTA can be helpful. Regarding when to use coronary CTA versus stress tests, similar with the general population. If we have a younger patient with very few cardiovascular risk factors where we suspect less obstructive coronary artery disease, coronary CTA probably is favored because it can help us to rule out obstructive coronary artery disease and can help us to diagnose non-obstructive plaque. So we are going to put a lot of emphasis on prevention measurements. Now, for older patients with higher amount of cardiovascular risk factors, when we suspect more obstructive coronary artery disease, a stress test may be favored because then we can focus our attention on an ischemia-guided management and the amount of myocardial at risk to base our decisions regarding treatment. So let's go back to our patients. Let's start with Mr. R, 46-year-old male, needs a stem cell transplant due to lymphoma, and has a history of ischemia at a very young age with significant amount of cardiovascular risk factors. Well, what do we do with this patient? We pick up the phone, and I found out from oncologists that actually he had a very high risk lymphoma, and he had a very narrow window of opportunity to receive his transplant before the lymphoma recurs. So he had a normal functional capacity. He was on the right therapies to prevent further events. And we decided to clear him for transplant with very close monitoring. And thankfully, he underwent the treatment with no cardiovascular events very successfully. How about Miss K? 63 years old female with metastatic breast cancer on treatment, has received radiation to the chest twice, has significant amount of cardiovascular risk factors, and is having a history that is very consistent with exertional angina. So my suspicion for coronary artery disease is quite high. So I decided to do an exercise echocardiogram. On the top, you have the resting images, and in the bottom, you have the stress images. She was able to go 10 minutes with no symptoms, so that was really good. And in the resting images, you see how she has normal ejection fraction, no wall motion abnormalities. But at peak exercise, she had dilated LV with wall motion abnormalities in different coronary territories, which made us concerned about multivessel coronary artery disease. So we took her to the cath lab, and she in fact had significant proximal to mid RCA lesions and mid left circ lesions and moderate lesions in the mid left LAD. So we stented the RCA and the left circ lesions, and she had resolution of her symptoms. I continue following her regularly, and she's doing quite well, focusing on secondary prevention. So this is the end of my talk. I just want to emphasize some take-home points. First, that coronary artery disease is very prevalent in cancer patients. Patients with non-metastatic cancer and coronary artery disease have worse prognosis than patients without it, independently of other cardiovascular risk factors and independently of their cancer diagnosis. Whereas symptomatic patients should be screened in the same way as non-cancer patients, some high-risk asymptomatic patients with cancer, mainly those who have received radiation to the chest, may benefit from coronary evaluation. The when and how depends on many factors and requires a close collaboration with our oncology colleagues to see how high is the risk of cardiovascular complications, how much we can delay if we can delay at all their cancer treatment. And the presence of coronary artery calcifications in non-cardiac CT is associated with increased cardiovascular events, and its identification provides a golden opportunity to start preventive therapies at a very low cost. So as we said before several times, please open those non-cardiac CTs looking for an indication for statins. Thank you very much. I really hope that you are enjoying the conferences and that you found this talk helpful. If you have any questions at all, please don't hesitate to contact me at that address. Thank you very much.
Thank you. Thank you so much, Dr. Marta Anhama Bellotto, for the wonderful presentation. We have enjoyed the two excellent presentations from Dr. David Linker and Dr. Marta Bellotto. And now we have 10 minutes for discussion. I would like to invite the audience to give questions to the wonderful speakers. May I have a question for Dr. Linker? Can you please recommend what cutoff we should use for to define heart failure recover EF in patients with cardio-oncology?
I'm sorry, could you repeat the question? I was having some technical difficulties here. Could you repeat the question? I was having some technical difficulties and had trouble hearing you.
Hello.
I'm sorry, may I repeat the question?
Yes.
Yeah. Can you hear me? My question is regarding the heart failure recover EF. So which cutoff do you think we should consider at which we can tell this patient has recovered EF with cardio-oncology patient? Thank you.
Thank you for the question. I think that is a very difficult question because the whole question of heart failure with recovered EF is still quite controversial. There's evidence that people who have had a depressed EF and have recovered may still, if you stop GDMT, may still have a fall in their EF, whereas other people may not have a problem. I think that it is very difficult to decide. I think that in general, I advocate a case-by-case evaluation with a bias towards continuing at least some elements of GDMT, such as ACE-ARB and beta blockers for the majority of the patients, although you may use less intense therapy if they have recovered.
Thank you very much. And Dr. Khoi from University Medical Center in Ho Chi Minh City. I have a question about the role of GLS in the algorithm of diagnosis and management of oncotherapy, chemotherapy-induced cardiotoxicity. So we know that the GLS have some advantages over the EF, but right now in the algorithm, we based mostly on EF, LVEF. So how is the role of GLS in your clinical practice when you use the EF? And the second question, right now we just started to collaborate the oncologist and cardiologist, your experience in this initial phase, who will lead, or how can we create a team that we can have a comprehensive and fruitful collaboration? Thank you.
Thank you for some very good questions. What we know about GLS is that it is more sensitive than the EF alone in terms of detecting injury. At the same time, there are challenges with the GLS in that there are different software packages, and also there can be technical difficulties that cause errors in measurement of the GLS. So it requires quite a bit of attention to detail and experience to do it. The second point is that how to interpret that even when you've done it well. And in general, I can speak for the oncologists I've worked with. If it is very depressed, then they will take that as a signal, even if the EF is still borderline normal. If it is borderline, then it's still a worrisome situation, and it's just a risk factor you need to take into account in terms of the total evaluation. At our institution, we are developing a team approach where there are certain cardiologists who are trying to primarily interface with the oncologists. And I think this is a very good development, because then you can have cardiologists who speak the same language, become more familiar with the different protocols and the risk factors. And you can have a team approach where there are oncologists and cardiologists who have worked quite a bit together. So I think that is something that is desirable to develop.
Thank you so much. Thank you so much, Dr. Linker. I have one more question. In female patients who had radiation, who are obese, who had surgery, can you please advise which way to optimize the image, and can we optimize the measurement of cardiac function? Which view we should use? Can we use subcostal view in this patient?
So thank you for the question. The question is how to optimize for female patients, I assume for breast radiation and reconstruction. This is, I think, something that is individualized, and the best is to have excellent sonographers who are very experienced, because I think it has to be individualized for each patient. And certainly there can be situations, especially if they've had breast reconstruction, where there are certain views that will be difficult or impossible to obtain. So I don't think I can give you a sort of formula or an algorithm for what's the best approach.
Thank you so much. And we have one more question for Dr. Marta. Can you please advise on the role of strain using MRI in cardio-oncology patient?
Strain MRI was the question in cardio-oncology patients. Okay. Yes. Okay. Yeah, normally in our institution, we do use MRI quite often. We don't use strain MRI that often yet. It's more investigational at this point. If you have very well knowledge echocardiography lab, most of the times a strain by echo is enough. Where we do use MRI a lot in cardio-oncology patients is, for example, for that patient you guys were discussing where the windows are not good because they just underwent reconstruction of the breast. Then MRI can be very helpful when you have a very high index of suspicion that they may have LV dysfunction, or when they are under cardiotoxic cancer therapy. But normally a strain MRI, we don't use that much. It's still investigational at this point.
Presentations, and now we will move on to the next speakers.
Hello. Tiếp theo thì xin mời Phó sư tiến sĩ Đinh Thị Thu Hương ở Viện Tim mạch Quốc gia với báo cáo sàng lọc và đánh giá nguy cơ tắc mạch ở người bệnh ung thư cho ai và như thế nào. Xin mời Phó sư Hương.
Thank you. Good morning, everyone. And I will present in Vietnamese. Vâng. Qua hai phần trình bày trên thì chúng ta đã được nghe về các cái phương pháp sàng lọc về chẩn đoán hình ảnh để đánh giá về chức năng tim cũng như là bệnh lý mạch vành ở các bệnh nhân điều trị ung thư. Thì chúng ta biết là ung thư là một cái bệnh đang rất là phổ biến và ngày càng tăng dần ở tất cả các nước trên toàn cầu. Và một cái nguyên nhân được góp phần vào làm cho tỷ lệ tử vong ở các bệnh nhân ung thư tăng cao đó là thuyên tắc huyết khối. Và nó là nguyên nhân thứ hai đứng ngay sau cái ung thư đó. Đầu tiên là người ta chết vì ung thư và sau đó là người ta chết vì thuyên tắc huyết khối. Vậy thì làm thế nào để chúng ta có thể kiểm soát được các bệnh nhân về thuyên tắc huyết khối đấy? Người ta thấy rằng là ở các bệnh nhân ung thư mà có huyết khối và so với bệnh nhân không có huyết khối thì tỷ lệ ở bệnh nhân có huyết khối và ung thư thì tỷ lệ tử vong tăng hơn gấp 4 lần so với các bệnh nhân không bị ung thư, không bị huyết khối. Và người ta thấy rằng là khoảng xấp xỉ 20% các trường hợp thuyên tắc huyết khối là xảy ra ở người bị bệnh ung thư, và đó là nguyên nhân thứ hai là tử vong thứ hai ở các bệnh nhân ung thư. Và nguy cơ tái phát thuyên tắc huyết khối ở bệnh nhân ung thư thì rất là cao, gấp từ 2 đến 5 lần ở bệnh nhân không có ung thư. Và người ta thấy rằng là tỷ lệ về ung thư tăng dần, đồng thời với tỷ lệ là thuyên tắc huyết khối ở các bệnh nhân ung thư cũng tăng dần theo các nghiên cứu từ năm 97 cho đến năm 2017. Và một cái nghiên cứu trên 200 bệnh nhân ở tại Việt Nam thì chúng tôi thấy rằng là 52,2% bệnh nhân huyết khối tĩnh mạch sâu chi dưới được phát hiện ung thư trong thời gian nằm viện. Và với các bệnh nhân mà điều trị hóa chất thì cái tỷ lệ thuyên tắc huyết khối nó xảy ra nhiều nhất là trong cái giai đoạn đầu, trong 4 cái trị liệu đầu tiên. Và sau đó nếu như bệnh nhân xuất hiện là di căn thì đấy cũng là một cái giai đoạn mà tỷ lệ huyết khối rất là tăng cao, và nó sẽ đeo đẳng suốt cuộc đời cái người bệnh trong suốt thời gian còn sống của các bệnh nhân ung thư. Do đó mà cái việc khảo sát là hết sức cần thiết. Với các bệnh nhân ung thư mà phải trải qua phẫu thuật thì người ta thấy rằng là cái tỷ lệ trên sơ đồ đây chúng ta thấy là cái tỷ lệ thuyên tắc huyết khối ở các bệnh nhân phẫu thuật ung thư nó tăng rất cao ngay từ những ngày đầu tiên sau khi phẫu thuật, và rồi sau đó là giai đoạn tiếp theo là điều trị hóa chất sau phẫu thuật thì cái tỷ lệ ung thư đó tăng vọt. Đấy là các cái giai đoạn mà chúng ta cần phải khảo sát thuyên tắc huyết khối ở các bệnh nhân ung thư mà có phẫu thuật. Và người ta thấy rằng là 46,3% cái đột tử do tắc mạch phổi là xuất hiện ở các bệnh nhân ung thư có thuyên tắc mạch phổi. tuổi càng cao, bệnh nhân bị ung thư mà tuổi càng cao thì tỷ lệ thuyên tắc huyết khối càng tăng. Trên sơ đồ trên đây chúng ta thấy là cái đường nó dốc đứng thẳng lên, với khi mà tăng dần tuổi từ độ tuổi 20, 24 cho đến độ tuổi 85 thì cái tỷ lệ huyết khối nó càng tăng dần. Và huyết khối thì xuất hiện ở các đối tượng bệnh nhân khác nhau, ở các cái mức độ ung thư, các bệnh cảnh ung thư khác nhau sẽ khác nhau. Và chúng ta thấy rằng là huyết khối sẽ cao nhất ở cái nhóm ung thư tụy, rồi các cái ung thư hệ tiêu hóa, ung thư sinh dục. Và bệnh nhân bị ung thư di căn thì có nguy cơ huyết khối gấp 20 lần so với bệnh nhân ung thư mà chưa di căn. Nên với bệnh nhân mà ung thư mà ở giai đoạn muộn, chúng ta phải rất cẩn thận trong cái việc rà soát xem bệnh nhân có thuyên tắc huyết khối hay không. Vậy thì tại sao các bệnh nhân ung thư lại có cái nguy cơ huyết khối cao như vậy? Thì có 4 nhóm nguy cơ hoặc là yếu tố khởi phát để dẫn đến cái thuyên tắc huyết khối ở bệnh nhân ung thư. Cái nhóm đầu tiên là nhóm liên quan đến chính bản thân bệnh nhân. Và những bệnh nhân này thường có các cái bệnh đi kèm theo, và đấy là yếu tố nguy cơ. Rồi bệnh nhân có tiền sử của các cái bệnh lý tĩnh mạch từ trước, như là suy tĩnh mạch hoặc là tắc tĩnh mạch từ trước. Và ngoài ra thì còn có thể khảo sát các yếu tố di truyền. Thứ hai nữa là các cái yếu tố nguy cơ liên quan đến chính bản thân cái khối u đó, vị trí khối u ở đâu và mức độ chèn ép các loại ung thư như thế nào. Thì cái nhóm mà đối tượng có nguy cơ rất cao đấy là các nhóm nguy cơ, các nhóm bị ung thư dạ dày, ung thư tụy và ung thư não. Và các cái nhóm nguy cơ cao đấy là ung thư phổi, ung thư hệ bạch huyết, ung thư các cái phụ khoa và ung thư thận. Và việc chúng ta sang giai đoạn, khi các bệnh nhân sang giai đoạn di căn thì cái tỷ lệ ung thư, tỷ lệ thuyên tắc huyết khối nó càng tăng lên gấp bội. Chính cái bản thân cái việc điều trị của bệnh nhân ung thư cũng là một yếu tố để dẫn đến thuyên tắc huyết khối. Thì ngay cái phần trình đầu của cái ông giáo sư Mỹ vừa rồi chúng ta thấy đấy là các cái điều trị hóa chất khác nhau nó sẽ có mang tới cái ảnh hưởng khác nhau đến cái chức năng tim, và ở đây là ảnh hưởng đến cái tỷ lệ huyết khối. Bản thân các cái khối u đấy nó sinh ra các cái biomarker khác nhau, và đấy cũng là yếu tố để khởi phát nên quá trình tăng đông, và từ đó dẫn đến tỷ lệ huyết khối tăng lên gấp bội. Và với cái khuyến cáo của Hội Mạch Máu châu Âu năm 2021 thì đã đưa ra cái việc là cần phải rà soát thuyên tắc huyết khối ở các bệnh nhân bị ung thư, đặc biệt là các bệnh nhân mà thuyên tắc huyết khối mà lại không rõ yếu tố khởi phát, thì cái việc cần thiết là chúng ta phải đi tìm ung thư ở đâu đó. Thì đấy là cái khuyến cáo cấp độ 1A. Vậy thì làm thế nào để chúng ta đánh giá nguy cơ huyết khối ở các bệnh nhân ung thư? Thì chúng ta có một cái thang điểm Corona ở các để giúp chúng ta đánh giá ở các bệnh nhân ngoại trú. Thì thang điểm Corona này người ta sẽ căn cứ vào cái điểm, cái cơ quan bị ung thư đó là cơ quan nào. Ở cái nhóm mà nguy cơ rất cao, đấy là ung thư dạ dày và ung thư tụy thì được 2 điểm. Và các nhóm nguy cơ cao như là phổi, u lympho, ung thư sản khoa vân vân thì là cho 1 điểm. Rồi bệnh nhân trước khi điều trị hóa chất mà cái công thức tiểu cầu là trên 350 x 10 mũ 9 là 1 điểm. Rồi cái hemoglobin giảm dưới 100 gram trên lít là cho 1 điểm. Rồi các cái điều trị hóa chất trước đấy và các cái công thức bạch cầu của bệnh nhân trước khi điều trị mà trên 11 thì lấy là cho 1 điểm. Và đặc biệt ở những nhân mà BMI cao trên 35 thì cũng là một yếu tố nguy cơ và được cho 1 điểm. Và đây là một cái nghiên cứu để đánh giá khi áp dụng cái thang điểm Corona này vào trên 819 bệnh nhân và thời gian theo dõi là 656 ngày, thì người ta thấy rằng là cái điểm Corona càng cao thì cái tỷ lệ về thuyên tắc huyết khối rất là tăng một cách rất là rõ ràng. Bước thứ hai là chúng ta có thể dùng cái thang điểm Well khá là quen thuộc để chúng ta đánh giá về cái nguy cơ thuyên tắc huyết khối tĩnh mạch sâu chi dưới, như là ví dụ như là bệnh nhân ung thư đang hoạt động rồi liệt bất động, nằm tại giường nhiều ngày, rồi có các cái triệu chứng của tắc tĩnh mạch như là đau dọc đường đi của tĩnh mạch, chân sưng hơn và đặc biệt là chân sưng một bên, chân to đau hơn, và chúng ta có thể đo đường kính của hai bên chân. Nếu mà nó chênh nhau 3 cm thì đấy là một cái dấu hiệu rất đáng ngờ. Rồi phù chân có triệu chứng tĩnh mạch nông bằng hệ nổi dưới da hoặc tiền sử huyết khối tĩnh mạch sâu, và các cái chẩn đoán, nếu có cái chẩn đoán tương tự khác mà lại giống thuyên tắc huyết khối thì trừ 2 điểm. Và các bệnh nhân có nguy cơ cao về thuyên tắc huyết khối nếu như trên 2 điểm và ít có khả năng nếu như dưới 1 điểm. Và bên cạnh đó chúng ta có thang điểm Well để đánh giá tắc mạch phổi, thì chúng ta cũng dựa vào các cái triệu chứng lâm sàng để đánh giá. Nếu bệnh nhân có các triệu chứng lâm sàng như là đau sưng ở bên chân thì lúc đấy là chúng ta cho 3 điểm. Rồi các cái tiền sử về đã thuyên tắc huyết khối hoặc tắc mạch phổi, rồi tần số tim là một cái dấu hiệu rất là rõ để chúng ta có thể khảo sát được. Thì khi đó nếu mà tần số tim trên 100 là 1,5 điểm. Và nếu bệnh nhân bất động trên 3 ngày trong vòng 4 tuần vừa rồi thì chúng ta cho 1,5 điểm. Và cái tiền sử đã bị tắc mạch phổi hoặc là tắc tĩnh mạch sâu là 1,5 điểm. Rồi thiếu máu, rồi là các cái giai đoạn di căn. Và khả năng nguy cơ cao của tắc mạch phổi nếu mà trên 4,5 điểm và ít khả năng hơn nếu mà là 4 điểm. Và đây chính là sơ đồ chẩn đoán huyết khối tĩnh mạch đã được đưa ra trong khuyến cáo của Hội Tim mạch Việt Nam năm 2022. Thì tất cả những bệnh nhân mà nghi ngờ về huyết khối tĩnh mạch sâu trên lâm sàng thì chúng ta cần phải đánh giá triệu chứng, yếu tố nguy cơ khá lâm sàng, và chúng ta đánh giá xác suất là mắc bệnh của người bệnh. Nếu mà có khả năng huyết khối tĩnh mạch sâu chi dưới thì chúng ta sẽ chỉ định siêu âm Doppler, và nếu mà siêu âm Doppler không thấy thì chúng ta có chỉ định làm siêu âm lần thứ 2 sau 1 tuần. Và nếu mà trên siêu âm Doppler mà đã thấy rồi huyết khối rồi thì chúng ta phải tìm xem đấy là bệnh nhân có yếu tố khởi phát hay là không có yếu tố khởi phát. Với các bệnh nhân mà không có yếu tố khởi phát thì bắt buộc chúng ta phải tầm soát ung thư, và đây là khuyến cáo cấp độ 1A. Và đây là cái thang điểm Well cải tiến đánh giá xác suất lâm sàng bị huyết khối tĩnh mạch sâu chi dưới đã được đưa vào khuyến cáo năm 22 của Hội Tim mạch Việt Nam. Về các cái ngoài ra thì chúng ta có thể làm thêm các cái định lượng D-dimer, là một cái phương pháp mà có độ nhạy khá là cao và được khuyến cáo ở những bệnh nhân ít có khả năng lâm sàng bị huyết khối tĩnh mạch sâu. Đây là một cái biện pháp để chúng ta loại trừ các bệnh nhân bị thuyên tắc huyết khối và khuyến cáo cấp độ 1B. Ngoài ra, siêu âm duplex với đầu dò đè nén dọc đường đi của tĩnh mạch là một cái thăm dò hết sức có giá trị để chúng ta có thể xác định được thuyên tắc huyết khối ở các bệnh nhân, và khuyến cáo cấp độ 1B. Và nếu bệnh nhân có khả năng lâm sàng bị khối tĩnh mạch sâu nhưng kết quả siêu âm âm tính thì cần phải xem xét siêu âm lại sau 1 tuần. Đôi khi chúng ta cũng có thể chỉ định chụp tĩnh mạch cản quang, nhưng bây giờ tại các trung tâm của Việt Nam thì cái việc chụp cản quang tĩnh mạch này gần như là không thực hiện. Và nếu bệnh nhân nghi ngờ bị huyết khối tĩnh mạch sâu vùng bắp chân thì nên dùng siêu âm toàn bộ chi dưới, và không khuyến cáo tầm soát thuyên tắc phổi thường quy ở những bệnh nhân huyết khối tĩnh mạch sâu mà không có dấu hiệu hoặc là triệu chứng gợi ý thuyên tắc phổi. Ở bệnh nhân bị huyết khối tĩnh mạch sâu chi dưới đoạn gần không rõ yếu tố thúc đẩy thì khuyến cáo khám lâm sàng và tầm soát ung thư, và đây là khuyến cáo cấp độ 1A. Và đây là chiến lược chẩn đoán về thuyên tắc mạch phổi ở các bệnh nhân. Thì chúng ta cũng chia ra làm 2 phác đồ. Là thứ nhất là ở các bệnh nhân có rối loạn huyết động. Thì khi bệnh nhân mà nghi ngờ về thuyên tắc phổi ở bệnh nhân có rối loạn huyết động thì cần phải làm siêu âm tại giường ngay và đánh giá về chức năng thất phải. Nếu mà không có rối loạn chức năng thất phải, chúng ta có thể tìm các nguyên nhân khác gây nên rối loạn huyết động. Còn nếu có rối loạn chức năng thất phải thì khi đó chúng ta chỉ định các biện pháp chẩn đoán hình ảnh như là chụp cắt lớp, và nếu mà chụp cắt lớp và dương tính thì chúng ta chỉ định điều trị thuyên tắc phổi nguy cơ cao. Và nếu mà chỉ định chụp cắt lớp âm tính thì chúng ta tìm các nguyên nhân khác gây sốc hoặc là rối loạn huyết động ở các bệnh nhân này. Ở các bệnh nhân có huyết động ổn định thì chúng ta đánh giá khả năng thuyên tắc phổi dựa trên lâm sàng và các phương tiện dự đoán. Chúng ta có thể đánh giá bằng Well và bằng Geneva, và chúng ta đánh giá cái nguy cơ, và chúng ta có thể làm thêm D-dimer để đưa ra các cái chỉ định tiếp theo. Nếu D-dimer dương tính, chúng ta sẽ chẩn đoán bằng tiếp theo là cắt lớp động mạch phổi, và chúng ta sẽ xác định, nếu xác định được có thuyên tắc huyết khối thì chúng ta đưa vào điều trị. Còn bệnh nhân nguy cơ cao hoặc có khả năng thuyên tắc phổi thì chúng ta cho chỉ định chụp cắt lớp luôn, và nếu có thuyên tắc phổi thì chúng ta đưa vào điều trị, và nếu không có thuyên tắc thì chúng ta cần làm thêm các cái thăm dò khác để xác định nguyên nhân. Trong phân tầng nguy cơ thì chúng ta luôn luôn đánh giá mức độ nặng của bệnh nhân bằng thang điểm Pepsi và S-Pepsi. Và bên cạnh đó thì chúng ta phải đánh giá nguy cơ tử vong nội viện trong vòng 30 ngày với các bệnh nhân này. Thì chúng ta có 3 cấp độ đánh giá là cấp độ cao, cấp độ trung bình và cấp độ thấp. Cấp độ cao nếu tất cả có các cái dấu hiệu như rối loạn huyết động và Pepsi trên 1 và rối loạn chức năng thất phải đều có xuất hiện và có hiện tượng là tăng troponin. Còn nếu chỉ có 2 trong 3 các biểu hiện thì chúng ta đấy là các đối tượng nguy cơ trung bình, và nếu không có các cái biểu hiện rối loạn huyết động, Pepsi bằng không thì như đấy là các đối tượng mà có nguy cơ thấp, và chúng ta phải đánh giá thêm các cái chẩn đoán hình ảnh khác. Để kết luận cho phần trình bày trên thì chúng ta thấy rằng là huyết khối trong ung thư rất thường gặp là nguyên nhân làm tăng tỷ lệ tử vong ở bệnh nhân ung thư, và huyết khối nhiều nhất ở 3 đến 6 tháng đầu sau khi phát hiện ra ung thư. Bệnh nhân có nguy cơ cao là những bệnh nhân đã có di căn, điều trị hóa chất và phẫu thuật ung thư, và nên sử dụng thang điểm đánh giá nguy cơ để sàng lọc nguy cơ thuyên tắc huyết khối ở mỗi bệnh nhân ung thư, và cần tìm huyết khối ở bệnh nhân ung thư khi thấy bệnh nhân than phiền vì những triệu chứng không đặc hiệu, và sớm chẩn đoán ra thuyên tắc huyết khối ở bệnh nhân ung thư sẽ điều trị hiệu quả hơn và giảm biến cố đáng tiếc. Xin cảm ơn sự chú ý của các đồng nghiệp.
Okay, thank you very much, Professor Thu Hương, for a very comprehensive and informative talk. So now we fly over the Pacific Ocean to Chicago. I hope that Professor Axter is there. Good evening, Professor Axter. For the topic, roles of cardiovascular biomarkers in stratification of severe risk in oncology patients. So, Professor Axter. Can you hear us, Professor Axter?
I can hear you. I think I provided my video earlier, and I'd like to show that.
Play the video and then the Q&A will come later. Thank you.
Hello. Thank you very much to the organizers for the opportunity to speak today on the roles of cardiovascular biomarkers for stratification of cardiovascular risk in oncology patients. These are my disclosures. So what is a biomarker? A biomarker is any characteristic that can be measured objectively and evaluated as an indicator of normal biologic process, pathogenic process, or a pharmacologic response to an intervention. So biomarkers are proposed as a method for improving risk prediction and identifying subclinical disease in patients at high risk for cardiotoxicity from cancer therapy. The definition here is intentionally broad and not limited to circulating biomarkers, but those are the ones that have been primarily studied due to rapid and low-cost measurements. Biomarkers are most useful when accurate, easy to measure, and provide useful information. Biomarker studies in cardio-oncology have been limited due to small sample size, no standardization of time points, heterogeneous assays, which differ in positive and normal thresholds. The accepted cutoffs and reference values have not been established for patients with cancer on anti-cancer therapies, and many of the non-cardiotoxic causes for biomarker elevations are seen in the oncology population, such as sepsis and renal dysfunction. Most of our data is with troponin and BNP, and most of the studies have been done on anthracycline and trastuzumab. The primary outcome studied is a change in LV ejection fraction. Cancer therapy-related cardiac dysfunction will be used throughout today's talk, which is a decrease in ejection fraction by greater than 10% to a value at least less than 53%. We recently received some guidance from the European Society of Cardiology Cardio-Oncology Guideline Statement on the use of baseline biomarkers. And this guideline statement advocates for measuring baseline biomarkers such as troponins and BNP in all patients with cancer risk of CT-RCD, especially if these biomarkers will be remeasured while on treatment. The release of biomarkers differ based on different cancer treatments and different clinical situations. And this talk, we will focus on 3 specific cancer treatments: anthracyclines, trastuzumab, and immune checkpoint inhibitors. As you're aware in this audience, anthracyclines can have acute, subacute, and chronic phases of toxicity, which really represent a continuous spectrum of pathophysiology going from the acute reversible to the chronic irreversible, with increasing doses and coexisting cardiac risk factors that determine the rate of progression to cardiac dysfunction. So there are several recognized risk factors, including cumulative dose, method of administration, baseline low EF, older age, pre-existing cardiovascular disease, prior or concomitant mediastinal radiation, and concomitant cardiotoxic chemotherapy such as trastuzumab. Let's quickly review the cardiac troponin complex. So cardiac troponin is the component of the sarcomere, which is the contractile unit of the heart, and it has isoforms C, I, and T. When calcium binds to troponin C, it moves troponin T, thereby exposing the myosin binding sites and allows myosin to bind and lead to contraction. Highly sensitive troponin assays, by definition, must provide measurable concentrations above a limit of detection of greater than or equal to 50% of healthy individuals. Dr. Cardinale and colleagues have done a lot of seminal work in biomarkers. This is one of the earliest studies that was done looking at troponin I almost 20 years ago. They evaluated 204 patients who received high-dose chemotherapy and checked biomarkers 72 hours prior to every chemotherapy cycle. Those patients with a troponin I positive were more likely to have a decrease in LVEF from 1 to 3 months, and which then persisted at 7 to 12 months. Troponin I positivity was more likely to have a decrease in LVEF less than 50% and also to result in heart failure. Of note, this study really has not been able to be replicated due to the higher positive threshold for troponin and the very high doses of chemotherapy that were used. And the frequency and sampling of troponin also is impractical and costly. In a subsequent study, the same group looked at using more of a contemporary assay, which used a threshold of greater than or equal to 0.08 nanograms per milliliter. In 703 patients who received high-dose chemotherapy, troponin was checked before and then early after treatment, which was within about a month after, and these patients were followed for 3 years. They divided patients into 3 groups: those that had troponin that remained negative, those that had a positive troponin that then became negative, and those that had positive troponin that remained positive. What they found was that patients who had a negative troponin at the start and end of treatment, those patients had a very low incidence of cardiac events, about 1% during the 3-year follow-up. However, those patients that had elevated troponins at the beginning and then at the end, these patients were more likely to develop a decrease in LVEF and adverse cardiac events such as heart failure, arrhythmias, and cardiac mortality. Also, importantly, the rise and fall pattern, as opposed to a persistently elevated pattern, may be able to differentiate acute versus chronic myocardial injury, which is also may be useful in the care of cancer patients. Few studies have been done with troponin T with mixed results, and there's also limited data with highly sensitive troponin. In the PRADA study, sub-study that evaluated troponin I and troponin T in patients who received epirubicin with cumulative dose greater than or less than 400 milligrams per meter squared, they found no association between elevated highly sensitive troponin or cardiac troponin T and a change in ejection fraction. Both NP and NT-proBNP have been used for the diagnosis and prediction of heart failure. They are mainly triggered by wall stress from congestion, and the use of NPs for identifying those at risk for anthracycline-induced cardiovascular dysfunction is less clear, but there may be some value in high-risk patients. In this study of 109 patients who received point-of-care biomarkers before and 24 hours post-anthracycline chemotherapy, they found about a 10% cardiac event rate. All patients had elevated BNP, and those patients, and you see the box plots showed both in A, pre and B, post BNP levels, that patients with cardiovascular events, who are the shaded box plots, had elevations in their BNP. So the major consensus recommendations generally support the use of troponin or natriuretic peptides in identifying patients at increased risk for cardiac toxicity from anthracyclines. There are several novel biomarkers that are being evaluated, such as ADMA and MMA, which play a role in endothelial dysfunction and doxorubicin toxicity, as well as looking at microRNA levels. So the ESC guidelines on biomarkers with anthracyclines show here that there's a class 1 indication for obtaining biomarkers in the high and very high risk patients at baseline, and then with every cycle of cancer treatment, 3 months and then 12 months post. And those with low moderate risk, so those are patients who've received greater than or equal to 250 milligrams per meter squared. These patients, there's a class 2A or 2B indication to check biomarkers at every other cycle and then 3 months post. Changing gears to trastuzumab. So the FDA approved trastuzumab in November of 2006, and this was a really a milestone moment in cancer treatment. It targets the HERB-B2 oncogene. It's overexpressed in about 15 to 30 human breast cancers, and it is associated with increased tumor aggressiveness, early disease progression, and high risk for relapse and death. About 10% of patients will develop trastuzumab cardiotoxicity without prior anthracycline exposure, and those who receive sequential treatment with anthracycline, the incidence is about 25% at 12 months. Clinical heart failure is less common, and what we see is largely reversible. There are many new anti-HER2 therapies on the market now. Generally, they have lower incidence of LV dysfunction and heart failure, and there's no increase in cardiotoxicity that is seen with dual versus monotherapy. Also, there's a new study that is showing that metastatic low expression HER2 patients may benefit from anti-HER2 therapies, so we'll be seeing more of this in the future. Risk factors for trastuzumab toxicity include a low baseline or post-anthracycline ejection fraction, structural heart disease, cardiovascular risk factors or comorbidities, concomitant, and sequential use of anthracyclines. In a study of 251 women receiving trastuzumab for early stage HER2-positive breast cancer, 19% of these patients who had an elevated baseline ultrasensitive troponin I developed cardiac dysfunction during trastuzumab therapy. And the cutoff here was 0.8 nanograms per liter. Baseline high troponin I was also found to be a predictor of a lack of response, a lack of recovery despite optimal heart failure therapy. This was again examined in the largest study looking at trastuzumab, troponin in trastuzumab patients in a sub-analysis of the Herceptin adjuvant trial, or the HERA trial. In this study, 533 patients with HER2-positive breast cancer received trastuzumab and had serial measurements of troponin I, highly sensitive troponin I, and highly sensitive troponin T. And they found that the increased baseline pre-treatment highly sensitive troponin I and T were associated with a 4-fold increased risk of cancer therapy-related cardiac dysfunction. Other studies have looked at multiple biomarkers and newer biomarkers because it is hard to tease out the role of biomarkers with trastuzumab alone, because a lot of these studies have enrolled patients who've received serial therapy with anthracycline followed by trastuzumab. This study looked at several new biomarkers. It was done by Dr. Bonnie Key and colleagues. They looked at GDF15, which is a growth differentiating factor, MPO, which is myeloperoxidase, PIGF, placental growth factor, SLFT1, soluble like tyrosine kinase receptor, and galactin-3. What they found when looking at all of these biomarkers, that there was a greatest risk for toxicity when there was an interval change in cardiac troponin I and MPO. And what they were able to show that is that MPO specifically is being studied to identify cardiotoxicity risks because of its role in the innate immune response generating reactive oxidative species, which is thought to be a mechanism for the development of toxicity with anthracyclines. So when both ultrasensitive troponin I and MPO are used together, they can provide some additive information. And this probability for toxicity at 15 months when both biomarkers are elevated, it was about 50%. Independent validation is still necessary for this study. In this next study on the graph, you'll see that the trastuzumab line is green, doxorubicin is red, and doxorubicin plus trastuzumab is blue. So this was a prospective study of 323 breast cancer patients who were treated with anthracycline and or trastuzumab and were followed for 3 years. And what they found was that highly sensitive troponin greater than 14 milligrams per liter at anthracycline completion was associated with a twofold increased risk of CTR-CD. Changes in NT-proBNP predicted the risk for CTR-CD, particularly in patients that were treated with sequential anthracycline followed by trastuzumab. To summarize, for trastuzumab and biomarkers, baseline cardiac troponin data on trastuzumab may predict a CTR-CD and LV recovery. Overall data are generally less robust for the use of biomarkers when monitoring for trastuzumab-related toxicity. Studies have been done usually with serial administration with anthracyclines. Newer anti-HER2 therapies and non-anthracycline-based regimens have less cardiotoxicity, and the utility of biomarkers with these newer regimens does require more study. So in terms of the ESC guidelines on biomarkers with anti-HER2 therapy, there's only one class 1 indication, and that is for checking pretreatment biomarkers in high and very high risk patients being treated with trastuzumab. Finally, just to touch on immune checkpoint inhibitors as well, this is a new cancer therapy that was approved in 2014. Myocarditis is kind of the most feared cardiac consequence. It can be fatal, but it is rare in less than 1% of patients. There are 3 immune pathways that are exploited by cancer cells, including CTLA-4, PD-1, and PD-L1. The median time of onset for ICI myocarditis is usually soon, so 34 days within a first dose of treatment, and usually presents within the first 3 months. Nearly all patients did have an elevation in troponin, 94%. They also had abnormal EKGs, and about 50% had normal ejection fractions. What the study found was that patients had about a 38% MACE rate despite a normal ejection fraction. So the final or discharge troponin T of greater than or equal to 1.5 nanograms per milliliter was associated with a 4-fold increased risk of MACE. There are some risk factors that are thought to cause ICI myocarditis, including pre-existing cardiovascular disease, pre-existing autoimmune disease, dual immunotherapy, and concurrent immune-related toxic effects, such as myositis. Now, myositis can occur in about 25% of patients. Cardiac troponin T has known cross-reactivity with skeletal muscle, and so cardiac troponin I may be more specific for myocardial injury in these patients. Some other institutions have shown their experience. So Memorial Sloan Kettering experience with 76 asymptomatic patients with advanced melanoma on combination ICI therapy. Screening with troponin I and EKG found only 17% of patients with elevated troponin I, and none of those patients developed myocarditis. In another study, of 59 patients with non-small cell lung cancer that were treated with nivolumab, only 1 patient with sustained ICI elevation had subclinical myocarditis. Highly sensitive troponin there still needs to be much more research in this space in ICI myocarditis. And this research letter that was published in JACC Cardio Oncology looked at 214 patients who were receiving monotherapy or combination ICI therapy, and they found that a positive predictive value of 12.5% for troponin I threshold of greater than 55. In terms of the ESE guidelines for biomarkers in ICI, there's a class 1 indication for baseline cardiotroponin and BNP in low and high risk patients, so anybody starting ICI therapy, and a class 2A indication to start to check it with every cycle in the first few cycles of treatment, as there are higher rates of ICI within the first month of treatment. So baseline screening with troponin to detect ICI myocarditis. And then for high-risk patients, check troponin with, again, weekly for the first 4 to 6 weeks. This may be helpful due to the time frame that we are seeing the increased incidence of ICI myocarditis. And more data is needed for highly sensitive troponins. This is a nice figure in JACC Cardio-Oncology, which breaks down the biomarkers into sort of 4 biomarker profiles, and the management and the differential consideration. So I urge you to look at that. In summary, pre-treatment, NPs and cardiac troponin should be checked at baseline and in patients at risk for CTRCD who will have biomarkers repeated while on cancer treatment to assess for CTRCD. Elevated pre-chemotherapy biomarkers can help risk stratify patients for CTRCD and those treated with anthracycline-based and anti-HER2 regimens. During treatment, elevation of biomarkers, again, troponin and NPs during anthracycline and anti-HER2 regimens can help risk stratify patients for CTRCD, and elevated troponin during ICI therapy may have some potential utility in identifying patients at risk for ICI myocarditis. Post-treatment, a rise and fall pattern versus persistently elevated biomarkers post-anthracycline-based chemotherapy and possibly with immunotherapy can help risk stratify patients for CTRCD. Thank you very much.
Hello. 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 Thank you so much, Professor After from USA, for your perfect presentation. And now we have a little, some minutes for discussing. Any question?
Tôi có một câu hỏi là có rất nhiều cái dấu ấn ung thư đã được đưa ra trong cái để sàng lọc cái bệnh các cái dấu hiệu về viêm cơ tim và suy tim ở bệnh nhân ung thư điều trị hóa chất, thì theo bà thì và bên bệnh viện bà thì nên sử dụng cái marker nào nhất?
To congratulate the Congress for putting forward such a fantastic session. I think that this is really important to have included these great talks today within cardio-oncology. It's a very hot and up-and-coming area. And I think there definitely needs to be a lot more research in the biomarker space. I think, a lot of what we have is very mixed. And so a focus on 5 things, really increasing the sample size of the trials and the studies that we have. Also, the ESE has helped us with unifying some endpoints and definitions and giving more universal definitions. We also have to be more clear about our methodology. I think in the papers, it's not very well described usually, the methodology for biomarker work, and also look at where we have some intersection within cardio-oncology and heart failure, and to see where there is shared prognostic biomarkers between these spaces. And finally, we really do have to work with our oncology colleagues in the design of clinical trials up front, and give our input from the cardiology side of things, so that we can get this data prospectively. Thank you.
Thank you so much for your answer. Có một cái câu hỏi ở dưới đại biểu là em hiệu chỉnh dimer trên bệnh nhân ung thư như thế nào? Vì theo bạn này là vì trên bệnh nhân ung thư, đặc biệt là ung thư giai đoạn cuối, thì nồng độ dimer cao hơn so với người bình thường, dù không ghi nhận bằng chứng huyết khối.
I was hoping that you could provide the translation for that question.
Vâng, vì thời gian của phiên này chúng ta đã hết rồi, do đó mà chúng ta phải chốt lại để cho phiên tiếp theo có thể được bắt đầu. Không biết đường truyền như thế nào và bên kia cô ấy không nghe được. Và như vậy là trong cái phần sáng ngày hôm nay rất là bắt đầu rất là sớm, chúng ta đã qua 4 cái bài báo cáo của 3 giáo sư Mỹ và tôi về thứ nhất là các cái rà soát về đánh giá về chức năng tim ở các bệnh nhân ung thư điều trị hóa chất, thì người ta nhấn mạnh được cái vai trò của sức căng dọc trên siêu âm tim. Đấy là một cái dấu hiệu có giá trị để đánh giá về thay đổi chức năng tim ở những bệnh nhân điều trị hóa chất. Với báo cáo thứ hai thì chúng ta thấy là các cái thăm dò chẩn đoán hình ảnh được chỉ định để đánh giá các cái bệnh lý mạch vành ở bệnh nhân ung thư, nó gần tương tự như là các cái bệnh nhân mà bình thường mà chúng ta nghi ngờ là mắc mạch vành, thì bao gồm có các cái triệu chứng lâm sàng, sau đó là siêu âm tim gắng sức và các cái chụp ống từ và chụp cắt lớp động mạch vành và chụp động mạch vành qua da, và các cái điểm đánh giá điểm vôi hóa ở các bệnh nhân có nguy cơ cao là cái điểm cũng rất là cần thiết. Và với cái phần trình bày về các cái biomarker và để đánh giá cái phân tầng nguy cơ ở các bệnh nhân ung thư ở trên các đối tượng bệnh nhân tim mạch, thì người ta nhấn mạnh người ta thấy rằng là có rất nhiều các cái yếu tố nguy cơ, có rất nhiều các cái yếu tố biomarker chúng ta có thể đánh giá khác nhau, như là troponin, HS, và có 5 các cái dấu hiệu mới là GDF 15, MPO, GIP, PEGF, GAN 3. Đấy là các cái dấu hiệu, và người ta thấy rằng là HS troponin T mà tăng gấp trên 14 lần, lớn hơn 14, thì như thế tăng nguy cơ tim mạch gấp 2 lần. ở các bệnh nhân ung thư. Thì đấy là các cái phần cơ bản mà chúng ta đã trải qua buổi sáng ngày hôm nay. Xin cảm ơn các báo cáo viên và cảm ơn sự lắng nghe của các quý vị đồng nghiệp.
It's a brand new day. It's a brand new day. It's
Good morning, everyone. Good morning, everybody. I'm very pleased now we have a meeting with the honored speaker from the United States. Now, our chairman now is, I am next to me, Professor James Kirkpatrick. Professor Kirkpatrick is a great friend of Vietnam. He helped us so much in echocardiography. He is past president ancien of us. You before you are president of echocardiography. Oh no. No more. No. Okay. No. Not okay. Now he is in University of Washington Medical Center, Seattle. Next to me is Dr. Chien from 108 Hospital, and Dr. Quỳnh Nga. I know her so many years. She's from Hanoi Health Center, and I am now from Tubman Hospital. Now we are very pleased to have meeting today. So I would like to invite Professor Kirkpatrick to introduce the first speaker.
Thank you so much, Dr. Vin. It is such a pleasure to join everyone in the room and online and watching later. I want to acknowledge and celebrate with you 30 years of VMHA and 18 years of this National Congress. Congratulations to everyone. It is definitely an honor to be here to celebrate with you. Our first speaker today is Professor Noshin Akhtar from Northwestern University in Chicago in the United States, and she is an expert in many different things, but in particular she has much experience in the use of echocardiographic myocardial strain, and we are so honored to have her join us today to talk on that topic.
Thank you very much to the conference organizers for the opportunity to speak on one of my favorite topics, which is strain imaging. My topic is risk stratification with echocardiographic myocardial strain, and I have no relevant disclosures for this talk. In order to understand strain, we must start with an overview of the cardiac architecture. Myocardial fiber orientation is quite intricate and orderly. So from the endocardium, we have longitudinally arranged fibers, and in the mid-myocardium, we have circumferentially arranged fibers. Then the fibers are arranged in two opposite helixes. From the subendocardium, there's a right-handed helix to the subepicardium, which is laid out in a left-handed helix. This helps promote contraction, which starts at the pulmonic valve. The base moves down to the apex in a descending loop in a clockwise direction, and the apex then moves up to the base in an ascending loop in a counterclockwise direction. There are several limitations to ejection fractions. Subtle changes in ejection fraction may not be detected due to image quality, precise endocardial border definition, and an inability to visualize the true apex, various loading conditions, and measurement variability. The American Society of Echo first came up with this concept of subclinical LV dysfunction kind of through their cancer treatment expert consensus statement, in which those patients that did not qualify for a change in ejection fraction that met cancer therapy related cardiac dysfunction fell into these smaller ranges of ejection fraction changes, in which strain was useful to detect these smaller changes in cardiac mechanics. The idea of using strain for our definition of cancer therapy-related cardiac dysfunction is just entering the International Cardio-Oncology Society consensus statement and the European Society of Cardiology Cardio-Oncology Guideline Statement, in which we have now a more nuanced definition of CTR-CD, which includes asymptomatic and symptomatic CTR-CD, which is then subcategorized into mild, moderate, and severe based on ejection fraction, relative changes in global longitudinal strain, and or cardiac biomarkers. So what is strain? This audience knows strain is a measure of myocardial mechanics. It is sensitive, robust, and reproducible. A change in length of the myocardium during relaxation and contraction. So a change in length over the original length is how we define strain. There are three primary vectors. longitudinal, circumferential, radial. You can see examples of circumferential and global longitudinal strain here. Global longitudinal strain is the most clinically robust. Normal ranges between -20 plus -2%. There are several factors that affect strain. This is also very critically important in the oncology patient population. So hypovolemia can reduce strain, neoworsening hypertension can reduce strain, changes in LV geometry or increase in LV dilation can reduce strain, which is often seen with anthracyclines. We also published a review on the diagnostic and prognostic value of strain in JAMA Cardiology a few years ago. I encourage you to look at it. These are some examples from that review. So we have over here examples of different polar bullseye, polar maps or bullseye plots looking at different cardiovascular conditions. So these are all ischemia. These are all examples of Takotsubo, both the classical variant and the apical variant. And then examples of where strain can be useful and important in the evaluation of left ventricular hypertrophy to detect amyloidosis, which you see here, the nice cherry on top pattern, and for hypertrophic cardiomyopathy, the septal variant and an apical hypertrophic variant with a reduction in strain in the apex. For the remainder of this talk, we will really be focusing on risk assessment with strain in the cardio-oncology population, because that is really where strain risk assessment began. So let's start with a case. A 72-year-old physician with AML presents to you. There's a normal baseline ejection fraction, exercises regularly, no cardiac symptoms, is planned to obtain induction chemotherapy with daunorubicin 7+3, and has risk factors including age, hypertension, hyperlipidemia. Baseline global longitudinal strain is reduced despite a normal ejection fraction to -15%. This was a very nice editorial that was published in JACC Cardio-Oncology by Dr. Lopez-Mate, discussing this concept of identifying the vulnerable patient. And this editorial was published looking at the idea of baseline global longitudinal strain to identify the vulnerable patient prior to receiving any type of cancer treatment that may be cardiotoxic. And those patients that had a reduced global longitudinal strain at baseline, this may be due to comorbidities or reduction in contractile reserve, so that we may start to think about this entity as patients that are the equivalent of ACC-AHA class B heart failure. In terms of cardio-oncology, the prognostic value of baseline global longitudinal strain has been demonstrated in hematologic malignancies, and this is a very important study done by Dr. Shura Crosby and colleagues looking at 450 patients with leukemia and lymphoma that were treated with anthracyclines and followed for 4 to 5 years. They had a 6% cardiac event rate, and their risk factors were primarily driven by hypertension and diabetes. They showed that a pre-chemotherapy global longitudinal strain of less than -17.5% was associated with a 6-fold increased risk of cardiac events. They then went on to use this in developing a 21-point risk score in 450 patients with acute leukemia treated with anthracyclines. In their risk score, they assigned a baseline global longitudinal strain of greater than -15%, 6 points, which is the most points in their risk calculator, to help determine the incidence of heart failure. Now, this risk calculator still needs prospective external validation. However, we have done external validation of the risk score in acute myeloid leukemia patients. 200 patients experienced about a 20% hospitalization for heart failure. And we did find a significant association between heart failure and risk group categories when employing the risk score. This is a very nice meta-analysis published in JAMA Cardiology, looking at the concept of both an absolute on-treatment global longitudinal strain and a relative change in global longitudinal strain from baseline. So both of these entities had good prognostic performance for detecting CTR-CD, which is important in practical clinical application, because when we read an echo, sometimes we don't compare it back to that pre-chemotherapy echo, but rather just the echo before. So global longitudinal strain discriminatory accuracy appeared to be consistent across cancer subtypes that received anthracyclines plus minus trastuzumab. The authors did caution that limited data was available on the optimal cutoff for the values, that larger prospective studies were needed, and that there may be some concern for publication bias. Coming back to our patient with AML, post-induction, the ejection fraction is in a low normal range. The patient had colon abscesses which required an exploratory laparotomy and a need for sigmoid colectomy and colostomy, GDMT was not initiated at that time. The post-induction GLS was even lower, now at negative 11.5%. 5 months later, this patient wakes up with shortness of breath and is admitted to an outside hospital with new onset heart failure with ejection fraction that's reduced to 30%. Evidence of congestion. He's optimized with diuretics, GDMT, and in a left heart cath demonstrates non-obstructive coronary artery disease. A cardiac MRI is obtained, which is consistent with the low ejection fraction at negative 22%, as well as a low RV systolic function. There's no evidence of edema or scar, but there is some evidence of non-specific findings for remote myocarditis. This patient is optimized on GDMT and is now 3 years into survivorship with an ejection fraction of approximately 50% without any heart failure symptoms. There are several papers that were published between 2011 and 2013 that looked at the prognostic utility of global longitudinal strain in CTR-CD. Now, it's important to note that these papers were all done in patients with HER2-positive breast cancer who were receiving serial anthracycline followed by trastuzumab treatment. Dr. Schreier-Crosby again and her colleagues have found that monitoring global longitudinal strain can identify patients at risk for cardiotoxicity. So changes in strain can predate changes in ejection fraction. And that global longitudinal strain is an early predictor of cardiac toxicity. It has a very high negative predictive value when normal. There's also patterns with myocardial mechanics. So in this study looking at 135 patients with breast cancer, it demonstrated changes in longitudinal strain preceded changes in circumferential strain. So these are maybe factors to consider when in the duration of continuing heart failure treatment. Just this past year in JAMA Cardiology, there was another study looking at the additional use of circumferential strain on top of global longitudinal strain in patients treated with trastuzumab to detect trastuzumab cardiotoxicity, and that increased the sensitivity for detection. Coming back to a new patient, we have a 48-year-old female. She has a history of left-sided breast cancer, which is ER positive, PR negative, and HER2 negative. This was diagnosed in 2009. She has some cardiovascular risk factors. The cancer is treated with a bilateral mastectomy followed by adjuvant ACT, which includes adriamycin, total dose of 240 milligrams per meter squared, cyclophosphamide, and Taxol, bilateral implant reconstructions, and is started on adjuvant tamoxifen. Unfortunately, about a decade later, she's found to have a new primary at the lateral aspect of her left breast reconstruction, which is now HER2 positive. She is treated with a wide excision, including skeletal muscle, and has negative margins. She started on adjuvant TCHP, given 6 cycles. This includes a regimen of docetaxel, carboplatin, and trastuzumab, and pertuzumab, which are both anti-HER2 agents. This is her baseline echocardiogram, which is normal ejection fraction 70% and GLS of negative 20%. Now, the FDA recommends echo surveillance at every 3 months with patients who are on anti-HER2 treatments. In this patient's 3-month echo, you can see that her ejection fraction is still normal, but the GLS has declined to negative 16.3%. So she meets the threshold for subclinical LV dysfunction, or according to newer definitions, mild asymptomatic CTR-CD. At her 5-month echo, ejection fraction is now 47%, and the GLS is further reduced to negative 14.7%. She endorses shortness of breath and chest tightness, therefore chemotherapy is held. And she started on some carvedilol, which is limited by hypotension. A stress test is done to evaluate for ischemia due to her history of left-sided radiation, which was approximately a decade prior, which demonstrated no ischemia, and her ejection fraction after improving to 50 to 55%, it was determined that she was safe to be re-challenged with anti-HER2 therapies. This time she was started on a new regimen called trastuzumab or TDM1. This is her echo on the re-challenge, and her ejection fraction is maintained at 54% with a GLS of negative 15.9%. So to really quickly touch on some novel applications for strain and risk prediction, global longitudinal strain is being looked at for patients with immune checkpoint inhibitors. Now recall, about 50% of patients with immune checkpoint inhibitor myocarditis present with normal ejection fraction. And so strain can be potentially useful in these patients. In this study, looking at 101 patients with confirmed ICI myocarditis compared to 92 controls, they found that all patients had similar GLS prior to starting ICI treatment, and that GLS was decreased in patients with myocarditis, and it was lower amongst all patients with myocarditis despite ejection fraction. The controls had no change in GLS. We've also at our institution looked at left atrial strain in predicting atrial fibrillation on a drug called ibrutinib, which is a Bruton tyrosine kinase inhibitor associated with about a 10 to 15% increased risk for atrial fibrillation. Our patient population was older and had comorbidities such as diabetes, coronary artery disease, and heart failure. And also on the baseline echo, there was an increase in E over E prime in those patients who went on to develop atrial fibrillation. After a multivariable analysis was done, we demonstrated that impaired PAX, or peak atrial contractile strain, or also known as booster strain, identified patients with poor atrial contractile function, which predisposed them to developing ibrutinib-associated atrial fibrillation, and this was independent of age. RV strain has also been evaluated in patients with diffuse large B-cell lymphoma who've received R-CHOP, which is not anthracycline-based treatment. Typically, the cumulative dose is 300 milligrams per meter squared. In this study of 74 patients, echoes were obtained at baseline after cycles 2, 4, and 6. And what we see is that at the T2 time point, that there were changes in RV size and worsening RV free wall strain. However, there was no changes on RV EF until the very end. So this looks like it's similar to what we're seeing on the left side in terms of strain predating changes in ejection fraction. In summary, it's important to contextualize strain, GLS, in the interpretation based on cardiac condition. For cancer therapy, it is important to know the time point in the echo during treatment and the treatment history or regimen. Strain patterns on the polar map are also an important diagnostic tool, but haven't really been looked at in terms of risk prediction. Pre-treatment GLS, however, can identify patients at risk for cardiac toxicity, especially in patients with leukemia and lymphoma. Absolute on-treatment GLS and relative change in GLS from baseline can be used for prediction of prognostication of anti-cancer treatment, especially cancer subtypes with anthracyclines and trastuzumab. We need more recent research on post-treatment GLS for risk prediction, and there are lots of opportunities for future research in developing risk scores, which incorporate strain, investigating GLS cutoffs for many different types of cardiac conditions, and the utility of LA and RV strain. Thank you very much.
After for a very interesting presentation. Now we move the next speaker, Professor James Kirkpatrick, for a talk to lab atrial assessment with echocardiography, novelties, and clinical importance. Professor Kirkpatrick.
Thank you so much for the opportunity to talk about the left atrium. I don't have any relevant disclosures. I received some salary support from participation in NIH studies, but my disclosure today is that I'm from Seattle. You may or may not know that we are famous for coffee and for building airplanes and for software and even for online shopping. And our iconic building is the Space Needle. You may or may not know that it is not the tallest building in Seattle. It's not even close to the tallest building in Seattle, but in every picture you see of the city, it looks like it is, but it's not. The buildings behind it are taller. And you also may think that it rains a lot in Seattle. It actually rains more in Miami, but it rains all the time in Miami at once, but in Seattle it's just dripping every day for 9 months. This is a picture of Seattle, and you will see that it is surrounded by water, much like Vietnam, except that we have a large lake in the center there called Lake Washington. On the other side, on the left, is Puget Sound, and right in the middle between the two is a lake called Lake Union. you will see that there is a channel between Puget Sound that runs all the way to Lake Washington, and it stops essentially in Lake Union. And then we can see there are many different and very beautiful pictures in Seattle. Now, this will become important later as we think about the left atrium. We're also known for our public market. It's not the same as the night market. In fact, it closes down at night, unfortunately. So I think the Hanoi and Halong night markets are better in that respect. And we actually also have something that's rather interesting in Seattle, and that is fish throwing. So if you have never seen someone throw a fish, you will have to come to Seattle and view that, and hopefully not get caught and hit in the head as they're throwing it. So our outline today is going to discuss the left atrial anatomy and function and some of those functional measures, including 3D and strain, and I will give some thoughts about the future of left atrial imaging. So here is a picture of the left atrium we can see from the lateral aspect here. You can see where the pulmonary veins come in, you can see the foramen ovale, and you can see the mitral valve. And the mitral valve is a little bit like the locks in Seattle. So Lake Union is like the left atrium. And in order for boats to get from Lake Washington into Lake Union and out into Puget Sound, they have to go through these locks. These locks are there essentially to help separate the salt water from the fresh water, and then on the side of the locks is a way for salmon fish to be able to jump and get into Lake Washington and up into the rivers and streams. So it's a little bit like the mitral valve. If it's not working, you're going to get a backup of the boats. So this is a picture of Lake Union with too many sailboats in it, and that will sometimes happen. So we have to, if we think about Lake Union like the left atrium, we have to have proper dynamics. And it really is divided into three different phases. Dr. Akhtar talked about this a little bit. The reservoir phase is essentially measuring the ability to fill the left atrium from the pulmonary veins, and this happens while the mitral valve is closed. Then there is the conduit phase that happens after the mitral valve opens. Conduit refers to passive filling. The left atrium isn't really doing anything. It's not necessarily actively relaxing. It's certainly not contracting. It's just allowing blood to come from the pulmonary veins through it into the ventricle. And then there's the contractile phase. This, of course, happens when the atria contract in late systole. And here's the relative percentage of contribution of each of these phases to left atrial dynamics in the normal person. As we know, when people get older, the contractile phase can sometimes be more important because the left ventricle is stiff and we have to eject blood into it. The left atrial size is an important marker for left atrial dynamics and function. It has been called the hemoglobin A1C of diastolic dysfunction because it is a long-term marker of diastolic dysfunction, and I would add atrial myopathy and other problems with the left atrium. It's associated with mortality in heart failure with preserved ejection fraction and heart failure with reduced ejection fraction, and even in acute myocardial infarction. This doesn't make a huge amount of sense, but it actually is. It is also associated with reverse remodeling or beneficial changes in heart structure and function in cardiac resynchronization therapy. Left atrial dilatation above 60 milliliters per meter squared volume index, or using the old style method of measuring the left atrial diameter from the parasternal long axis view on echocardiography, has been implicated in the guidelines as one of the criteria for repairing the mitral valve. And in some studies, but not in all of them, left atrial size has an association with stroke. This is a way to measure the left atrial size using 3D echocardiography. You can see the multiplanar reconstructions in two different software packages here, which will give a left atrial volumetric measurement. So just as we used to think that the left atrial dimension was a very good way to measure atrial size, and then we realized it is not because it doesn't reflect the eccentric dilatation of the left atrium, we should also realize that two-dimensional, even two-dimensional biplane measurements are not as good as three-dimensional measurements. Now, this is not always easy to measure because you can't always see the border of the left atrial wall and the left atrial cavity. But nonetheless, these are better measurements and we should likely be using them. I expect that they will be involved in the guidelines in the future. But what about left atrial function? Well, this is an old way to think about it here, left atrial emptying fraction. It's not left atrial ejection fraction, it's emptying fraction. But it is essentially very similar. This measurement has been associated with heart failure hospitalizations and mortality, and also the development of atrial fibrillation and ischemic stroke. And interestingly, we are now learning that left atrial function is associated with dementia. This may, of course, be because people with impaired left atrial function developed blood clots, and then they go on to have micro strokes, which then give patients dementia. Perhaps a more involved, perhaps more accurate measurement here, which was actually proposed years ago in 2008, is the left atrial function index. It essentially takes that left atrial emptying fraction and then multiplies it by the ratio of the left ventricular outflow tract velocity time integral, which is a surrogate for left ventricular stroke volume, and then divides that by the left atrial systolic volume index. So this basically is a way to correct the left atrial function for left ventricular function and also left atrial size, excuse me. This marker is lower in patients with atrial fibrillation, not surprising, and interestingly, it also improves on cardioversion to sinus rhythm. But the more modern way of thinking about left atrial function, of course, as Dr. Akhtar mentioned in the previous talk, is the use of left atrial strain. I like this picture because it shows the established utility of measuring left atrial strain in atrial fibrillation, hypertension, heart failure, and aortic stenosis, but also the emerging utilities: coronary artery disease, obesity, ischemic stroke, hypertrophic cardiomyopathy, amyloidosis, Fabry's, chronic mitral regurgitation, even diabetes. It seems that the left atrial strain is good for everything. Now, we've been helped recently by looking at some normal values for left atrial strain. This is from the Copenhagen Heart Study on the left. They had nearly 5,000 patients that they screened, ended up with 1,641 in the population. These were, at least theoretically, healthy patients. And you can see over on the right side of the screen, right underneath the picture, the measurements that they got. So we have both the longitudinal strain, which corresponds essentially, this is the peak longitudinal strain, so it corresponds more or less to that reservoir strain, and then also circumferential strain, or excuse me, contractile strain, and also the conduit strain. And you can see here, just focusing on the top, that the median was 39, with the lower limit of normality at 23. And they were able also to show that pretty much all of these measures here were helpful in correlating with atrial fibrillation development. Now, there are some problems with our normal values. This is a study that took many patients in Korea and examined what the normal strain values were over time, or over age, I should say. And you can see in the age categories here, again, just focusing on the LA reservoir strain, that there is quite a difference if you are young or if you are older in the quote-unquote normal strain values, ranging all the way from the lower limit of normal in the 30s down to probably below 20. We saw a similar thing for the conduit strain, but interestingly, the contractile strain seemed to be relatively similar across the age groups, which is odd, of course, because we think of contractile strain as becoming more important in older patients. More work needs to be done in this area. But here from the guidelines, from a meta-analysis, is suggesting the different values that we might use for strain, at least with the mean, and then if you can look at the confidence intervals. And you can see that these didn't necessarily reflect those studies that we just saw with a very wide confidence interval for reservoir strain. And in fact, if we were to look at many different studies, we can see that the reservoir strain mean values and the confidence intervals were all over the map, as we like to say here. With, you could say that it lies somewhere around less than 40, but the reality is that studies showed that all over the place. And this is due to a number of factors, including the measurements that were actually used, the different vendors that were used to make the measurements, and of course there was heterogeneity among the different patient populations. But let's focus particularly on reservoir strain as a marker of stroke risk. Also, if you've had an atrial fibrillation ablation, if you have abnormal left atrial reservoir strain, you are more likely to have recurrence of atrial fibrillation. It is abnormal in diabetes and hypertension and improves with hypertension control. It's associated with increased pulmonary artery pressure and resistance and also reduced cardiac output and exercise workload. Associated with heart failure hospitalization and mortality, it is abnormal in hypertrophic cardiomyopathy and amyloidosis, and as we mentioned, for left atrial size, acute coronary syndrome, and mitral regurgitation. And again, much like left atrial size, it's associated with development of dementia. It seems that left atrial reservoir strain may be universally applicable, or just about. Now here's an algorithm, actually, I found this very interesting, for combining left atrial reservoir strain into our other assessments of diastolic dysfunction. So we have here our traditional diastolic parameters up in the top in the blue, and then we move to our left atrial strain, our functional assessment of the left atrium, using this cutoff of 24% on the reservoir strain. And this study was able to suggest that normal diastolic function was, particularly normal left atrial function, was correlated with normal diastolic function, but then, and then that was also true for the levels of diastolic dysfunction, but when you took this intermediate diastolic dysfunction by our traditional parameters, we actually were able, when applying left atrial strain, to reduce these intermediate cases by 75%. That's a huge number. And the prognosis then was also similar to normal function. So it may be that left atrial strain is going to play a very important role in diastolic dysfunction assessment, and it may be that the cutoff value is somewhere around negative 24%. This is another interesting study that examined left atrial strain as a marker for the severity of diastolic dysfunction that also, again, stratifies left atrial arrhythmic risk. They had 250 patients, and they did both cardiac MRI and echo and looked at left atrial peak longitudinal strain. And you can see basically the curves that were generated both by echo and by MRI. And then they actually also looked at the presence and severity of diastolic dysfunction and looked at clinical follow-up, and they found that left atrial strain was able to stratify arrhythmic future risk with arrhythmias coming from the left atrium here. And this was also consistent across the diastolic dysfunction categories. If we try to put everything together then, what should we say? Well, imaging in the management of left atrial size and function in both heart failure with preserved and heart failure with reduced ejection fraction, most of the time we're going to have a two-dimensional echocardiogram first. We're of course going to assess our diastolic dysfunction. We're going to measure our left atrial size. We might measure some other markers of left atrial function, such as the E and A waves, E and A and deceleration time, really are diastolic dysfunction parameters. We might use some tissue Doppler. We might look at the peak TR velocity and pulmonary vein reversal. all of this to sort of look at our traditional diastolic functional parameters. But if we particularly want to look at atrial fibrillation risk and also other things that we've already mentioned, to look at left atrial anatomy and function in this study, pre-ablation in particular, looking at both CMR and CCT, we can get some very good pictures of the size of the left atrium. But as far as our measurement of function, we need to incorporate speckle tracking for both diagnosis and prognosis. And that is in these patients who are thinking about undergoing atrial fibrillation assessment and interventions, but perhaps also in patients who really don't have other things but are at risk for atrial fibrillation. So they might have diabetes or hypertension. And incorporating left atrial strain by echo or by MRI could end up being incredibly important. Now, of course, we are also going to rely on MRI to look actually at the characteristics of fibrosis in the left atrium. And these are just some examples of where you can actually even drill down to see where the fibrosis is. And this is being worked on extensively, and we use this all the time in our institution to show which patients undergoing ablation are actually going to be free from recurrence of atrial fibrillation. Now, in terms of the future of left atrial echo measurements, I think it's going to be important in detecting atrial myopathy using, of course, reservoir strain. And this might be in cardiac chemotherapy, or it might be in many other different applications that we've talked about. For prognosis, we will be looking at left atrial size and left atrial emptying fraction, but really reservoir and probably contractile strain are going to basically become, I think, very standard in our assessments of prognosis. And it will be prognosis for many different things: recurrence of atrial fibrillation and heart failure hospitalization, and it will be more universally applicable. And I do think that diastolic dysfunction, the next iteration of guidelines, may very well think about incorporating left atrial reservoir strain into the algorithm. Will it be in place of or addition to left atrial size? Will it be a marker on its own? Will it be incorporated into standard, or will it be an extra thing that we use? I don't know, but I think that it will be hard to ignore the data that is being amassed. Right now we have problems with cutoff values. Many studies have suggested heterogeneity due to a variety of different reasons. But it may be that that one study I showed you is the correct one, and that it will be somewhere around the 24% range for the lower limit of normal. I do think it will continue to play a role to signal fibrillation and stroke risk, but we have questions. Will it be indicated as will it be used to say, this is a patient with abnormal left atrial strain, so now we should get a monitor to see if the patient has undetected atrial fibrillation. Perhaps it will indicate that the patient should go on to have a cardiac MRI in order to quantify the amount of cardiac fibrosis, and fibrosis in the left atrium in particular. Or will it possibly be used as a marker to help us titrate medications that are used for heart failure with preserved ejection fraction? I think in particular the SGLT2 inhibitors, and also eplerenone or spironolactone, and some of the other medicines we will hopefully have in the future to help us treat patients with heart failure with preserved ejection fraction. Will it be used for that? I don't know, but we shall see. What we hope, though, is that the use of left atrial size and mechanics will help us to keep our atrium free of congestion of boats, that it will be able to continue to allow the boats to come in to the left atrium and then go out of the left atrium in a coordinated and rational and reasonable fashion. And that is our hope. So thank you very much for your attention. And again, best wishes on your Congress, and congratulations.
Thanks the very instructive lecture of Professor Kirkpatrick. I understand more about left atrial strain. I hope we can apply it in the diagnosis of atrial myopathy. It is very difficult for us, it's very new. Thank you very much.
And now we move to the third presentation. I invited Dr. Nina Rashadi from Washington Medical Center with the topic left atrial assessment with echocardiography, novelty and clinical importance. Please, Dr. Rashadi.
Good morning. Thank you so much for the invitation to this wonderful STEAMed conference. My name is Nina Rashidi from University of Washington Medical Center. I've been asked to present on right ventricular function evaluated by multimodality imaging, advances, and clinical applications. The right ventricle had long been considered a dispensable cardiac chamber that does not contribute significantly to overall cardiac function. Yet studies in a couple of last decades has shown that RV function has been an important independent predictor of morbidity and mortality in patients with congenital heart disease, heart failure, pulmonary hypertension, and coronary disease. My goal for the next 15 to 20 minutes is to provide a current overview of multimodality imaging of the evaluation of the right ventricle function, with emphasis on benefits of new imaging techniques in clinical settings, making a comparison between different imaging techniques, and highlight the strengths and limitation of each technique. The right ventricle is pretty complex, but it has three basic structures, which are the inlet tricuspid valve leaflets, the heavily trabeculated apex, and a smooth outlet. And the shape and the geometry of the right ventricle present significant challenges to imaging of this ventricle. It is heavily trabeculated, and this definitely affects the definition of the endocardial surface. And this is also compounded by the fact that right ventricle is hugely load dependent. In general, cardiac MRI is thought to be the gold standard. It is, however, not widely available, time consuming, and it is costly. So we're going to start with the basics. Physical examination. We can use the third and fourth heart sounds from the right ventricle. We can use edema as a sign, or the RV heave. However, neither sensitive nor specific for assessing RV function. Then we use echocardiography, which is the most commonly used imaging technique to estimate right ventricular ejection fraction, quantification of RV free wall deformation by speckle tracking strain. Echocardiography may be superior to the more commonly obtained measures of RV contractile function. We use four major parameters involving echocardiography to assess RV function. These include tricuspid annular plane systolic excursion, or TAPSE. Second is tricuspid annular velocity, or S prime. Third is fractional area change. And fourth is the 3D drive RVEF. I'm going to take the next few minutes to go over these four parameters. The tricuspid annular plane systolic excursion, or TAPSE, also sometimes referred to as tricuspid annular motion, reflects a longitudinal shortening of the right ventricle. It is measured in the apical forechamber, and it is measured by placing the M-mode cursor on the lateral tricuspid annulus. It measures the peak distance traveled by reference during systole. So it is the distance that the lateral tricuspid annulus moves towards the reference during systole. The greater distance traveled during systole, the greater the RV systolic function. Normal TAPSE is considered greater and equal to 1.7 centimeter. However, TAPSE has major limitations. Number one, it represents one component of the RV motion, and the right ventricle may be frankly dysfunctional despite relatively preserved TAPSE, such as patients with severe pulmonary hypertension. Or the RV function may be globally preserved, however, TAPSE may be significantly reduced in those patients post-cardiac surgery. The second parameter to talk about is tricuspid annular velocity, or S prime, which measures the peak velocity of the tricuspid annulus during systole. So this is opposed to TAPSE, which was looking at the longitudinal displacement. S prime is looking at the velocity, and it is measured using the apical forechamber by placing tissue Doppler on the lateral tricuspid annulus. Normal S prime is equal and more than 9.5 centimeter per second. This parameter is simple to perform. It has prognostic data, and it has been shown to correlate well with CMR-derived RVEF and predicts outcomes in patients with pulmonary hypertension, inferior MI, chronic heart failure, and arrhythmogenic RV cardiomyopathy. The next parameter is fractional area change, which is equivalent to the EF of the left side, but we're getting this on the right side. The equation that we use to measure the fractional area change is end diastolic RV area minus end systolic RV area over the end diastolic RV area times 100. Normal FAC is equal and more than 35%. Major limitation is, again, tracing. So primary limitation is accurate identification and tracing of the true RV endocardial border rather than the prominent trabeculations and muscle bands. It really does correlate well with the CMR-derived RVEF. Lastly, we have RV ejection fraction measured by 3D. So RVEF with volumes measured from the 3D acquisition. We know that normal 3D RVEF, which is considered to be equal and more than 45%, is associated with low risk of cardiac mortality, whereas severely reduced, which is less than 30%, is associated with high risk of cardiac mortality. To reduce the time and variability associated with 3D echo measurements, machine learning algorithms with and without operator adjustments are undergoing development and testing, which will hopefully make this parameter much more available and efficient for the users. And then we move to the cardiac MRI, which is the most accurate and reproducible imaging method to quantitatively assess RV size and function. CMR is recommended for patients who have non-diagnostic echo images or insufficient images for diagnosis and evaluation. It's also used widely for complex congenital heart disease patients, for example, monitoring of the repair tetralogy patients, or those with suspected diagnosis of arrhythmogenic right ventricular cardiomyopathy or sarcoidosis. CMR is the preferred approach to assess RV size and function. If CMR is unavailable or contraindicted, then other imaging modalities such as cardiac CT can be used. The major limitations of this is difficulty defining boundaries of the RV at the tricuspid and pulmonic valves during the cardiac cycle. We do not need gadolinium just for the imaging of the ventricular size and function. Next, we have cardiac CT. It can be used to quantitatively and qualitatively assess RV systolic function. Visual assessment of the RV can be graded qualitatively by viewing cine loops of the cardiac cycles like we do with echo. And cardiac CT images are relatively rapid compared to all the other imaging modalities. However, the temporal resolution of cardiac CT is inferior to echo and MRI, which leads to CT overestimating volumes and as a consequence, underestimating RVEF. Again, major limitations are reduced temporal resolution. It also exposes patients to intravenous administration of iodinated contrast, and there's significant radiation exposure. Another modality that is no longer commonly used for assessment of RV function is nuclear. Using radioactive tracer to label the patient's red blood cell pool and a gamma ray camera to capture images of the blood circulating through the heart, we can assess RV systolic function. Limitations are there's significant radiation exposure using this method, and precise information on RV size and RVEF are not typically available through the widely used SPECT. So major limitations are radiation exposure, low temporal resolution, and also there's limited definition of RV borders and overlap with adjacent cardiac chambers. Lastly, we have cardiac catheterization, which is a reference standard for assessment of right heart hemodynamics, but it's only indicated in select patients with suspected right heart disease and pulmonary hypertension. In conclusion, during the recent years, right ventricular structure and function have been found to be an important determinant of outcome in different cardiovascular and also pulmonary diseases. Currently, echocardiography and cardiac MRI are the two imaging modalities that are most commonly used to visualize the RV. Most structural abnormalities of the RV can be reliably described by echo, but due to its complex geometric shape, echo is more challenging, and new promising echocardiographic techniques are emerging, but lack validation and limited normal reference data influence the routine use. Cardiac MRI is used as the gold standard for assessment of RV. And in those cases that the patient may be severely claustrophobic or they have devices that are contraindicated for cardiac MRI, other imaging modalities such as cardiac CT, nuclear, or even cardiac catheterization can be used for assessment of the right ventricle. We certainly have multiple imaging modalities and can all be used for different indications or individual to the patients. I want to thank you for inviting me to this conference and allowing me to participate. I have my Twitter handle attached. Please feel free to contact me and reach out if any questions, and hope to see you all very soon.
For a very interesting presentation. We hope after this meeting we have question and answer after this. Now we move to the next speaker. We would like to invite Dr. Gary Huang from University of Washington Medical Center, Seattle. The topic of Dr. Huang is detection of subclinical myocardial damage using multimodality imaging. Anything new in 2020? Please, Dr. Huang.
Hi everyone, my name is Gary Huang, and I will be discussing the detection of subclinical myocardial damage using multimodality imaging. Is there anything new in 2022? I'll start off by talking about the mechanisms and patterns of myocardial fibrosis, followed by cardiovascular imaging modalities for evaluation of myocardial fibrosis, including echocardiography, cardiac magnetic resonance imaging, computed tomography, and nuclear imaging. So what is myocardial fibrosis? Myocardial fibrosis is the excessive activation of cardiac fibroblasts, which leads to the expansion of the extracellular matrix with excessive collagen accumulation in comparison to cardiomyocytes. Fibrosis leads to increased myocardial stiffness and therefore cardiac dysfunction. Patients with myocardial fibrosis may present clinically with heart failure, but this disease is often subclinical also. So these images are a histopathology slide of healthy myocardium, interstitial fibrosis, and replacement fibrosis. So in healthy myocardium, you have the cardiomyocytes, which are stained in red here. With interstitial fibrosis, you have increased extracellular matrix in blue. And then with replacement fibrosis, you have a reduction in the number of cardiomyocytes and a very significantly increased amount of extracellular matrix. Myocardial fibrosis is most commonly secondary to ischemia, but it can be non-ischemic as well. And as I mentioned before, replacement fibrosis results in myocardial necrosis, typically from MI, and it's irreversible. In contrast, interstitial fibrosis is the result of increase in interstitial volume without a loss of cardiomyocytes, and it's reversible. So this is just a figure showing a healthy heart here with cardiomyocytes. Interstitial fibrosis, for example, in a patient with hypertrophy, you have the same number of cardiomyocytes but higher amount of extracellular matrix. And then replacement fibrosis, you have myocardial infarction, for example, which leads to death of the myocytes and an increase in the extracellular matrix. This figure just shows a timeline of cardiac imaging, which is used for the detection of myocardial fibrosis. So the first modality is endomyocardial biopsy. It's a highly accurate modality, but it's also invasive. And so other imaging modalities came after that, including basic echocardiography, late gadolinium enhancement, or LGE, by cardiac magnetic resonance, or CMR, in the 2000s. Speckle tracking echocardiography was developed in 2008, and then T1 mapping by CMR in 2010. We also have computed tomography and nuclear imaging for assessments of myocardial fibrosis, all of which I will discuss soon. So the first imaging modality, echocardiography. So in echocardiography, speckle tracking echocardiography is an advanced echo technique which is used to assess myocardial deformation, which is represented by strain. Speckle tracking echo allows for the identification of abnormalities in cardiac function in early and subclinical phases of various cardiac diseases. And myocardial fibrosis results in abnormal endocardial thickening because the myocardium becomes stiff. You also have changes in cardiomyocyte mechanics, which is reflected by abnormal strain values. So this is a polar plot of strain, and we have a patient with acute myocardial infarction and a patient with acute myocarditis. And these are just strain numbers. The more negative it is, the more normal, and the positive numbers actually indicate abnormality. So in this patient with acute myocardial infarction, you have abnormal strain in the anterolateral portion of the left ventricle. And in corresponding image, this is LGE by CMR, which I'll discuss soon. It shows transmural scar in a corresponding area, anterolateral wall, to the acute myocardial infarction territory. In acute myocarditis, you have abnormality in the basal inferior lateral wall, which you see here, LGE by CMR, which shows fibrosis in the subepicardium, which is shown here. So some studies with speckle tracking echo show that in patients with advanced heart failure, global longitudinal strain is more accurately predictive of myocardial fibrosis, even when compared with more traditional indices of systolic function, for example, ejection fraction. And in this study, the optimal cutoff point for global longitudinal strain to predict severe fibrosis was -10%. Other studies have also shown a correlation between myocardial fibrosis and strain in patients with a variety of cardiac diseases listed here. So limitations of speckle tracking echocardiography include a lack of standardization and specific cutoff values, but this is changing with an increased number of studies which involve speckle tracking echo. Also, speckle tracking echo is strongly dependent on echo image quality. In fact, global longitudinal strain calculation should be avoided when more than 2 myocardial segments are not well visualized. So this is just showing that. So in this patient, you have a really good image of the left ventricle, and it's optimal for strain calculation. This is certainly a suboptimal image in which you definitely can't make out a significant portion of the LV. And so this would be a poor candidate for speckle tracking echo. So let's switch gears to cardiac magnetic resonance imaging. So cardiac magnetic resonance imaging, or CMR, involves to detect fibrosis, the use of gadolinium. And this is a contrast agent which accumulates in any expanded extracellular space, such as seen in myocardial fibrosis. And late gadolinium enhancement, or LGE, on CMR detects myocardial scar secondary to replacement. There's different patterns of LGE which can be seen depending on the etiologies which cause myocardial fibrosis. And LGE is excellent in distinguishing non-ischemic from ischemic cardiomyopathies. So these are just images of a variety of cardiac pathologies and the late gadolinium enhancement patterns for each of them. So this is arrhythmogenic cardiomyopathy with left ventricular enlargement showing mid-myocardial scar in the inferior septum and the inferior insertion point showing LGE. This is Anderson Fabry disease showing mid-myocardial and inferior lateral LGE in the basal and mid-ventricular level. This is hypertrophic cardiomyopathy in image C, which shows mid-myocardial patchy anterior septum and inferior wall LGE with associated hypertrophy of the LV. This patient here in D has a RCA infarct and subendocardial LGE in the inferior wall here. This patient in E has cardiac sarcoidosis, which shows a typical mid-myocardial septal intense LGE at the basal ventricular level with corresponding area of hyperintensity on T2 weighted sequence. Even in patients with aortic stenosis, you see mid-myocardial, anterior septal, and inferior insertion point LGE at the basal ventricular level. And this patient with a severely enlarged heart has dilated cardiomyopathy with linear mid-myocardial LGE pattern. Patients with cardiac amyloidosis have amyloid deposition in the myocardium, which is the result of interstitial expansion, and LGE pattern in these patients is often subendocardial with circumferential or patchy transmural involvement. You can see here over time, after you inject gadolinium, you see LGE here kind of throughout the LV and corresponding findings on the histopathology slide. Patients with aortic stenosis with severe AS, they have increased afterload and resultant cellular hypertrophy. Over time, you have diffuse fibrosis, which occurs early and cannot be detected by LGE. Over time, you have myocyte cell death and replacement fibrosis in non-infarct pattern, and that occurs late and can be detected by LGE, which you can see in these areas here. Patients with hypertensive heart disease can have mid-myocardial LGE involving the basal anterior septum and RV insertion points. And patients with diabetes can have an ischemic LGE pattern even if they don't have a history of coronary artery disease. And these findings are associated with worse cardiovascular outcomes. T1 mapping and extracellular volume, or ECV quantification. T1 mapping can be used to scale the expansion of extracellular volume in the myocardium. And T1 mapping provides better characterization of myocardial tissue. So in contrast to LGE, you can actually detect interstitial fibrosis. And there's evidence with recent studies that abnormal T1 and ECV values are associated with worse outcomes with a variety of cardiovascular pathologies. So this patient with LGE has fibrosis in the septum and the inferior wall and native T1 here. And expansion of ECV you can see is abnormal here in the corresponding segments. The limitations of T1 mapping and ECV are a lack of standardization in data acquisition and post-processing, and no standardized cutoff values for what's abnormal and normal. T1 and ECV also are not specific for the presence of myocardial fibrosis. For example, you can also have high T1 and ECV values in the presence of other pathologies that just increase interstitial space. So myocardial edema, for example, in the setting of acute MI and inflammation, and infiltrative diseases like amyloidosis and sarcoidosis. These figures just show that the pathologies with the highest levels of T1 and ECV are MI and infiltrative diseases, which you see here, infiltrative for T1 is very high, as well as edema, and similar here with ECV. Another promising development in CMR is the use of non-contrast methods in detecting myocardial fibrosis, so you don't need to inject gadolinium. And one of the examples is CMR ultra-short echo time mapping, which utilizes the fast T2 signal decay property of collagen. And another is a diffusion-weighted CMR image. So this is an example of diffusion-weighted CMR imaging showing myocardial fibrosis in the patients with hypertrophic cardiomyopathy. So this is just the LGE showing fibrosis here in the inferior septum and corresponding findings here with diffusion-weighted CMR imaging. Another interesting and promising development in CMR is diffusion tensor imaging, or DTI, which can determine the architecture of the myocardium. And you can apply this to refine sudden cardiac death risk stratification in HOCM patients. And also you can perhaps predict adverse outcomes in patients after MI with adverse remodeling. And you can see a really interesting image here of DTI. And another promising development to CMR is novel agents that allow for non-invasive imaging of the pathophysiologic phases of infarct healing, but at a cellular level. So for example, you have elastin or tropoelastin specific contrast enhanced MRI for detection of ECM remodeling during infarct healing, and then a myeloperoxidase enhanced CMR, which can address the relationship between inflammation and extracellular matrix remodeling. This figure, I'm sure, looks familiar, and it's feature tracking CMR, which is very similar to speckle tracking echocardiography. And this allows for the evaluation of myocardial deformation before changes in EF. Also similarly correlates well with LGE and strain assessed by FTCMR, and has prognostic value in various conditions. One of the drawbacks is FTCMR has lower spatial and temporal resolution when compared with speckle tracking echocardiography. So again, speckle tracking on MRI, and this is LGE showing corresponding findings. Okay, switch gears again to a next imaging modality, computed tomography. So using CT for assessment of fibrosis is certainly new and evolving, and it involves the detection of scar via CT delayed enhancement and estimation of ECV. It does have a lower signal to noise ratio when compared with LGE by CMR, but the contrast agents used by CT delayed enhancement has similar kinetics with LGE by CMR, so some of the techniques in CMR can actually be applied for CT delayed enhancement. This is an example of a patient with dilated cardiomyopathy who received a CT delayed enhancement, and it shows a linear mid-myocardial pattern here. Studies have shown CT delayed enhancement to have excellent correlation with LGE by CMR and pathology in pigs with chronic infarct. So this pig who had a chronic infarct obtained a CT delayed enhancement image, histology, ex vivo and in vivo MRIs, and it shows kind of corresponding findings with CT, histology, and MRI. But again, because of its lower accuracy compared with MRI, its clinical application is currently limited still. The protocol for CT delayed enhancement is the use of higher contrast volume, so 130 to 140 milliliters, and lower energy, only 80 kVps compared with coronary CTA. And this is thought to improve contrast resolution, signal to noise ratio. Acquisition occurs 7 to 10 minutes after contrast administration. And CT delayed enhancement areas, for example here, have the same signal intensity as a blood pool, which could explain its low sensitivity but high specificity. One way to perhaps improve image quality is the use of dual energy CT, in which you're using CT acquisitions at different photon spectra. So either with an X-ray source that emits 2 different spectra, or using a 2-layer detection system. And dual energy CT allows for improved tissue characterization, so again, could improve image quality and also reduce the contrast use. This is just an example of dual source CT, in which you have 2 X-ray tubes and corresponding detectors, which emit different photon energies. Here you have a single source X-ray tube with alternating energies and a detector. And in this one, you have 2-layer detector with 1 X-ray tube that can emit, again, multiple energies. Some potential advantages over CMR of CT include its ease of use. Most facilities have a CT, and not being limited by implantable electronic devices like ICDs. Challenges include the need for increased contrast administration, the patients are exposed to radiation, and there is currently limited long-term prognostic data. And lastly, nuclear imaging. So nuclear imaging or myocardial perfusion imaging involves the use of SPECT or PET and can provide an indirect assessment of myocardial fibrosis. Perfusion tracers reflect myocardial blood flow and the presence of cellular integrity. So if you don't have uptake of the radio tracer on the REST scan, it could be interpreted as scar, but can also reflect attenuation artifacts and hibernating myocardium. Some limitations of SPECT include limited spatial resolution, and you're relying on relative counts, where the area of greatest uptake of the radio tracer in the myocardium is used as reference. So if there's diffuse abnormalities, you can perhaps underestimate the extent of scarring. This is a PET study of the PET viability study, which allows for quantification of absolute blood flow. And so you have the REST N13 up here, and then the corresponding FDG. So you see scarring in the apical and tereseptal wall, and corresponding FDG here as well, and so here, and the horizontal and vertical long axis here. And the perfusible tissue index, PTI, obtained by PET, is a new development that represents the portion of myocardium that can exchange water rapidly. And so it's an indirect measurement of myocardial fibrosis. So for example, a low PTI index reflects scar, which is not perfusible by water. 64 copper DOTA is another development which mimics the pharmacokinetics of gadolinium. So you can actually quantitatively analyze uptake in fibrotic tissue using PET imaging, but it does require an on-site cyclotron, so it's not used as much. Another interesting development in nuclear imaging is targeted imaging of fibrosis using radio tracers. And one of them is TCRIP, which targets integrins on the surface of myofibroblasts, which are responsible for collagen production. And in patients with MI, TCRIP uptake has been shown to be detected on the infarct area. So this is a study showing LGE here on short and vertical long axes, and a corresponding TCRIP uptake here. And this is a fusion image with MRI and nuclear, which is quite interesting. And lastly, we have integrin imaging using F18 labeled RGD in PET and acute MI patients, and was found to be feasible. And you can actually also have molecular imaging of the angiotensin receptor and even direct imaging of collagen and matrix metalloproteinases responsible for extracellular matrix degradation and turnover, and it's been shown to be possible. This is a rat model, and here you're seeing myocardial histology, and then you're actually seeing, this is planar imaging, and this is SPECT frontal and sagittal, and you're seeing uptake here, again, corresponding to scar. So quite an interesting development. That's all I have. Thank you very much for your attention. You can email me at my email here, GarySH123@Hotmail, or Twitter. You can follow me at Gary S. Huang. Thank you again.
That was a wonderful presentation, and we are very happy that all of our speakers, I will say in particular that Dr. Raschetti is the director of one of our echo labs in the University of Washington system, and Dr. Gary Huang unfortunately has moved to the Bay Area near San Francisco to be closer to family. But both of them are involved with the American Society of Echocardiography leadership program, and I'm very proud and happy that they have that distinction and are leaders in the field of imaging. I have a question actually for our other distinguished panelists here that is based on Dr. Raschetti's talk, and perhaps others in the audience could answer this too. Dr. Raschetti talked about 3D right ventricular ejection fraction, but it is time consuming currently. She said that in the future we will have the opportunity to do this with artificial intelligence assistance, which will make it faster, but right now it is challenging. So my question is, in Vietnam, which patients do you think should have 3D right ventricular ejection fraction if it is available?
Okay, thank you, Jim. I think that I agree with you. 3D echo is not frequent work in my hospital, and because it costs much of time. And so in measuring function of right ventricle, we only use TAPSE, FAC, and another thing. I do not remember mine. Do you remember in our hospital? Not mine, sorry. In one of our hospitals. So I think that sometimes our young doctor do 3D right ventricle. But for the person, we need to do 3D. I hope, I think the person with pulmonary hypertension, we think about cardiomyopathy of right ventricle. And we think about the cause of severe TR, severe tricuspid regurgitation. We need to find the cause. We need to measure right ventricle function.
Yes, I think that 3D is a very consuming time method, but it's not the routine method to do for every patient. But the patient which we think that have the RV disease, such as valvular disease or cardiomyopathy or MI, then it's very useful. And you have many congenital heart disease which affect the right ventricle, and that is very useful method. Yes, thank you.
Any question from the audience? Các đồng nghiệp có câu hỏi gì cần hỏi không ạ? Thầy giáo sư Kirkpatrick là một người đã làm rất nhiều năm trong echocardiography, nguyên ông đã là chủ tịch của hội siêu âm tim Mỹ. Tôi đã đến thăm bệnh viện của ông, hàng ngày tôi thấy ông ngồi đọc echo nữa. Ở bên Mỹ thì thường thường bác sĩ không có làm echo như mình đâu, có sonographer làm. Và sau đó thì bác sĩ ngồi đọc thôi. I explained about how you work in the United States. Sonographer will record echo, and I saw you read the echo in your lab. So I think that you have more time to study about echocardiography. For this case, I would like to ask Professor Kirkpatrick about atrial myopathy. You know that in the new guideline, they explained something about atrial myopathy, but for us, it's a very new one. Can you explain more about this?
That is a very good point. It is a new concept for us as well. The idea that the atrium can have a problem with it even in the absence of mitral regurgitation or diastolic dysfunction or even long-standing atrial fibrillation. That I think what this may represent is a complex interplay between the different aspects that either cause or contribute to atrial fibrillation or atrial myopathy, and the fact that atrial myopathy by itself can contribute to these other factors. Particularly, and I think the common thinking right now is in annular dilatation in mitral regurgitation. There's nothing wrong with the ventricle. There's been no ventricular enlargement. There's been no myocardial infarction. The mitral valve looks very good. There should be normal mitral valve function, but there is not, because the atrium is enlarged and therefore the mitral valve annulus is enlarged. And sometimes it is hard to tell if it's primary or secondary, but in the absence of other causes and in the absence of atrial fibrillation, there may actually be this primary atrial myopathy cause. I think we need much more information about how this will work, but the earlier application of strain imaging, I think, will help us to identify these patients earlier. If we believe that reservoir strain is maybe our most sensitive marker of left atrial dysfunction, we will begin to see it in many patients who have no other reason for atrial dysfunction. We will see that they have something wrong, and I think that in the future we will see that not only will they go on to atrial fibrillation, but they will also have, some patients will have a large mitral valve annulus, and some patients, this will be their first at least discernible marker of diastolic dysfunction. So I think on that point in particular, we may find that diastolic dysfunction is more about the left atrium, or at least as important in the left atrium without the left ventricle as with the left ventricle. That remains to be seen, and it will be very difficult to separate left ventricular diastolic dysfunction from left atrial diastolic dysfunction. But hopefully we will have more studies that will help us to understand that.
Yes, thank you, Professor Patrick, coming here. And I have just a question for you, because our hospital is we do many operation of valvular heart disease, and when the patient has atrial fibrillation, we do the Mace procedure. And what do you think we should evaluate the left atrial function before and after the Mace procedure, and when to do right after the operation, or 1 month, or yeah.
That is a wonderful question. I am so happy every time that I get the chance to interact with very smart people who ask really great questions, which is always true when I talk to people in Vietnam. The idea that we will be able to identify before May's procedure something wrong with the left atrium and then track its either improvement or continued worsening after May's procedure is a great question. I am not aware that there has been any research that has looked at this. I think in part because in the United States, at least, and in Europe, we are doing lots of left atrial catheter-based ablation procedures, so it is much better studied in that population. I do think that it makes sense to give some time after the May's procedure, at least 1 month, because I don't think that immediately after or within that 1 month we will get a good sense of what the left atrial function will eventually be like. I think, however, that we need studies to look at this, because I would suspect there are some patients who will recover left atrial function quite quickly, and they may actually have a better prognosis as far as staying out of atrial fibrillation than patients who say don't recover it. So let's say left atrial strain improves at 2 weeks after May's in one patient, and then it doesn't improve until 3 months in another patient. I would suspect that that patient who improves early will be less likely to have a recurrence of atrial fibrillation as long as we control for other factors, including perhaps left atrial size. But that is a study that probably should be done, and if you have a large May's population and could actually begin to look at that, that would be a very good contribution to our understanding.
Okay, thank you. The idea of Dr. Nga, and thank you, Jim. I think that we have a study about this. We can do this. Because in our hospital, we do Mace by ablation. And so we do measure strain of atrium before, after. Thank you very much for the idea. Okay, now the news, the chairman coming, but can you conclude?
Yes. Well, thank you all for joining us. Again, it's so wonderful to see everyone in the audience and to know that many people are watching online, and many others will be watching the recording of this over time. Please do feel free to contact our speakers. I'm sorry I didn't put my contact information, but I can usually be found on the internet. We are happy to continue the dialogue between the United States and between Vietnam in how we can improve the care of our patients. I think we have so much to learn from each other, and that we should continue to do that. I certainly have learned a lot, and I thank all of you for your contributions and for your attention.
Vâng ạ, xin chào quý vị đại biểu, xin chào các bạn. It's my honor to chair today with Professor Jim Kirkpatrick, our friend, our colleagues from Seattle. He's a big boss and big specialist on echo in Seattle. He's working with our society for many years, and today he is one of chair of our session. So in our session we have 4 speakers, and as our secretary says that Professor Jim McCable, he's not online right now. He'll come late, so we move on the second talk of Dr. Jim Lee, the time to intervene for aortic valve disease by multimodality imaging. By what and whom and who? Please, the clip of Dr. Lee, please.
Hi, my name is James Lee. I'm the director of echocardiography at the Henry Ford Hospital in Detroit, Michigan. I'm also a structural heart imager where I do interventional echocardiography and cardiac CT for structural heart disease. Today, we're going to understand some of the unique considerations of patients with aortic valve disease and challenging diagnoses, as well as their options for treatment, including transcatheter aortic valve implantation or surgery. The first thing we need to do is understand what the diagnosis of severe is. And while this may seem simple in some aspects, it's important to understand that the diagnosis of severe is a moving target, and it's based on multiple criteria, including symptoms, valve anatomy, valve hemodynamics, and the effects of valve dysfunction on ventricular and vascular function, such as end organ damage. We now have some interest in defining valve disease depending on the stage, which is stage A would be at risk. Stage B is what we usually would call mild to moderate historically. And stage C and D are the severe asymptomatic and symptomatic cohorts. And the way we make these diagnoses traditionally has been through echocardiography, which is available, cost-effective, and easy, although is limited by available imaging windows and sonographer expertise. Invasive catheterization used to be the gold standard, although is less frequently used now, but can still play valuable roles in adjudicating difficult and challenging cases with a lot of discordant data. Exercise testing, whether done with echocardiography or invasive catheterization, can both be extremely helpful in adjudicating cases, but does require trained operators and trained sonographers to really do an adequate job. We do have increasing numbers of patients with what I call the low gradient conundrum, where we now have almost up to half of patients undergoing transcatheter aortic valve replacement presenting with a low gradient variant. And we do have data that shows treating these patients with TAVR rather than doing a lot of adjudication with dobutamine stress echocardiography is helpful for improved outcomes. But these patients still are quite sick with a long-term morbidity or mortality of 39%. And certainly the diagnosis of these patients can be really difficult, where issues such as a high BMI may lead to low stroke volume indexes, and even adjudicating things such as invasive catheterization are not perfect because things like the Gorlin equation remain flow dependent. There are things that have come up that have improved the diagnosis of these types of disease processes, such as doing the aortic valve calcium scoring. Historically, this was done for risk of coronary artery disease risk stratification, but now when applied to the aortic valve can be helpful in adjudicating whether severe aortic stenosis is more likely or unlikely depending on the cutoff. You'll find different cutoffs in the literature, but these are the ones that are from the SCCT TAVR guidelines. You do need to have some caution in younger patients, particularly those that are under 51 years old with bicuspid aortic valves, because they may not have time to have calcified their valves yet. CT can provide a lot of adjunctive information, though, because you can see here, these are 3 aortic valves with severe stenosis with different morphologies that you can see just from a visual standpoint have significant leaflet restriction. So the traditional tricuspid valve on the left, a bicuspid Sievers class 0 in the middle, and a Sievers class 1 bicuspid valve on the right. So here is an example of case to sort of bring that point home. You've got an 80-year-old woman with dyspnea and exertion. She's morbidly obese with a BMI of 62 with obesity hypoventilation syndrome and a number of other cardiac comorbidities. And she was diagnosed with severe or moderate to severe low flow, low gradient aortic stenosis with preserved ejection fraction. Her peak velocity was 3.5 meters a second with a mean gradient of 25 millimeters mercury. And although her dimensional index was only 0.4, her aortic valve area calculated to be 0.9 centimeters squared and a stroke volume index of 26 milliliters per meter squared, which is far lower than the 35 required to make the diagnosis of severe low gradient aortic stenosis. Here's the Doppler tracing on the left of the aortic valve, and on the top right you can see the aortic valve in the parasternal long axis is restricted and a little calcified, and the short axis on the bottom right similar findings, although the quality of the echocardiogram is a little limited, likely due to the patient's high BMI. Here, the patient underwent a planning CT to help improve the diagnostic ability for the placement of the transcatheter aortic valve, and here she was found to actually have a valve that opened quite widely, and the aortic valve area by planimetry was 1.9 centimeters squared. And here I've got a few different ways that the valve area could have been calculated, either with an anatomic or geometric valve area versus an effective valve area. And you can see how we can get different diagnoses, anywhere from 0.88 centimeters squared to 1.9 centimeters squared, just depending on how you do it. So this is why for these low gradient cases, it's so important to look at the valve from as many different perspectives as possible to really help understand whether this patient does need to undergo an intervention, whether that be surgical or transcatheter. So when do we intervene once we've made the diagnosis in these tricky patients? Well, we want to make sure the patient has appropriate symptoms such as dyspnea, heart failure, angina, syncope, and pre-syncope by exercise testing. And certainly anyone with a severe high-gradient AS without symptoms but has a drop in the EF under 50% or is otherwise going to cardiac surgery are pretty reasonable reasons to send patients for surgery. There are a number of other class 2A indications for sending patients to surgery. But really at this day and age, one of the main questions that we have is when a patient needs a valve intervention, whether it's surgical or transcatheter, how do we decide which way to go? And it used to be we sent the high-risk patients to transcatheter aortic valve replacement and the lower risk ones to surgery. But these days, with the Partner 3 data showing there's a large equipoise in these types of populations, we really want to understand what the lifetime management of these patients are. Are they going to require a valve and valve and valve, requiring a larger initial valve to be placed? Are they going to have risk for leaflet thrombosis? Do they have patient-specific anatomy that make a transcatheter valve difficult to place? Or are these patients ones where we may want to just do a balloon valvuloplasty to start off to see if their symptoms improve and see whether it's worth sending them for an additional surgery? The partner data was one of the seminal trials that showed a lot of this initial data that showed in the high and prohibited risk cohorts, transcatheter aortic valve replacement was not only feasible, but had really significant improvements in symptoms when they survived, although these patients did still have high morbidity and mortality. And we've gone now all the way to this partner 3 data where the patients low risk have equipoise or in some cases superiority compared to surgical valve replacement. And what used to be the salvage procedure initially has now become a really a routine commoditized procedure where doing salvage or emergent procedures is actually quite rare. And you can see that the volume is growing for TAVR year over year. And then the risk of the patients is going down year over year. So the importance of having better outcomes is just becoming more and more critical. So this is where we use CT to plan for things like valve sizing, where we look at the aortic annulus to make sure that there's no abnormalities that may be an impediment. And you can see that looking at the aortic annulus, which is an oval structure, you see the minor dimension by transthoracic or TEE, and you're going to undersize a valve if you just use a single 2D dimension by echocardiography compared to CT. The aortic valve is also known to have a dynamic nature throughout the cardiac cycle, getting bigger in systole and smaller, more oval in diastole. And we can find a lot of other things with CT, such as calcium, that may increase risks of coronary obstruction, conduction system injury, annular rupture, and paravalvular leak. The calcium isn't everything, but here you see a patient with no calcium in the aortic annulus that ended up having actually a VSD post-TAVR. So even though we do our best to predict, we can't predict everything. Here's an example of a patient that had severe aortic stenosis, but had valve migration due to insufficient calcium in the aortic leaflets and the LVOT. So this goes to show you that the presence of calcium in the leaflets is not only helpful for the diagnosis of severe aortic stenosis, but can help you understand what might be a risk factor for something like valve migration. In this case, we were able to retrieve the valve with a balloon. However, this is obviously a very high-risk maneuver. Coronary heights are also very important to understand in patients with undergoing TAVR. With low coronary heights, a high risk for coronary obstruction. 10 millimeters tends to be the cutoff where we feel that the coronary height is low. But that's not everything, because here you can see a patient with a bicuspid aortic valve who had highly calcified leaflets, and despite having an adequate leaflet length, actually had coronary obstruction due to the significant calcium at the tip of those leaflets. If patients have had a prior surgical or transcatheter valve, we oftentimes do a projection of the valve size to the coronary level to see what the valve to coronary distance is. And if this is low, generally under 4 millimeters, this is also a risk factor for coronary obstruction. We also have other risks that we can identify with CT, such as the suicide left ventricle, where a precipitous drop in afterload in a patient that's hyperdynamic with underfilled LV may require a significant increase in afterload to maintain their blood pressure. We also want to understand that vascular access is very important for patients undergoing transcatheter aortic valve replacement. And historically, femoral access was the most popular approach and continues to be, but there is an increase in alternative access approaches such as subclavian carotid and what we use a lot of, which is called the transcaval approach. And so here you see a patient on the left with good femoral access and one on the right with poor femoral access. Here's an example of what we and a few other institutions would do called the transcaval access, where we use electrocautery to burn from the IVC to the aorta. And for those with a lot of small calcified femorals, this may be a very good approach. And we found that the outcomes with this are actually very similar, if not better in some cases, compared to traditional femoral approach. Although vascular access size isn't everything, here's an example of a patient that had a stent in the endovascular graft, and even though the graft was okay by size, the catheter still got caught on the bottom right going up in this patient. We use a lot of what we call fluoroscopy C-arm planning on CT to help understand risks and improve patient care planning. So I want to bring this all together with showing you one of our more complex cases. And this is a patient that was an 84-year-old man who had dyspnea exertion, had a surgical aortic valve replacement in 2011 with a 23 millimeter mitral flow, and a number of actually cardiovascular and non-cardiovascular comorbidities. The ejection fraction was reduced at 40 to 45%. and the aortic valve Vmax was 3.55 meters a second, and an AVA of 1.54 with moderate aortic regurgitation. And so the question was this patient's symptoms due to the aortic regurgitation and valve degeneration with maybe some aortic stenosis, or was they due to poor coronary function or some other etiology to one of the comorbidities? Ultimately, it was decided that the aortic regurgitation was probably the driver of the symptoms. And here's an example of how TEE can identify valve pathology. Here you can see a flail leaflet that is seen there with a severe eccentric aortic regurgitation. This can be difficult to see and oftentimes requires expertise and experience to remove the shadowing from the valve frame. And color Doppler by itself may be difficult to see this torrential aortic regurgitation. Here's a transgastric image that shows a little bit an improved color spread, although things like the pressure halftime, you can see in the top right, may not be as low as you think in patients where this is a little bit more of a chronic process. 3D can provide adjunctive imaging here. On the left, you can see the color 3D and the live 3D view. On the right, you can see actually there's a fusion between two of the coronary leaflets, indicating that probably is some degree of stenosis of this prosthetic valve degeneration. And here you can actually use the 3D data set to localize which leaflet is flail. So you can see the crosshairs on the top left are on the left coronary leaflet. And then there's that flail leaflet showed by the yellow arrow. And here is an example of the adjunctive value of invasive angiography. You can see the torrential aortic regurgitation where it was a little more difficult to see by CT or by echocardiography. This patient had some other risk factors such as pseudoaneurysm of the abdominal aorta, but otherwise had adequate femoral access. And we do a lot of CT volume rendered images to help guide what these images are going to look like under fluoroscopy and guide our image planning. And then we do our valve sizing. You can do this by CT alone, or you can use a freely available valve app to predict what type of valve should go inside this valve. And these things may sometimes be discordant, so you do have to have some caution on interpretation of this data. Here's an example where the coronary height in this patient was actually adequate at 11, greater than 11, but the valve to coronary distance was short and the coronary leaflet was long, leading to an increased obstruction risk. And we had the same issue on the right coronary artery where there was a long valve leaflet and a short valve to coronary frame. And so you can see that the valve leaflets were not very calcified. So we need to decide what to do. Should we go and send this patient for a surgical valve replacement or a transcatheter valve replacement? The transcatheter valve was highly risky due to the low coronary or the high risk of coronary obstructions, but the surgical risk was actually quite high as well. So we decided to do a transcatheter valve replacement with something called the basilica procedure, where we use intentional laceration with electrocautery of the valve leaflets so to mitigate the obstruction risk. And here we use a CT to plan what the view is going to look like under catheterization in the left main and the RCA. And here you can see the procedure itself. So under TEE, this procedure is guided with TEE. So first we want to make sure that there's adequate coronary flow. And then we use the predicted images and correlate under catheterization what the angles are to burn through the leaflet. And then here's an example of in the secondary view of how we line up the image. And then this is an example of 3D TE and 2D TE, how we identify the correct leaflet. So the yellow arrow is the left coronary leaflet we want to burn, but the catheter is actually in the non-coronary leaflet. And so we want to guide them. Here in the right, you can see that they're inside the frame, which is the correct positioning there. So what we do is we use TE to continually guide the procedure till we get them in the right position. You can see we're now on the left coronary cusp, although we are a little more in the mid-body to tip of the leaflet rather than the base. But ultimately, you can see we're pretty close to where the coronary artery is. So here's an example of how the wire is bouncing on the coronary leaflet prior to burning. And then this is what it looks like under TE as we undergo electrocautery to start burning in the leaflet. And then we confirm here that the wires cross the leaflet under TE. And then we snare the wire, forming what we call the flying V, leaving just an exposed wire tip to do electrocautery with. And so this tip of the wire burns with electrocautery as we pull through the leaflet. So here's an example of us going through the right coronary leaflet because we did burning through both leaflets in this patient. And here on the left, you can see as they're burning with electrocautery, the right coronary leaflet burning, and here on the left coronary leaflet burning with the flying V. Here you can see the lacerated leaflet on the right and the left showing the burned leaflet, and we now have severely worsened aortic regurgitation. And here's the transcatheter aortic valve going up safely in this patient, oftentimes with a lower deployment than we would have otherwise. Here you can see that we want to make sure we do have a preserved coronary flow. And then here in this final image, you can see this is the free tip of the leaflet that was burned. And had we not done the laceration, that would have surely obstructed the coronary artery. So in summary, treatment of aortic valve disease requires an integration of patient-specific risks to determine whether TAVR or SAVR is most appropriate. Multimodality imaging remains key for establishing the diagnosis of severe aortic stenosis and can really help in some of these really challenging cases where there are no good options. And we do need to have a lot of considerations for things like lifetime management to decide on the route for the initial therapies. And CT can help plan the complex interventions with patients without low-risk alternative options. Thank you so much for your time today.
Well, many thanks to Dr. Lee for an excellent presentation. Dr. Lee is certainly an expert in imaging and has expertise in both CT and in echo, and is able to use his expertise every day, as you can see, to guide those procedures. Well, let's go ahead and open it up. Are there any questions from the audience that we can discuss here in regards to intervening on the aortic valve in particular, but we can also take any questions or comments on intervening on the mitral valve as well. I will say that this basilica procedure has dramatically changed how TAVR is done in patients with very long aortic leaflets, because it used to be the case that these patients would have to go for surgery or would have a myocardial infarction. And Dr. Lee mentioned one thing that was important, and that is putting a wire down the coronary artery that you think might be obstructed during the course of the TAVR procedure, but that doesn't help at the end of the procedure. You basically have to be able to keep that open. So the basilica, as I hope everyone realized, basically cuts the leaflet in half, or at least cuts it, and then that allows the two sides of the leaflet, when it is opened, to have a hole through which coronary perfusion can occur. And that allows situations in which there is a low annulus to coronary height or a very long leaflet to actually still undergo TAVR procedures. As he showed, this is a difficult procedure to do and does involve having to grab the end of the cautery wire to be able to force it through to basically make that cut inside the leaflet. So it is something that must be learned. But you can see how important it is to do particularly the CT scan ahead of time to be able to see how high that height is and how long the leaflet is to see if this is a needed procedure. Dr. Loy, is there any basilica being performed that you know of in Vietnam? The basilica procedure, or cutting the leaflets, is that something that's done in Vietnam?
Not yet. Yes. So you have in Vietnam you have only about 100 cases of TAVI, and you don't have so much experience on TAVI. It's very, very expensive in Vietnam, and now only some hospital in Vietnam performing this procedure. In Hanoi's Vietnam National Heart Institute, you have some nearly 20 cases, and Vinmec Hospital, they have some 80 cases, and other hospital just few 2-5 cases.
Do you have data on outcomes as far as are outcomes better with the hospitals that do many rather than hospitals that do just a few?
Sure. So yes. So in VIệt Professor Nhan in Ho Chi Minh City VIệt Hospital, he has the largest number in Vietnam. So the first day there was some complication. There was some bad case, but with the time, with the number of cases, the outcome is much better.
Do you know about the role of CT scanning in Vietnam pre-TAVR? Is it used? Is it just use echo?
No, but CT is absolutely necessary to perform before the TAVI, because you have to measure the annulus, you have to see what about the aortic ascendant aortic arch, and you have to see the femoral artery.
And one controversial issue in the United States is during the procedure, not for basilica, but just a routine, standard, low-risk TAVI, do you use transesophageal echo or just transthoracic?
Most of case transthoracic.
And we're doing the same thing. There are some places in the United States that still use transesophageal, but the problem is the patients then have to stay longer in the hospital, and they have to be intubated, and they have to have general anesthesia, and it is much easier just to look for transthoracic, and we have not had problems. There are some cases, basilicas and others, that you still use transesophageal, but the vast majority are just transthoracic, and it's after the procedure is over. Very quick look.
So that's very important, the interaction between the interventionist and echographer, and I think transthoracic is good enough.
Yeah, it certainly is, but we do have to look and be very careful to look for the perivalvular leaks. Sometimes they're hard to see because the patient is flat on the back and you can't roll the patient, and sometimes the lights are very bright in the procedural theater, but you still have to be careful to scan through, particularly in the short and peristernal long axis views. Sometimes we only find it when we do the apical views and when we use our continuous wave Doppler to assess, because it's very small. But the presence of even a small amount of perivalvular leak is not a good prognostic sign, or at least not as good when you have none. Dr. Lee also mentioned the possibility of having a ventricular septal defect that can happen, and so we need to look for that. If there was a case in which the coronary heights are questionable, we really should look at wall motion abnormalities to make sure that there hasn't been an occlusion of the coronary arteries. And then sometimes you can get a pericardial effusion if you rupture the coronary or the aortic sinus, although that is very, very rare. So it's good to take views that allow you to see whether there is a pericardial effusion. We also routinely do measurements on the TAVI valve afterwards. The peak velocity, of course, the mean gradient, the Doppler velocity index, and the acceleration time. Mostly we do this as a comparison to follow-up echocardiograms, because if we see a big difference in one of those parameters, then we might be concerned for thrombosis of the valve leaflets. But you have to remember that a patient who, again, is flat on the back and is under sedation will naturally have lower velocities. So you have to take that into consideration. So the initial post-intervention echo, whether it's the next day or a month later, you have to realize that a change in velocities from the intra-procedural echo will not necessarily reflect a problem.
Thank you very much, Professor Dr. Jim Lee, and thank you, Jim, for your discussion. And now we have to move on to Professor Jim Kirkpatrick's talk about the when and whom and how the imaging modality help in intervention of tricuspid valve. This question, intervention on tricuspid valve is something rare in Vietnam, so your experience is very important for us, Jim. Please.
Thank you so much, Professor Loy. It is relatively rare in the United States also. So it is something that we are all learning, and we look forward to learning along with you as we all move forward in this. So I have no disclosures that are relevant to this talk, but I do get some salary support for 2 studies through the National Institutes of Health in the United States. I think everyone is aware that as rheumatic valve disease worldwide has become more rare, nonetheless degenerative valve disease with the aging of the population and even some other types of emerging valve disease, including endocarditis, is becoming more important. So while we have some successes, we also have some challenges that we have to take care of. And in fact, the total cost of heart valve in the United States, at least, is very expensive, $23.4 billion. As Professor Loy said, the new interventions that we have are playing a role in this cost, certainly. But we are seeing substantial costs from asymptomatic aortic valve disease, as well as the symptomatic diseases that we also see. We don't have data at this point, or at least I'm not aware of it, for the costs that are associated with tricuspid valve disease, especially because they overlap to some degree with the other valve diseases. But they are nonetheless, I think, quite substantial. Well, in the history of valve disease, we have many different ways to address it. Most of them have been surgical, and this is an interesting picture from the National Museum of American History in Washington, D.C., that has some examples of many different surgically implanted valves that we have used over the years. You can see some of them look quite strange to us nowadays, but no doubt in many years later, some of our current therapies will look very strange. And one of those therapies now that is gaining popularity in the United States and is performed quite frequently in our institution by Dr. McCabe is the tricuspid clipping procedure. And this illustrates to some extent its development, at least over the last 2 years. Tricuspid clips used to be just mitral valve clips, but they were quite small. And it's not until recently that larger specific tricuspid valve clips have been developed that allow us to actually grasp more of the thin tricuspid leaflets that also tend to be a bit wider in some cases than what we see on the mitral side. The Triluminate trial was an important trial that looked at transcatheter tricuspid valve repair against guideline-directed medical therapy for moderate to severe or much worse tricuspid regurgitation. And one of the things to note that even in this early trial there was very good initial success of 91%. And tricuspid valve severity was reduced to less than or equal to moderate tricuspid regurgitation In over half of patients at 30 days and 6 months, didn't seem to matter too much. But actually at 1 year, in conjunction, of course, with medical therapy, it was reduced at 64%. Even if it if it wasn't reduced to moderate or less, nonetheless, the change in tricuspid regurgitation of at least 1 grade was 86% at 30 days and 87% at 6 months, not really all that different. Very, very importantly, the New York Heart Association class was 1 or 2 in up to 80% of patients. But before the intervention, it was only 22%. So patients were clearly feeling better. And this was also reflected in the Kansas City Cardiomyopathy Questionnaire, the 6-minute walk test, and, as we shall see, importantly, improved right ventricular remodeling and particularly right ventricular systolic function. This is an example of a patient from our institution very, very recently, within the last 2 weeks. This patient had carcinoid disease and was very symptomatic, not just from the carcinoid, but also from lower extremity edema, and actually was even very short of breath. And you can see the thickened tricuspid leaflets here that don't coapt very well. Here's the regurgitation. If you just look at the color jet, you do not understand the full degree of tricuspid regurgitation. Accompanying this was also a very triangular shaped tricuspid regurgitant continuous wave velocity profile, and also flow reversal in the hepatic veins. Using transthoracic 3D techniques, we were able to look very, very well at the tricuspid valve leaflets. And you can see here on the left side of the screen, we have some ability of coaptation between the septal and anterior leaflets, but there's really no coaptation between the posterior and septal leaflets, and then there's a very small sort of posterolateral leaflet as well. And there is a very big hole right in the middle in systole through which all of this tricuspid regurgitation was coming. Again, these are transthoracic images with 3D, not transesophageal. And then looking at it from the other side, so we have flipped it around, we're now looking at it from the right ventricular side. The arrow is indicating where there was pretty good coaptation of at least parts of the leaflets there, indicating that this was probably the target for a tricuspid valve clip. But you can still see there's a big hole there. And I was rather worried that we were going to end up with a fair amount of regurgitation after the tricuspid clip, even though that it would clip there, because it looks like there's still a big coaptation defect. We were able to actually quantify, both in systole and diastole, how big this defect was, which gave us a sense both of the regurgitant orifice area and also how much how big it was during diastole, and give us a sense of the degree of tricuspid stenosis. And then here's a picture of the right ventricular systolic function. I'm giving you the subcostal view because it compares best with the post-intervention function, which we shall see. But we also did 3D right ventricular ejection fraction, showing that the ejection fraction was 44.9%, essentially normal or low normal. So this also was a very good sign that we were actually going to get a good result. And sure enough, you can see the tricuspid clip, which is here now. This is the clip there. You can see it's a very wide clip. We didn't reduce this to trace. We didn't reduce it even to mild, but we did get it down to a moderate degree. And fortunately, again, the thing I was worried about, there was not significant tricuspid stenosis here. The mean gradient was 5 millimeters of mercury, very, very acceptable at this point. For time, I'm not showing the intraprocedural TEE images, but they were pretty much concurrent with what we saw in the post-transthoracic images. The one thing that was different, of course, is that the right ventricular systolic function was impaired. I'm sorry we don't have three-dimensional images, but I think you can see here on the left side of the screen, the pre-images made the right ventricular function look better than what we saw in the post-images. Now, again, this is a very recent case. We'll have to see how the patient does over time, but the procedural success was excellent, and we are anticipating that the patient will get some relief of symptoms. There are other tricuspid valve interventions by transcatheter techniques which are available here. You can see the edge-to-edge repair, which is the clip that we just talked about. But there are also annuloplasty devices that are under development. Essentially, it is a percutaneously placed tricuspid valve ring that essentially is anchored to the annulus and then is pulled on a string to close and cinch down, reducing the annular size and improving tricuspid regurgitation. But there are also options for a tricuspid valve repair, what's been called orthotopic bioprosthesis. Essentially what this is right now is putting a TAVI valve inside the tricuspid valve position, and that will allow us to basically have a repair. Now, this is complicated because there's usually not a lot of calcium to anchor the valve, and so tricuspid valve replacements are under development right now, and hopefully will give us options to replace the valve. There are also what are called heterotropic bioprostheses, and essentially what these involve is putting valves inside the SVC and the IVC in order to reduce the effects of tricuspid regurgitation. These have not been used quite as much recently, especially because we're anticipating that these will be better valves, but we have to work on the anchoring systems. However, we run into the classic problem that we face in all of medicine when we're talking about interventions. We want to hit here on time, but we are at risk for doing an intervention too early, and we're particularly at risk for doing an intervention too late. And this is really, I think, where imaging plays the most important role. It's in giving us information that helps us to find the right clock. If we think about what cardiac imaging does, it can provide a diagnosis, it can provide a detection of a problem even in the absence of symptoms, it can characterize or describe what are the different facets of that problem, and it can also be used in monitoring. So when we apply this particularly to tricuspid regurgitation, we see that imaging can help us find the cause of right heart failure symptoms, and it can also detect asymptomatic right ventricular dysfunction. It can give us information about the primary or secondary nature of tricuspid regurgitation. Is it a problem with the valve leaflets, or is it a problem with the right ventricle, similar to how we think about mitral regurgitation? But characterization also means that in describing the nature of the tricuspid valve and the tricuspid regurgitation, it can tell us about whether the patient is a candidate for which type of intervention. Detection is obviously also important, and in particular, I would put under this the fact that we can find severe tricuspid regurgitation in the setting of mitral regurgitation, and obviously this helps us to decide whether to intervene on the tricuspid valve at the same time as mitral valve surgery or mitral valve interventions. But also it's the detection of right ventricular dysfunction in the setting of tricuspid regurgitation that will help us figure out what to do. And finally, obviously, imaging can show us the response to therapies and also, of course, provide intraprocedural guidance, which I don't have time to talk about today. This is a very important paper, I think, in describing the different types of tricuspid regurgitation. And we should find at least this one and this one very familiar. Functional or secondary tricuspid regurgitation reflects the fact that we might have dilatation of the tricuspid annulus and the right atrium, but really most of the time we're talking about dilatation of the right ventricle and dysfunction, systolic dysfunction of the right ventricle. But we can also have problems with leaflet restriction from tethering from the right ventricular dysfunction. And also, of course, our usual primary sense when we have a problem with the leaflet, and this actually could be in the setting of rheumatic heart disease or something like carcinoid, as we've seen, but it can also be primary leaflet prolapse, myxomatous leaflets, and that sort of thing. But on the tricuspid side, we have this other category, and this is lead related. This is from a pacemaker lead or an ICD lead that can actually, in some cases, fuse with a tricuspid valve leaflet and keep it from coapting, or at least prevent it from adequate coaptation. And of course, we can also develop this tricuspid regurgitation in the setting of chronic right ventricular pacing, which can lead to right ventricular enlargement and dysfunction. And so we can see this distribution, a little bit different than the mitral valve because of the involvement of the leads and pacing. But you can see here the relative percentages, at least that we think right now. We still think that most of this is probably secondary and mostly due to annulus and tethering. But there is a substantial number, particularly among congenital heart disease patients, and of course the acquired, whether it's from tricuspid valve endocarditis or other. Tricuspid regurgitation gradations, just to go over them, hopefully this is a helpful way of thinking about it. We can use multiple different echocardiographic assessments, but these are also available by MRI. Vena contracta is something we're very used to. Of course, we do it from one imaging plane, and that can be problematic, but our cutoff values here you can see, basically it's 3, 6, 7, 14, and 21. If you want to try to remember it, putting it into these categories all the way from mild up to torrential. Now, some people would say, why do we need anything worse than severe? Why do we need massive? Why do we need torrential? Severe is bad enough. And part of the reason is we want to be able to track improvements in tricuspid valve regurgitation with our interventions. So one of those one gradient changes with tricuspid valve clips that we saw in the triluminant study might be a reduction from torrential to massive. We clearly still need more data on how to use this. Our effective regurgitant orifice area that we would measure by our traditional PISA techniques, understanding all the caveats of PISA, of course, usually they're not a circular orifice, particularly in the tricuspid valve, but again, you can see the cutoff values there. Regurgitant volume, the same sort of thing, quite similar to what we would see on the mitral side. Regurgitant fraction. And then I think what we need to use more and more often, and this is a theme in every echo conference, is the use of 3D, particularly on the tricuspid side when we have problems with our vena contracta and EROA measurements because they do not reflect the true nature of the regurgitation. We need to be able to look at the 3D vena contracta. Now, we must recognize that secondary tricuspid regurgitation does not always improve with treatment of the primary problem. For instance, when we have left-sided valve surgery, usually on the mitral valve, and we leave the tricuspid valve alone, there's a 33% progression of the tricuspid regurgitation. So even though we think that TR is due to MR, we still end up with worse TR in a third of patients later. We do see that tricuspid valve surgery associated with right ventricular reverse remodeling and long-term outcomes happens when we actually do concomitant tricuspid valve surgery along with our mitral valve surgery. And as I hinted at earlier, the right ventricle is so important, and I couldn't say it any better than what was mentioned in the guidelines here. Patients with significant secondary tricuspid regurgitation had worse outcomes in the presence of right ventricular systolic dysfunction, regardless of whether there was right ventricular dilatation at the same time. However, patients who had right ventricular dilatation but preserved right ventricular systolic function had comparable outcomes to those who had no right ventricular enlargement, and this clearly underscores the importance of early referral before right ventricular systolic dysfunction occurs. So it may be that if we just have isolated right ventricular dilatation, we can wait a bit. But that probably means that we need to intervene because once you get right ventricular systolic dysfunction, we have a problem. We can reverse remodel the right ventricular size, but we have more trouble in actually reversing the function. So what do we need to know from imaging specifically in tricuspid regurgitation? Well, clearly we need to know the degree of tricuspid regurgitation. Then we need to answer the question, is this primary? Is this secondary? Is this both? Or is this due to a lead? And this means that we have to do careful assessment of the leaflets, the annulus, and the leads. And then clearly we need to look at the right ventricle, the size, the systolic function, and we should do our best to try to find out why it is dysfunctional. And then of course we need to measure hemodynamics, pulmonary artery systolic pressure, and others. And here is the guidelines, already a bit out of date because you'll notice at the bottom here it only talks about tricuspid valve surgery, but we didn't have overwhelming data at this point. But I have drawn circles around the areas that we need to play a role in imaging. The first is in right heart function. You can see here in severe tricuspid regurgitation, whether it is symptomatic or asymptomatic, we need to assess the right ventricle. In severe TR, we clearly need to differentiate between primary and secondary TR, even if it's asymptomatic. And we also need to look at annular dilatation, annular size, and the pulmonary artery systolic pressure. And we need to do that also if we don't even have severe TR. And the reason is that this annular size cutoff of 4 centimeters, which is basically where we have our data at this point, would at least give us a 2A indication for tricuspid valve intervention, let's say, instead of just calling it surgery. Here's the strengths of different imaging modalities that we can actually use in assessing right ventricular size and function and tricuspid valve leaflets and tricuspid leads. And clearly echo is very available, and it can look at the leaflet morphology and all of the right ventricular parameters and the annular size, and obviously guides intraprocedural interventions. But there are limitations in the use of echo, poor windows, and if we don't have access to 3D, we may have some problems with our accuracy as well. And that's where CMR can come in. Obviously gives us, in addition to the right ventricle assessment, tissue characterization, again getting at that why is the right ventricle dysfunctional, because it may just not be the tricuspid regurgitation. Increasingly, tricuspid regurgitation by MR in terms of quantification is very, very helpful, especially when the echo is less so. We can also get some leaflet morphology and look at the subvalvular apparatus. CT is also very important and really key in looking particularly at annular size. We can get some more information about the other things that we mentioned. And one of the things too is to make sure that if you're putting in a tricuspid annuloplasty device or a tricuspid valve replacement, that you look to see where the right coronary artery is, because you could occlude it during the procedure. We also can get some very good views of the vena cava and of course the femoral veins in case there's a problem. And so putting it all together, this is a very helpful diagram, I think, looking at what we would use echo for, what we would use CT for, and what we would use MRI for. And you can see where we have overlap in these different areas. I think practically echo is going to be the thing that we use for volumes and function, and to some extent for our degree of tricuspid regurgitation. But as I said, in areas in which echo is not clear, we should use cardiac MRI. And then also the cardiac MRI is really our gold standard for the right ventricle. Now this does bring up the fact that three-dimensional use in echocardiography will be very helpful because, as I said, 2D vena contracta cannot really capture our coaptation zone, which is not a circle anyway, and the tricuspid valve annulus is not a circle, and it's not even planar. This is a classic diagram showing as the tricuspid annulus gets bigger, it doesn't do so universally. It's constrained by the crux of the heart, and it really enlarges in this dimension here along the anterior and posterior, particularly the anterior dimensions. And so we do not see it in all of our imaging planes. We really need a three-dimensional assessment of it. And the tricuspid valve annulus, like the mitral valve annulus, is not planar. It is actually shaped in a three-dimensional way. So we really do need more three-dimensional usage there to characterize it well. And here are just some pictures of cardiac CT, cardiac MRI, excuse me, and the ways that you can actually get very good pictures. I think particularly with CT that we're able to use our planar imaging to look at it in multiple different ways and make very important measurements. And again, this is really going to be crucial as we use the annuloplasty devices, if those actually work, and also the tricuspid valve replacements. And there's just some more indications. Here's actually a way of trying to predict what will happen if you put in a tricuspid annuloplasty device. You can see this is a partial ring. Here's another thing that's not used so much. It's basically putting something right in the middle to try to plug up the tricuspid regurgitation. Here is a picture of what it would look like to actually have those tricuspid, the TAVI valves placed in the superior and inferior vena cava. And here is predicting what a valve replacement would actually look like in the tricuspid space. You can do all of this by CT. And of course, we need to use 3D ejection fraction, but also this is very well done by cardiac MRI. RV strain is something else that we haven't talked about yet, but is actually very important. We do know it is more sensitive in the detection of RV dysfunction. It does correlate with RV fibrosis and with strain by MRI, and it can help us in risk stratification. Again, this question of when to intervene. It may be that we now begin to use RV strain, particularly by echo, to tell us this is the time when we need to address that right ventricular, the right ventricular remodeling that is happening, and the right ventricular functional changes that are happening from tricuspid regurgitation. So hopefully I've given a picture of how imaging can help us in deciding, trying to get the on-time intervention here with all of these different techniques, which may or may not become standard. Certainly tricuspid clip is there. Symptoms are incredibly important, and our response to medications, if a patient is diuresed well and resolves, or if the tricuspid regurgitation resolves, we may want to watch this patient and continue to image, but this is a good sign. But there are those who will not respond to medications, and then we have to decide when to intervene. Clearly, we're going to use echo, and again, a plug here or a statement that we should be using more 3D and we should be using more strain. And then MRI, especially if you have an indeterminate echo, but also provides 3D and strain parameters of the right ventricle. And then CT, particularly for pre-procedural planning and our ability to determine what kind of intervention that we are going to use. Well, I thank you very much, Gamang, for your attention here. I do want to tell everyone that you can learn more about all of these interventions at the American Society of Echo 2023 Congress. It is being held in Washington, D.C. in June, and we hope to see as many as can make it there. I will guarantee that Washington, D.C. in the springtime may be nice, but it is nowhere near as beautiful as Halong. So thank you again so much for your attention.
Thank you very much, Professor Jim Kirkpatrick, for very beautiful and comprehensive talk about difficult problem, about the sometimes rare pathology that you are not good in Vietnam. Thank you. We have two more talk. The Professor Jim McCabe joining us, but first I would like to invite Dr. David Thor Lincoln. He will talk online. Thank you.
Ladies and gentlemen, I'd first like to thank the hosts for inviting me to speak with you today. And the title of my talk is Time to Intervene for Valvular Endocarditis by Multimodal Imaging. By what, for whom, and how? Patients with endocarditis are a varied and high-risk group. Decision-making can be complex, and in the time allowed, I can only scratch the surface of this challenging problem. What I will do is discuss some of the criteria, present some cases to illustrate how this multiple techniques can assist us in more complicated clinical situations. So when do we intervene in infective endocarditis? Fortunately, there are guidelines. The American Heart Association and the European Society of Cardiology have these guidelines, but these guidelines agree on some details but differ on others. The areas of agreement include heart failure. If there's heart failure due to severe valve dysfunction, if there's depressed LV function or severe symptoms, those are all reasons to intervene surgically. Uncontrolled infection is another reason to involve surgeons. If there's abscess, fistula, persistent infection, or a drug-resistant bug, these are all reasons that you may want to consider early intervention. Embolic risk, if the patient has had an embolic event, and also if the vegetation size indicates that the embolic risk is high, would be reasons for early intervention. Now, the guidelines disagree in some cases. So, for example, areas of disagreement are that the European Society of Cardiology says that the vegetation size has to be greater than 30 millimeters in size for that alone to be a reason for intervention. If there are signs of emboli, then they say that the vegetation only has to be 10 millimeters in size. For the American Heart Association guidelines, it's sufficient to have a vegetation that is 10 millimeters in size. So let's see how this plays out in a few case studies, some of them simpler and some more complex. So here in case one, we have a 33-year-old male who has a history of IV drug use on methadone. He has chronic bilateral lower extremity wounds from injection site infection. He presents with septic emboli to the spleen. He has acute renal failure with anuria, mild aortic regurgitation, and E. fecalis bacteremia. TEE was done and had the following findings. We can see that there's clearly a very large vegetation on the aortic valve that is attached to one of the leaflets. But interestingly, when we look at color Doppler, although there is aortic regurgitation, it's relatively minor. So in this case, there's not a lot of valve destruction, but we do have a large vegetation. This vegetation measured 2.7 centimeters or 27 millimeters in size. So by vegetation alone, then this would not meet the criteria by the European guidelines, but does by the American guidelines. Since he has evidence of septic emboli, then he meets surgical criteria by both guidelines. And in fact, he went on to a successful bioprosthetic valve replacement. Case 2 is a 64-year-old man who has methicillin-sensitive Staphylococcus aureus bacteremia. He also had an epidural abscess, which was probably the source of this bacteremia. He underwent an orthopedic intervention, and his echo was initially negative for vegetations, and after surgery, his bacteremia cleared. A repeat echocardiogram was done at day 10. And what we can see is there's no evidence for vegetations. There's a slight thickening of the aortic valve, and there is regurgitation, which looks like it's about mild aortic regurgitation. Since his bacteremia had cleared, then he was just followed. One month later, he presented with symptoms of shortness of breath, and an echo was performed. In this case, we can see there still is no evidence of vegetations. There appears to be more regurgitation on the color Doppler. The key finding that we found at this point, though, was that on the continuous wave Doppler, the aortic regurgitation profile was markedly abnormal. You can see a very steep descent of the aortic regurgitation. This measured at 4.2 meters per second squared. Generally, the deceleration slope of the aortic regurgitation jet can be used as a judge of the degree of regurgitation, with a threshold of 3.5 as the threshold for severe. So this is clearly above the severe level. And in fact, his left ventricle was enlarged, and the cause of his shortness of breath was this progressive injury to his aortic valve due to the endocarditis. And he also underwent successful aortic valve replacement with a bioprosthetic valve. But in both of these cases, we're using, well, in the first case, it was very simple, based just on seeing the diagnosis on the images. In this case, we're using the adjunctive modality of Doppler to indicate the severity of the aortic regurgitation. The third case is a 71-year-old male who has valvular cardiomyopathy with an ejection fraction of 18%. He had severe aortic stenosis, status post-TAVR in 2015. Unfortunately, he also developed Hodgkin's lymphoma and a large B-cell lymphoma which was treated with chemotherapy in 2017. On top of that, he developed COVID-19 4 weeks prior to presentation. He has a history of arterial hypertension and obstructive sleep apnea. He developed worsening shortness of breath and was found on echo to have aortic and mitral endocarditis, and his blood cultures showed Streptococcus bovis. Unfortunately, he then developed progressive conduction disease, Mobitz type 2 second-degree AV block, which was a concern for possible involvement of an abscess. And then he developed an ST elevation myocardial infarction and received a drug-eluting stent in the mid-left anterior descending artery. The decision-making for him was quite difficult because here we have a patient where we think he may have progressive endocarditis, although he has a sensitive organism. And if we were to take him to surgery, this would be very high-risk surgery given his low ejection fraction and other comorbidities. Ideally, we would like to treat him medically if we can convince ourselves that he does not have a periannular abscess. Here is his transesophageal echo, which shows the TAVR, which is well seated. It's not moving. It's not dehisced. And the leaflets are somewhat thickened, which is probably due to the endocarditis. At the same time, there's no evidence for periannular abscess. Based on this, the decision was to treat him conservatively in spite of all of his comorbidities and what has been happening. Case 4 is a 58-year-old woman who has aortic dissection type A with aortic root replacement. in 2021. She had previously had a thoracic endovascular aneurysm repair in 2020, a previous aneurysm repair in 2019, and a bioprosthetic aortic valve replacement. Comorbidities included diabetes mellitus type 2, and she presented developing septic shock from E. faecalis bacteremia and had a suspicion of aortic graft infection. This was based on CT. She has a sensitive organism, and we did a TEE, and this was somewhat alarming. This is the short axis view of the aortic valve, and we can see a collection posterior to the valve, posteromedial to the valve, which has a complex structure with echolucencies and septi. This is fairly typical for an abscess. Again, she's fairly high risk in terms of surgery. And the question was, is this truly an abscess, or is it an old accumulation that just wasn't noticed before because she hadn't been imaged? One way of doing this was to use another imaging modality, which was a tagged white cell scan using nuclear medicine. And here's the results of that tagged white cell scan. We can see a high uptake in the spleen and a lesser degree of uptake in the liver. But looking in the mediastinum, there is no uptake at all, indicating that there is no inflammation in the area of the aortic root. This would indicate that this is not an active infection, but is a chronic problem. So she is being managed conservatively for now. So in conclusion, multimodality imaging is useful for the timing of interventions in infective endocarditis. Echocardiography is the mainstay of evaluation, but other modalities can also be useful. The American Heart Association and ESC guidelines agree on most criteria, but have some significant differences. This very high risk and complex population is very well served by using a multimodal approach to determine what is best for each patient. Thank you very much for your attention.
Question for us in Vietnam also, the endocarditis. You have quite often this case, and the antibiotic therapy is very important, but sometimes you have to decide to operate or not this patient, because sometimes the response to antibiotic therapy is not so good, and the patient is in critical situation, and the decision is difficult. So, Dr. White, please, do you have any comment on this question? Dr. White, our Vice Director of Vietnam National Heart Institute, she is a specialist on echo in our institution.
Thank you very much, Dr. Linker, for the wonderful presentation. Thank you very much, Professor Loy, Professor Kirkpatrick. I learned a lot from the presentation of Dr. Linkers. In Vietnam, we have so many obstacles, so many challenges in dealing with the endocarditis patient. First of all, we lack of resource to access to advanced cardiac imaging like nuclear imaging, even cardiac CT is still expensive to Vietnamese people, and we even if we have a machine we have equipment. We do not have enough human resource who are well trained to interpret the data. So that is some limitation in the limited resource setting. So we mainly base on echocardiography, and in some big hospitals we have a 3D echocardiography. I have one question to Dr. Linker. When we treat the patient with endocarditis, and even the patient, the fever has gone, they respond very well with the antibiotic therapy, and we do the surgery for the patient. But after a few months, they have a fever relapse, so the infection comes back. So, but the guidelines doesn't tell us when to do the echo after the successful operation, or when the patient is asymptomatic, but the abscess or the infection is still limited and is in progress. So sometimes if the patient has a fever relapse and it is too late, because we need to detect earlier. And so if we have a nuclear imaging or other advanced, that would be better. But with echo, I think there's still a gap in our practice in this field. Thank you so much.
Thank you, Professor Dr. Please.
A very challenging problem that you bring up. And I think that I would say that in our practice, it's not routine to do more advanced imaging other than routine transthoracic echocardiography after successful operation for endocarditis. The difficulty is that, as you know, then a complication such as annular abscess may be difficult to identify on a transthoracic image. And so if we really wanted to look for that, we would have to do TEE. And I don't think we're at the point where we would do that routinely on all of our patients after surgery. And just another comment I want to mention to Dr. Loy's comments. I think that it's really important in these patients to have a multidisciplinary approach where we always talk with our surgeons and also talk to our infectious disease colleagues in terms of planning what we're going to be doing on these patients and the decisions that are made.
So we have to move on to Dr. Professor Jim McCabe presentation on imaging of mitral disease. Please, Professor McCabe.
Hi, I hope you can hear me. Thank you so much for the invitation. I'm Jamie McCabe from the University of Washington. I'm sorry for the confusion earlier. I'm actually in New York City at a wedding, and it's just about 1 a.m. My time on Saturday night, and I mistook some of the timing. So thank you for your flexibility. I wanted to speak for just a couple of minutes, on mitral valve disease, kind of following through on the format that you've been hearing, sort of timing and for whom and how. I am an interventional cardiologist, so I spend my time doing catheter-based mitral valve interventions, which will obviously be, so my presentation will be somewhat biased in that direction, but I wanted to just spend a few minutes referring to the American Heart Association guidelines, showing a couple of cases, and then hopefully generating some discussion. So mitral valve disease is obviously a very broad topic, and to cover it in a few minutes, we're just going to sort of do a very high-level overview. Obviously, mitral valve disease encompasses mitral stenosis, and within that, you can speak about a rheumatic mitral stenosis, or more commonly in my own practice is sort of calcific degenerative mitral stenosis. Mitral regurgitation, obviously a very common problem too, and in that scenario, you can have either primary valvular pathology or secondary mitral regurgitation due to LV dysfunction. So we'll just touch very briefly on all of these scenarios. So for rheumatic mitral stenosis, the American Heart Association guidelines the algorithm is sort of laid out here. The assessment, I think, is notable in one specific way as regards the 2020 guideline updates, which is that mitral gradient by echo was taken out of the guidelines in favor of mitral valve area specifically. And that's an acknowledgement that gradient obviously can change with heart rate, as everyone is aware. So the authors instead chose to focus on a mitral valve area less than 1.5 centimeters squared as representing severe mitral stenosis. If you have a mitral valve area greater than 1.5 centimeters and significant symptoms, they suggest that you might consider a balloon mitral valvuloplasty. If you have severe mitral valve stenosis with an area less than 1.5 centimeters squared, then following the algorithm here, you can either consider mitral valve surgery or balloon mitral valvuloplasty if the valve is pliable and there is no clot and there's not substantial mitral regurgitation. Balloon mitral valvuloplasty is something that we certainly do, though I would actually love to come and learn from all of you, because I'm sure that it is done better in places where they see more rheumatic mitral stenosis than we do. We do have some experience with this, and this is just a brief case. A patient who had active pregnancy, was a G1 P0, 17 weeks pregnant. She had had some sepsis recently. She was diagnosed with mitral stenosis. Her echo demonstrated a normal left ventricular ejection fraction and a mean diastolic gradient of 20 to 28 millimeters mercury at a heart rate of 70 to 80 with mild MR. Her gradient had obviously jumped during her pregnancy as her blood volume increased. I'm sorry that these don't play. I just noticed this after I had left home and was not able to get new films, but you can see here that our gradient is really substantial. Here it's measured at 28 millimeters mercury, mitral valve area of 1.1 square centimeters. For our mitral balloon valvuloplasty, I actually am not very good with the in-away balloon. I prefer to use a double balloon concept, which makes more of an elliptical shape, which I think gets into the commissures better. I usually use a pair of 16 millimeter balloons to start, acknowledging that most people's intercommissural distance on the mitral valve is greater than 30 millimeters. So I think that is not a dangerous size to start with, but you can go up as high as 20 or 24 millimeters per balloon. And in this case, I'm sorry, this little section doesn't play, but the other echoes will. In this case, we got her mean mitral gradient down to 3, and we're very happy with that result with mild residual mitral regurgitation. So I think that is a pretty common procedure, and obviously in-away balloon, single balloon technique is more commonly done for cost reasons. In the US, we have a little bit less constraints that way and tend to use a different technique. When it comes to primary mitral regurgitation, the assessment as laid out by the American Heart Association really comes down to diagnosing severe regurgitation, which I'm not an echocardiographer, so take everything I say with a grain of salt here, because it's not my job to read these echoes, though I do look at them carefully. I think there is a description of mitral regurgitation severity which is very quantitative, though it's my impression that often the assessment does become somewhat qualitative, looking at the Doppler jet. That said, ERO greater than 0.4 square centimeters is the most common parameter we tend to use on surface echocardiogram for severe MR. Vena contracta area for for a little bit easier to see on transesophageal echo at greater than 0.7 centimeters. Those would sort of establish the diagnosis of severe MR. Of course, you could also look at pulmonary vein flow, and I think seeing pulmonary vein flow reversal would be very corroborative for severe MR. In this algorithm, if severe MR is present and there are no symptoms, but there is systolic dysfunction with an EF less than 60% or a dilation of the ventricle, and with a primary leaflet pathology, then mitral valve surgery is recommended. If there are symptoms due to severe MR, regardless of LV function, again, mitral valve surgery is recommended unless the patient is higher inoperable risk, in which case, at least in our practice, patients move on to catheter-based approaches like MitraClip or edge-to-edge repair in general. Within mitral valve surgery, of course, there is a broad conversations about repair versus replacement, and I will leave that to surgeons to argue about, but certainly we favor mitral valve repair whenever possible. I will, however, say that a bad repair is not as good as a replacement. So certainly working within the context of what your surgeons are capable of doing within the anatomy provided is important. For patients who have normal LV systolic function and no dilation, a low risk surgery can be considered for repair specifically. However, if surgery is not considered to be low risk, then there is the idea that you may wait until things progress. Because I'm not a surgeon, I will focus for a second just on what is capable, what we're capable of treating with edge-to-edge technologies in this day and age. So this is an 82-year-old woman with longstanding mitral regurgitation from primary MR. She was presented to our structural valve team, which is a multidisciplinary team. She had prior surgery with bypass surgery. She was symptomatic. She was not interested in repeat open heart surgery, and we got a TEE showing severe degenerative myxomatous disease bilaterally. This is the kind of disease that we really previously were not treating with edge-to-edge percutaneous technologies until sort of more recent iterations of that of this technology. And here are just a couple more views of it. Actually, with the fourth generation clip technology, we are able to deal a little bit better with this billowing myxomatous disease by really pulling those leaflets together and attaching them centrally. And again, you can see that we get some residual MR, but certainly substantially less. So that is, we're increasingly tackling more challenging mitral valvular disease with percutaneous technologies. In terms of secondary mitral regurgitation, just to move along a little bit, obviously the the centerpiece of this therapy is guideline-directed medical therapy by a heart failure specialist. Again, the same parameters for severity persist for patients who are already undergoing open heart surgery for some reason. Then mitral valve repair or replacement can be considered. However, largely this is a category where we're finding more and more referrals for edge-to-edge repair, particularly for patients with reduced ejection fraction or dilated ventricles. There are some finesse to this conversation in terms of being very specific about how large the ventricle should or shouldn't be, and how poor the ejection fraction can be and still derive benefit. But just at a sort of very broad level, secondary mitral regurgitation is not typically a place where patients are sent for primary mitral valve repair or replacement because it's understood that this is a disease of the ventricle, not a disease of the valve. And so fixing the valve itself and not addressing the ventricle tends to be less than optimal. Just very briefly, to touch on calcific mitral stenosis, I don't know if this is something that is seen a great deal in Vietnam, but is certainly in the United States is increasingly common. I actually believe it is in part more common because we are treating more patients with catheter-based aortic valve therapies, and they're surviving their aortic stenosis and therefore able to present later in life with calcific mitral disease. This is a patient who had a transcatheter aortic valve replacement in 2018. She returned a few years later from a faraway state with progressive symptoms and found to have a mean gradient across her mitral valve of 25 millimeters mercury. This, at the time of her initial, that was her aortic valve, pardon me. The mean gradient across the mitral was 6 millimeters mercury. And this is one of the things that makes calcific mitral stenosis so challenging, is that these patients can have really substantial mitral annular calcification by mitral valve, by either planimetry or halftime. The mitral valve area can be really small, but the gradients are often not high. And so I think this is a space that we're still trying to understand a little bit better, sort of the low flow, low gradient mitral stenosis phenotype, which probably has not been studied as well as it should be to understand better how to treat these patients. In this particular case, you can see that visually her mitral valve barely opened, also did have some not terrible mitral regurgitation, and then she had some paravalvular leak around her aortic valve. These are very complex patients. The guidelines here are as shown. Again, referring to that 1.5 square centimeter area, or greater than 150 milliseconds for the halftime, but as opposed to using pressure gradients. Really a complex state that I think we need to understand better. These patients always require a CT scan for planning because their left ventricular outflow tract is in jeopardy when you put a transcatheter valve in. I won't get too much into that, but we do need to make sure that the residual outflow tract is sufficiently large to accommodate normal flow out of the ventricle after a transcatheter valve is put in, since the anterior mitral leaflet is not removed in a transcatheter technique. And I won't go too much into this, but we ultimately decided to do an alcohol septal ablation, as well as to try and improve her TAVR performance a little bit. And what we can see is that with alcohol septal ablation, you can make substantially more area along the outflow tract now. He has demonstrated it with the green arrow. That's a septal reduction technology that I'm sure that, or technique that I'm sure that everyone's familiar with, to try and make more space. And then we can ultimately use another transcatheter valve, in the mitral position when surgery is not a viable option. And unfortunately for these patients with dense annular calcification in their mitral valve, we frequently see that surgeons are unwilling to operate on them because debridement of all of that calcium can lead to AV dissociation or sort of separation of the heart. So certainly more to follow on that, and I don't know how common that is in Vietnam, but it's something that we are seeing more and more of, and hopefully we'll have more answers in the future. So with that very brief overview, here's the final result of her echocardiogram. So with that, I'll stop and thank you very much for your attention.
So you can see in our session, 3 big specialist from Seattle, from Washington University, Professor James Kirkpatrick, Dr. David Linker, and Professor Mạch. So it's your big heart for Vietnamese cardiology. Thank you very much, and we hope our colleagues learn a lot from you, and we hope in the future you have more collaboration with Seattle University, and you could send more young physicians, young cardiologists to you, not to learn about the echo, not to learn only to learn about the imaging, not only to learn about the intervention, but to learn the way of clinical and imaging laboratory, the combination of this modality for our patient. That's very, very important for our young physician. Thank you again. Thank you very much. Please, Jim.
Well, thanks to everyone for this great session here. And again, we appreciate the participation that's here and also online in the future. I want to give a special thanks to my colleagues, particularly Dr. McCabe, who is staying up very late to participate in this session. He's gone above and beyond. I should say that he is one of the few interventionalists who I think understands imaging better than some imagers and does his own CT scan analysis, which is very, very impressive. But we thank everyone, and we thank everyone for the opportunity. I certainly have learned as much as I have taught, as I always do whenever in Vietnam. And again, we appreciate the opportunity, the invitation to participate, and as you said, look forward to much collaboration in the future.
Thank you again, Jim, Professor McCabe, and Dr. Linker. Thank you again. And I have to say thank you to our audience, to our young fellow for their good job at our session. Thank you very much, and see you again.
Bye.
science, no matter how advanced, is only as meaningful as the lives it transforms. At Boston Scientific, more than 30 years of meaningful innovation has saved and improved millions of lives through pioneering treatments for coronary and peripheral artery diseases, digestive diseases, urinary and women's health disorders, and abnormal heart rhythm.
It's a brand new day. It's a brand new day. It's
Science, no matter how advanced, is only as meaningful as the lives it transforms. At Boston Scientific, more than 30 years of meaningful innovation has saved and improved millions of lives through pioneering treatments for coronary and peripheral artery diseases, digestive diseases, urinary and women's health disorders, and abnormal heart rhythm. Life.
It's a brand new day. It's a brand new day. It's
Science, no matter how advanced, is only as meaningful as the lives it transforms. At Boston Scientific, more than 30 years of meaningful innovation has saved and improved millions of lives through pioneering treatments for coronary and peripheral artery diseases, digestive diseases, urinary and women's health disorders, and abnormal heart rhythm. Life.
Các kỳ đại hội tim mạch và Hội Tim mạch Việt Nam đều là những sự kiện rất lớn trong cộng đồng tim mạch. Nhưng lần này sẽ rất đặc biệt. Dấu mốc lớn chính của đại hội ngày hôm nay là Hội Tim mạch Việt Nam sẽ trang trọng kỷ niệm 30 năm ngày thành lập hội.
30 năm, đó là một chặng đường dài đầy ắp những kỷ niệm. Từ những ngày đầu gian khó với vô vàn khó khăn cho đến ngày nay, chúng ta đã thu được rất nhiều các cái thành tựu đối với ngành tim mạch Việt Nam.
Hội Tim mạch Việt Nam từ khi được thành lập giai đoạn đầu tiên mà rất khó khăn như vậy, và hôm nay chúng ta đã có một cơ ngơi khá biệt thế. Đó là những cái thành tích về kiến thức y học về tim mạch. Chúng ta đã hội nhập sánh ngang vai với các quốc gia ở trong khu vực Đông Nam Á, và trong một chừng vực chúng ta đã có tiếng nói và sẽ có tiếng nói nhiều hơn trong cái thời gian sắp đến.
Đã thành thông lệ, Đại hội Tim mạch toàn quốc luôn quy tụ những chuyên gia, những nhà khoa học hàng đầu trong chuyên ngành tim mạch trong nước cũng như quốc tế, đem tới những chuyên đề mới nhất, cập nhật nhất và nóng nhất cho các bạn đồng nghiệp trong nước.
Đến với đại hội lần này thì chúng ta không chỉ tham gia những phiên khoa học hết sức bổ ích mà chúng ta còn có dịp gặp nhau để ôn lại những kỷ niệm hết sức xúc động của Hội Tim mạch học.
Chào mừng đến với Đại hội
Tim mạch toàn quốc
kỷ niệm 30 năm Hội Tim mạch học Quốc gia Việt Nam.
Kính thưa các quý đồng nghiệp, sau đây chúng ta sẽ bắt đầu chương trình đào tạo về siêu âm tim, một phiên rất là đặc biệt với sự tham gia của các báo cáo viên là các chuyên gia hàng đầu về siêu âm tại Hoa Kỳ. Và chúng tôi xin giới thiệu cùng chủ tọa với chúng tôi hôm nay là giáo sư James Kirkpatrick đến từ Đại học Washington, Đại học Washington ở thành phố Seattle, Mỹ. Let me introduce my co-chair, Professor James Kirkpatrick, Director of Echocardiography and Cardiac Imaging of Washington Medical Center in Seattle, USA. Please, Dr. Kirkpatrick, introduce.
Thank you so much. It's such an honor to be here to share this session with you. Welcome to everyone here in person and who is watching online and who will watch later on the internet. Our first speaker today is a very famous person. Dr. Leo Lopez has been directing echocardiography for a long time and has been very involved in many aspects of pediatric echocardiography and is currently very involved in the production of guidelines, particularly in relation to his topic today of pediatric echocardiographic measurements. We are extremely honored to have Dr. Lopez here to speak with us today.
Hello again. I would like to say once more how grateful and honored I am to be able to speak at this Congress. Over the next 20 minutes, I will discuss another of my favorite topics, pediatric echo measurements and the importance of Z-scores in this domain. During this presentation, we will discuss the roles of standardization, normalization, and measurement variability within the area of pediatric echo measurements. So over the last 10 to 15 years, the American Society of Echocardiography has published several pediatric specific guidelines and standard documents to help us with our practice. This is the paper on pediatric quantification that we published in 2010, which we are now in the process of updating. We provided specific guidelines on how and where to make cardiovascular measurements, all in an effort to standardize clinical practice. But as you know, publishing a guidelines document doesn't necessarily eliminate the controversies related to the performance of measurements. For example, the pediatric quantification guidelines recommended left ventricular diameter measurements in short axis views, whereas the adult guidelines recommended measurements in long axis views to make sure that the diameter measurements are perpendicular to the long axis of the left ventricle. We know that the left ventricle is not always circular in pediatrics, particularly given the frequency of congenital heart diseases with abnormal loading conditions for the right ventricle. So the short axis view assures us that the left ventricle is indeed circular when the diameter measurements are made. In addition, short axis views can also address the issue of lateral motion of the left ventricle during the cardiac and respiratory cycles. The biggest source of controversy with our document was the recommendation to use only two-dimensional linear measurements of left ventricular size instead of M-mode measurements. Although M-mode's really been the standard of care for many years, since the 1980s, especially with its excellent temporal resolution, the rationale for recommending two-dimensional measurements include the following. M-mode's been known to overestimate 2D measurements by up to 12 millimeters. It doesn't account for lateral motion of the left ventricle during the cardiac and respiratory cycles, and it's often difficult, if not impossible, to pass the line of measurement through both the midpoints along the septum and along the posterior wall. So here are two examples of M-mode tracings depicting the problem. When you take a close-up view of the reference 2D images, you see that in neither instance does the M-mode line bisect the midpoints of both the septum and the posterior free wall. These left ventricular measurements would be clearly inaccurate since they are not true minor axis diameters. Having said that, M-mode will actually once again be part of the updated guidelines, but this time with very specific rules on when and where it is appropriate to use M-mode versus 2D measurements. The timing of aortic root measurements has also had its own share of controversies. The adult guidelines recommend making measurements in diastole, mostly because image resolution during the M-mode era was better during diastole. But the maximum effect of vessel size on vessel function occurs at peak flow, which is during systole. And peak systolic wall stress, which occurs at peak systole, is the biggest determinant of dissection in patients with aortic dilation. So we recommended that aortic diameter measurements be obtained in systole, partly because most of the published normal pediatric data are based on systolic measurements. Studies in the past have shown that systolic aortic root measurements are significantly bigger than diastolic measurements, not a surprise. And that's why it's important to have a standardized approach when performing measurements and establishing normal reference ranges. Having said that, a study in adults 6 years ago actually showed that diastolic diameters are significantly bigger than systolic diameters, which is certainly a surprise. But when you look at the results from over 1,100 adult patients, the difference between diastolic and systolic measurements is 0.3 millimeters. Of course, the difference is statistically significant with this many patients, just not sure how clinically important that is. So even if timing recommendations may not make a significant difference in adults, we looked at a cohort of 272 normal children when I was in Miami and found that systolic measurements of aortic root diameters were in fact statistically and clinically significantly bigger than diastolic measurements. The next area that we need to understand involves the normalization of pediatric measurements. We know that children are not little adults, and adult reference values for the sizes of cardiovascular structures usually do not apply to children because the heart grows in size as the person grows in size. Here you see how the average aortic diameter in normal children increases as the body surface area increases. The big issue is how to distinguish this normal physiologic growth from pathologic changes in size associated with some diseases. To put it another way, we already said that body size plays an important role. Organs become bigger as the body becomes bigger. We also know that the sizes of cardiovascular structures are affected by the abnormal hemodynamics of certain disease states. So for example, the left ventricle is often dilated in patients with a ventricular septal defect. In tetralogy Fallot, the pulmonary arteries are often small. Abnormal genes also play a role, the aorta and Marfan syndrome and in Williams syndrome, the left ventricle and familial hypertrophic cardiomyopathy. And some studies have suggested that age, sex, and race may play a role, as well as other confounding factors listed here, nutritional status, hematocrit, exercise status, and environment, just to name a few. But it's body size that appears to be the most significant determinant for most cardiovascular parameters. So when assessing total body size, it turns out that body surface area is probably the best parameter to measure total body growth. It seems better than just using height or weight alone. So in most instances, body surface area is usually the recommended parameter when adjusting measurements for the effects of body size. So a common practice in pediatric cardiology and in adult cardiology involves indexing measurements to body surface area in order to account for the effects of allometry. This practice evolved from the known direct relationship between cardiac output and body surface area. And because cardiac output is also directly related to the sizes of cardiovascular structures, it's easy to extrapolate these relationships to a direct linear relationship between body surface area and the sizes of cardiovascular structures, the so-called indexing of measurements to body surface area used in clinical practice and in research studies. There are a lot of problems with this, but the most obvious one involves the fact that body surface area cannot be linearly related to length and to area and to volume measurements at the same time. It's just mathematically impossible. What we need to do is to develop a mathematical description of the mean behavior of a specific measurement in terms of body size over the full range of body sizes encountered in pediatrics. And this mathematical formula has to work regardless of how big or how old the patient is. The next issue involves the term heteroskedasticity. And I have to confess that I love saying this word because it's probably the longest word for which I know the definition. So heteroskedasticity represents the phenomenon of changing or non-constant variance that then is often associated with persistent dependence of the adjusted value on the independent parameter. So why is this important? So we saw previously the linear relationship between aortic annular diameter and body surface area. When the aortic annular diameter is actually adjusted for body surface area, in other words, the diameter divided by body surface area, you can see that the adjusted value decreases with increasing body surface area. There's a persistent relationship between the adjusted value and body surface area. The adjusted value is still dependent on body surface area. So the formula of diameter divided by BSA, body surface area, will make it look like the patient's aorta is getting relatively smaller as he or she becomes bigger. Now, if you use some transformation of the body size parameter, like the square root of body surface area in this example, it sometimes fixes the problem. So here you see that there's still a linear relationship between aortic annular diameter and the square root of body surface area. But plotting the diameter divided by the square root of body surface area against increasing body surface area, increasing body size along the x-axis, results in a horizontal line. There's no residual dependence of the adjusted value on body surface area. The mathematical descriptor for this particular measurement doesn't change with increasing body size. And this fits in with the physiologic finding that body surface area is a good predictor of vessel area if the square root of body surface area is a good predictor of vessel diameter. So for the diameter of the aortic root, as well as other diameters of valves in most central vascular structures, dividing the measurement value by the square root of BSA provides the best predictor of the behavior of the measurement over the range of pediatric body sizes. So what you need to know is how close your measurement value is from the mean value for that particular body size. This is where z-scores come in. They represent the number of standard deviations a specific measurement is from the mean value at that particular body surface area. Z-scores of -2 and +2 represent 2 standard deviations below and above the mean and have generally been designated as the traditional limits of normal for a given population. So an aortic root Z-score greater than 2 in the setting of Marfan syndrome represents aortic root dilation. A left ventricular volume that is less than -2 likely represents some degree of left ventricular hypoplasia. This is a graphic representation of what z-scores mean for a normally distributed set of data, where each vertical line represents a unit of standard deviation from the mean value for that population. And what people would call statistically normal would fall in the domain 2 standard deviations below and above the population mean. So multiple studies evaluating normal echo databases and establishing z-scores have been published over the years, and these are some of the more popular ones from Boston, Cincinnati, Detroit, Massa in Italy, and the Pediatric Heart Network, which is a multi-center study funded by the National Institute of Health in the United States. And this is a study that we conducted and published 5 years ago. Massimiliano Cantinati from Massa published this important paper 10 years ago, where he highlighted the issues with the most commonly published z-score databases. Here you see the major problem that he identified. In a boy with a body surface area of 0.3 meters squared, a mitral annular diameter of 11 millimeters actually corresponds to an incredibly wide range of z-scores from -4.8 to +2.5. And people are making clinical decisions based on one of these nomograms. The main reason for this wide variability in z-scores is that each study is based on different sample sizes, different study populations, often at a single center, and utilizing different methodologies for both how the measurements are normalized and how the measurements are performed. We looked at this a little bit more intensely last year by comparing the Pediatric Heart Network z-scores to the 3 most common z-score models in use, namely Boston, Detroit, and Italy. We found pretty good correlation among the models for most measurements, but there were also some important differences. The most noticeable one involved the diameter of the LAD coronary artery, the left anterior descending coronary artery, which was the smallest structure in our database. We found that the PHN z-scores for the LAD were routinely higher than the Boston z-scores by a factor of 1.3. You can imagine the concerns this difference raised, particularly with the issue of coronary artery dilation seen in cases of multi-inflammatory syndrome in children associated with the COVID-19 pandemic. We recognize the fact that Z-scores have been used in outcome studies, and that these studies, when available, are what drive clinical practice recommendations, like the American Heart Association guidelines for the management of children with Kawasaki disease. So one of the conclusions of our paper was that clinicians should use the same Z-score model that these outcome studies used when making clinical recommendations. The Kawasaki disease guidelines were based on the Boston Z-scores. So clinical decisions related to the coronary arteries in Kawasaki disease should be based on the Boston Z-scores. Not all Z-scores are the same. This brings us to the question of why this systematic difference or error existed between the Pediatric Heart Network and Boston Z-scores for the left anterior descending coronary artery. Certainly one of the etiologies is the variability in measurement performance that occurs at different centers, despite the fact that guidelines and standards for measurement performance have been published. This actually happened when we looked at another set of measurements through the Pediatric Heart Network project. We found that among the 3,215 normal children in the PHN database, when we calculated shortening fraction and ejection fraction from the measurements in the database, 552 of them, 17% of our normal population, had an abnormal value for either shortening fraction or ejection fraction or both. With a shortening fraction less than 25% or an ejection fraction less than 50%. The calculations were made from blinded measurements. In other words, we calculated shortening fraction and ejection fraction long after all the left ventricular size measurements had been entered into our database. So you can imagine the shock when we discovered this finding almost a year and a half after we finished collecting our data. The inter-observer variability for individual left ventricular size measurements were all good. So we concluded that calculated left ventricular functional parameters from blinded measurements in normal children revealed significant variability despite excellent inter-reader reliability. In other words, abnormal values for these parameters can be generated from echo studies in children despite qualitatively normal systolic function. Our speculation is that we minimize this variability in our daily clinical practice by manipulating the measurements to match what we think the value should be. Most of us have been in situations where an ejection fraction is calculated in the echo lab and it doesn't match what the left ventricle looks like qualitatively. We either repeat the measurements ourselves or we send the fellow back to redo the measurements. This should give us pause when we use Z-scores for functional parameters like shortening fraction and ejection fraction. So perhaps automated measurements of left ventricular size may ultimately be better in terms of fully understanding what's normal or abnormal left ventricular shortening fraction or ejection fraction. The other source of measurement variability is random error, which can partially be explained by the finite resolution of all echo machines. The Pediatric Heart Network looked at the reproducibility of many cardiovascular measurements in a large population of patients with dilated cardiomyopathy and found that for most distance measurements, there was a measurement variability of at least 5%. This was even higher for slope measurements and calculations that involve two or more variables like left ventricular mass calculations. So what this means is that measurement differences less than 5% when performed for the same cardiovascular structure by multiple observers or at different times by the same observer are likely within the normal range of variability because of the issue with random error. We used this concept in several studies to make the distinction between a statistically significant measurement difference and an acceptable clinically insignificant measurement difference. Particularly in studies with large sample sizes like the PHN Echo Z-score study, small measurement differences can prove to be statistically significant without having any clinical relevance. Finally, I want to talk about some initiatives towards implementing improvements in pediatric quantification. In the United States, the Intersocietal Accreditation Commission has led the forefront in terms of quality improvement in echocardiography. They've recently developed an online quality improvement tool that is meant to allow facilities to do some self-testing with objective measures of quality improvement progress while allowing sites to have a quantitative report of their quality metric scores in order to track actual improvement. The tool is used quarterly for 10 consecutive cases and involves metrics to assess appropriateness, technical quality, interpretation, and reporting. And here you see some of the elements of the tool, including questions related to RV inflow views, foreshortening, and of the left ventricle and apical views, appropriate reporting of left ventricular function, valve function, and appropriate reporting of specific measurements. Nothing like this exists for pediatrics at the moment, but we're certainly exploring this structural organization as a way to help improve quantification in pediatric echo labs. Luke Mertens at the Hospital for Sick Children in Toronto addresses the issue of measurement variability in his echo lab with annual assessments of measurement reproducibility by establishing multiple stations with volunteer models to look at measurement performance by all members of the team, followed by a discussion of measurement optimization to really enable true improvement. He shared with me some of the data from their first exercise. Here you see variability in measures of LV function and measures of RV function. Notice the significant variability in measurement of the right ventricular myocardial performance index. These data help Luke and his team to figure out what kind of educational interventions are needed in order to improve measurement variability at a local level. So in summary, the necessary components of high-quality pediatric echo measurements must include standardizations of the methodologies related to measurement performance, normalization of actual measurement values to account for the effects of total body growth, and local quality improvement initiatives to reduce measurement variability within your echo lab, and understanding the controversies in and limitations of pediatric quantification is crucial for continued improvement. Thank you very much for your attention.
That was a wonderful talk, and we really appreciate Dr. Lopez showing us the complexities of measurements and the importance of the question to Z or not to Z. Well, next I'd like to introduce Baxi Lee to talk about left ventricular systolic function measurement by 2D and by 3D echocardiography. Baxi Lee.
Thank you. Dear Chairman, Professor James Kirkpatrick, kính thưa các quý đồng nghiệp ở trong hội trường. Hôm nay tôi rất vinh dự được tham gia vào hội nghị về siêu âm tim và có một bài trình bày về đánh giá chức năng tâm thu thất trái bằng siêu âm tim 2D và 3D. Các anh chị ở đây đều đã làm siêu âm tim và đây là công việc mà hàng ngày chúng ta vẫn đang làm. Mỗi ngày chúng ta làm rất nhiều ca như thế và rất nhiều tháng năm như vậy. Thế tuy nhiên thì vì là phiên đào tạo nên em cũng xin phép nhắc lại những vấn đề mà chúng ta cũng đã từng đang làm và những vấn đề mà những bạn mới sẽ sắp sửa sẽ làm, thì em xin phép sẽ vẫn trình bày bài. Các slide chuẩn bị cho bài báo cáo thì em dựa trên khuyến cáo năm 2015 của Hội siêu âm tim Hoa Kỳ về đánh giá về chức năng các buồng tim ở người trưởng thành. Thì khác với bài trình bày của giáo sư số 1 thì ở trẻ em thì chúng ta sẽ cần phải có những cái chỉ số Z-score, còn ở người lớn thì chúng ta đã có các hội siêu âm tim lớn, ví dụ như hội siêu âm tim Hoa Kỳ hoặc là hội tim mạch châu Âu, họ đã làm những nghiên cứu lớn và chúng ta đã có những cái số liệu để tham chiếu, do đó là chúng ta sẽ không cần phải có những bước tính như Z-score mà chúng ta sẽ chỉ cần làm sao mà đo đạc được chính xác nhất và sử dụng các biện pháp tối đa nhất để mà đánh giá được chức năng tâm thu thất trái. Và cái chức năng tâm thu thất trái khi mà đo nó sẽ cho phép chúng ta biết được là cái thất trái nó có bơm máu tốt hay không, của mỗi nhát bóp vào trong đi toàn cơ thể. Và chức năng thất trái cũng là một thông số rất là quan trọng và đầu tiên để chúng ta có thể đánh giá về những cái bệnh lý trong tim mạch. Và trong tất cả các phiên siêu âm thì các anh chị và các bạn nghe rất nhiều về vấn đề là chức năng tâm thu trái cũng giảm hay là bảo tồn, thì tất cả những vấn đề đó thì vẫn là cái vấn đề chúng ta cần phải khảo sát trên mỗi quả tim của một người trưởng thành khi mà chúng ta làm siêu âm cho bệnh nhân. Và chức năng tâm thu trái cũng có mối tương quan với các triệu chứng về lâm sàng, ví dụ như là với mức độ khó thở cũng như là các triệu chứng mà bệnh nhân có. Vì vậy thì em liệt kê đây các thông số để chúng ta có thể cần phải đánh giá đối với chức năng tâm thu thất trái. Tổng cộng là có 10 thông số và các chị thấy là chúng ta đã rất là quen thuộc với có thể là 7 hoặc 8 thông số ban đầu trên 2D chúng ta làm thường ngày và thành thường quy. Thế tuy nhiên thì có những thông số thí dụ về siêu âm tim 3D hoặc là đánh giá về sức căng của thất trái thì đã có một số trung tâm làm. Chúng ta tùy thuộc vào những cái phương tiện mà chúng ta có tại những trung tâm đó. Thế thì các mặt cắt chúng ta thường sử dụng để mà đánh giá chức năng tâm thu thất trái thì chúng ta sẽ có các mặt cắt thí dụ như là mặt cắt trục dọc cạnh ức, mặt cắt trục ngắn cạnh ức, mặt cắt 4 buồng từ mỏm, 3 buồng từ mỏm và 2 buồng từ mỏm là những mặt cắt mà với mỗi bệnh nhân chúng ta đều lướt qua những cái mặt cắt đó để mà chúng ta xem mà một cách toàn diện chức năng tâm thu thất trái cho người bệnh. Em sẽ đi vào cái chỉ số đầu tiên, đó là cái phân suất co ngắn sợi cơ. Thì đây là cái chỉ số mà chúng ta cũng thu được đầu tiên khi mà chúng ta làm trên một người bệnh trưởng thành. Và theo như hiện tại ở Việt Nam thì chúng ta vẫn, mặc dù là khuyến cáo của Hội Tim mạch Hoa Kỳ chúng ta sẽ dùng các thông số trên 2D, thì tuy nhiên thì chúng ta vẫn đang sử dụng M1 để chúng ta đo. Bởi vì lý do vì sao? Bởi vì chúng ta không mắc điện tim thường quy ở tất cả các bệnh nhân người lớn, vì lý do là chúng ta cũng có khá nhiều người bệnh, thế nên là cái việc mắc điện tim thường quy nó cũng sẽ gây tốn thời gian. Thế tuy nhiên thì nó sẽ có một cái điểm khác biệt khi mà chúng ta sử dụng đánh giá phân suất co ngắn sợi cơ. Thì khi mà chúng ta có hướng dẫn của hình ảnh 2D và làm M1 thì thì chúng ta vẫn ưu tiên hơn là chúng ta ưu tiên hơn là chúng ta phải dùng 2D không và có điện tim mắc kèm. Thế tuy nhiên thì trong một số những trường hợp thì cái này nó sẽ không phản ánh chính xác được chức năng tâm thu thất trái, đặc biệt trong những bệnh cảnh mà bệnh nhân có block nhánh trái hoặc là có cái bất thường di động của vách liên thất hoặc là cái rối loạn vận động vùng thành tim. Thì khi đó thì cái phân suất co ngắn sợi cơ này, tại vì mình cắt qua một điểm, nó sẽ không phản ánh được chính xác cái chức năng tâm thu thất trái. Và đây là cái bảng mà giá trị tham chiếu của chức năng tâm thu thất trái ở người bình thường, ở nam và nữ. Chúng ta có thể thấy là giá trị bình thường, giá trị giảm nhẹ, giảm vừa và giảm nhiều để chúng ta tham chiếu dựa trên khuyến cáo của Hội Tim mạch Hoa Kỳ. Phương pháp thứ hai khi mà chúng ta đánh giá cũng vô cùng quan trọng, đặc biệt là với những người mà đã làm siêu âm rất là có kinh nghiệm, đó là chúng ta sẽ quan sát bằng mắt, tức là chúng ta đánh giá ước lượng. Khi mà chúng ta đánh giá cái vận động của một quả tim thì ở hai hình này thì các anh chị và các bạn thấy thì ở cái hình đầu chúng ta thấy là một quả tim tương đối là vận động bình thường, chúng ta có thể nhìn thấy các thành vận động vào ra tốt và buồng tim thì không quá là lớn. Trong khi đó thì ở hình thứ hai thì buồng tim giãn to và cái vận động nó rất là giảm. Đấy, hầu như là làm sự thay đổi về giữa tâm thu và tâm trương rất là kém. Như vậy thì cái vấn đề là đánh giá bằng một cách định tính, bằng cách mình nhìn ước lượng mắt thường cũng là một cái phương pháp mà chúng ta sẽ đánh giá để, và đồng thời chúng ta cũng biết được cái vận động vùng của các vị trí nó có thay đổi khác nhau hay không. Đến đánh giá phân suất tống máu. Phân suất tống máu thì nếu mà theo phương pháp 2D thì sau khi mà có đánh giá phân suất co ngắn sợi cơ, chúng ta cũng có thể đánh giá phân suất tống máu dựa trên phương pháp tách côn, và cũng là cái mà chúng ta thường trả kết quả cho tất cả các bệnh nhân khi mà những bệnh nhân đến sàng lọc và hầu như là bình thường, tức là những người trẻ khỏe mạnh bình thường, không có rối loạn vận động vùng thành tim, các vùng vận động như nhau, thì chúng ta có thể sử dụng phương pháp tách côn. Thế tuy nhiên thì trong khuyến cáo của Hội Siêu âm tim Hoa Kỳ thì họ cũng khuyến cáo rằng là chúng ta nên sử dụng ngay cả cái phương pháp trên 2D đó thì mình cũng đo trên 2D chứ không đo trên TM, để mà mình tránh cái sai số như lúc nãy bài báo cáo trước ông có nói là mình có thể bị sai số từ 10 đến 12% khi mà mình đo giữa TM và trên hình ảnh 2D. Thế còn đây là cái phương pháp đánh giá phân suất tống máu mà dựa trên 2D, tức là dựa trên phương pháp Simpson, tức là mình đánh giá dựa trên các hình đĩa. Thế thì mình sẽ đánh giá được cái thể tích cuối tâm trương và cuối tâm thu, và dựa trên thể tích cuối tâm trương và tâm thu chúng ta sẽ tính ra được phân suất tống máu. Chúng ta tưởng tượng như cái thất trái nó như là một cái hình viên đạn và được xếp bởi rất nhiều những cái đĩa xếp chồng lên nhau, và chúng ta sẽ tính từng cái đĩa đó, và khi chúng ta tổng cộng lại các diện tích đó thì sẽ được một cái thể tích. Thế nhưng đây vẫn là hình ảnh 2D và chúng ta sẽ phải đánh giá theo từng mặt cắt, tức là chúng ta sẽ đánh giá trên mặt cắt 4 buồng từ mỏm, mặt cắt 3 buồng từ mỏm, 2 buồng từ mỏm. Và như thế thì chúng ta cũng chỉ nhìn được 3 vị trí, chúng ta cũng không nhìn được một cách tổng quan về cấu trúc 3D của thất trái. Và như thế chúng ta đánh giá được trong từng nhát bóp của tim về cái phân suất tống máu. Và cái phương pháp Simpson này chúng ta cũng đòi hỏi là chúng ta sẽ đánh giá thông thường trên lâm sàng. Chúng ta thường áp dụng trong những trường hợp là bệnh nhân có những cái rối loạn vận động vùng thành tim, thí dụ như là bệnh nhân có bệnh tim thiếu máu cục bộ, hoặc là những trường hợp mà bệnh nhân có thể không có bệnh lý mạch vành nhưng mà có những cái nguyên nhân khác nó gây ra rối loạn vận động vùng thành tim, thì cũng làm cho cái phương pháp Techcon nó không còn chính xác nữa, chúng ta phải dùng phương pháp Simpson. Và đây là chúng ta sẽ dùng phương pháp Simpson 4 buồng và 2 buồng để đánh giá. Chúng ta viền nội mạc để mà xem cái thể tích cuối tâm trương và cuối tâm thu của thất trái, và từ đó chúng ta sẽ áp dụng công thức và tính ra được phân suất tống máu. Tuy nhiên thì có một cái số những hạn chế khi mà đánh giá chức năng thất trái bằng phương pháp Simpson mà các anh chị nếu mà đã từng làm chúng ta đều biết là có những trường hợp là chúng ta cùng một tay chúng ta đo nhưng mà chúng ta sẽ ra rất nhiều những cái chỉ số nó khác nhau. Đấy, vì nó phụ thuộc vào cái nội mạc, cái viền nội mạc nó có đủ rõ chúng ta nhìn thấy cái bờ nội mạc thì mình viền hay không. Thứ hai nữa là có thể là khi chúng ta cắt ấy, thì chúng ta để nó bị ngắn hơn so với thực tế cái chiều dài của chúng ta không lấy hết được cái mỏm tim, do đó là nó cũng ảnh hưởng đến cái thể tích thất trái. Và vì chúng ta không mắc điện cực một cách thường quy nên là chúng ta cũng dựa vào cái sự đóng mở van hai lá hoặc van động mạch chủ để mà chúng ta xác định đâu là thì tâm thu, đâu là thì tâm trương. Thế nên là nó cũng sẽ có cái sai khác giữa cái thể tích cuối tâm trương, cuối tâm thu nếu mà chúng ta không lấy đúng được cái cuối và cái chu chuyển tim đó. Và cũng như là khi mà em đã trình bày, tức là mình đánh giá bằng phương pháp Simpson thì mình sẽ đánh giá cắt từ mặt cắt này chuyển sang mặt cắt khác, chuyển sang mặt cắt khác, tức là 3 mặt cắt, 2 buồng, 3 buồng, 4 buồng, một cách di chuyển nó không phải là một cái sự liên tục. Thế nên là chúng ta vẫn không đánh giá hết được, và có một số thành chúng ta không đánh giá được, ví dụ như là thành sau bên hoặc là thành trước vách. Đấy thì chúng ta không đánh giá được trong cái khi mình đánh giá về Simpson. Và khi mà bệnh nhân có cái tình trạng mất đồng bộ giữa các vùng có bóp thành thất thì nó cũng sẽ không phản ánh đúng được chức năng tâm thu thất trái. Và đây là cái giá trị tham chiếu từ khuyến cáo của Hội Thông tim Hoa Kỳ năm 2015 về các giá trị của thể tích cuối tâm trương và cuối tâm thu thất trái khi mà chúng ta đánh giá ở người nam giới và người nữ giới trưởng thành, và có tính theo chỉ số BSA để chúng ta có thể tham chiếu đối với những trường hợp mà chúng ta làm trên bệnh nhân, và chúng ta đã có cái số tham chiếu này ở trên cái bản kết quả của chúng ta để chúng ta có thể kết luận cho người bệnh. Một cái thông số nữa chúng ta có thể sử dụng để đánh giá về chức năng tâm thu thất trái, đó là cái đánh giá về cái thể tích tống máu và cái cung lượng tim. Thì thể tích tống máu thì là một cái nhát bóp mà thất trái có khả năng tống đi được bao nhiêu thể tích máu, thì chúng ta sẽ dựa vào cái VTI của đường thắt thất trái cũng như là cái đường kính của đường thắt thất trái để chúng ta tính được thể tích tống máu. Và trên cơ sở nếu chúng ta có mắc điện tim, chúng ta có tần số tim thì chúng ta sẽ tính ra được cung lượng tim của người bệnh cũng như là chỉ số tim. Thế thì hai cái đo đạc quan trọng trong cái đánh giá thể tích tống máu đó là mình sẽ phải bộc lộ được cái đường thắt thất trái một cách đo đạc một cách chính xác nhất vị trí đường thắt thất trái. Chúng ta sẽ zoom vào vị trí đường thắt thất trái và đo. Vì đây là chúng ta sẽ tính diện tích nên là nó sẽ bị sai số theo mức độ bình phương, và nếu mà chúng ta chỉ cần sai lệch 1 mm thì nó sẽ ảnh hưởng đến cái phân suất thể tích tống máu khá là nhiều. Và thứ hai nữa, đo VTI của đường thất trái thì chúng ta cũng sẽ cần lấy được một cái tín hiệu Doppler sum rất là rõ nét để mà chúng ta có thể viền được cái VTI đó. Và trên cơ sở đó thì chúng ta sẽ ra được một cái bảng các kết quả mà trong đó thì khi chúng ta có tần số tim thì chúng ta sẽ tính được cả thể tích tống máu cũng như là cung lượng tim cho người bệnh. Tuy nhiên nó cũng sẽ có một số những hạn chế trong cái phương pháp đánh giá về phân suất tống máu này, đó là trong những trường hợp bệnh nhân bị nhịp tim không đều, ví dụ bệnh nhân có rung nhĩ chẳng hạn, thì nó sẽ có cái sự sai khác giữa nhịp tim ở cái chu chuyển tim này với chu chuyển tim khác. Và thứ hai nữa là như tôi vừa nói, tức là khi mà chúng ta đo cái đường kính đường thắt trái mà nó không chính xác, nó chỉ cần sai lệch một chút nó có thể ảnh hưởng đến cái phân suất tống máu. Và trong những trường hợp nếu mà bệnh nhân có hở chủ thì nó sẽ bị sai số rất là nhiều với cái phân suất tống máu này. Và trong trường hợp bệnh nhân có hẹp chủ thì cái tín hiệu hẹp chủ nó có thể nhầm với cái tín hiệu của cái VTI đường thắt trái. Do đó chúng ta cần phải lưu ý trong những cái trường hợp mà cái thể tích tống máu này nó có thể là mình sẽ không áp dụng được một cách chính xác. Và bên là cái giá trị trong giới hạn bình thường của thể tích tống máu cũng như là cung lượng tim và chỉ số tim của người trưởng thành khi nghỉ ngơi cũng như là khi gắng sức. Các chỉ số về siêu âm Doppler mô cũng giúp cho chúng ta đánh giá được chức năng tâm thu thất trái của người bệnh, vì các tín hiệu Doppler mô thì chúng ta sẽ thông thường chúng ta đánh giá qua thất trái, chúng ta đánh giá qua vòng van hai lá ở vị trí vách liên thất cũng như là thành bên thất trái. Thì chúng ta cũng thấy là có những cái tín hiệu này là nó phản ánh cái vận động của vận động của cơ tim đó, vận động của từng sợi cơ tim đó, và các vận tốc ở vòng van thì nó trong thì tâm thu và nó có tương quan với lại phân suất tống máu thất trái. Thì chúng ta cũng có thể đo này nếu trong trường hợp mà phương tiện máy của chúng ta là có cái Doppler mô. Một cái thông số nữa chúng ta cũng sử dụng để đánh giá về chức năng tâm thu thất trái, đó là tỷ lệ dp trên dt, tức là một cái thông số để đánh giá về cái sự co bóp của cơ tim, và nó cho biết là cái tốc độ gia tăng về mặt áp lực trong buồng thất trái theo thời gian trong thì tâm thu của tâm thất trái, và cái tốc độ gia tăng này càng nhanh, tức là trong thời gian càng ngắn, thì cái chức năng tâm thu thất trái càng tốt, tức là nó vẫn được bảo tồn. Tuy nhiên thì có một số những cái hạn chế khi mà chúng ta đo đạc cái dp trên dt này, tức là chúng ta bắt buộc là phải có cái tín hiệu của dòng hở hai lá thì chúng ta mới đo được cái sự dịch chuyển từ sự thay đổi áp lực từ vận tốc 1 m trên giây đến vận tốc 3 m trên giây. Đấy, thì chúng ta cần phải có một cái tín hiệu hở hai lá tốt, đặc biệt là cái sườn xuống. Thứ hai nữa là chúng cũng sẽ bị cái thông số này sẽ bị phụ thuộc vào cái sự quá tải về thể tích cũng như là áp lực của thất trái, nên là chúng ta cũng sẽ cân nhắc trong những trường hợp mà bệnh nhân thí dụ như đang có tình trạng quá tải thể tích, hoặc là bệnh nhân đang suy tim chưa ổn định mà cái tần số tim quá nhanh. Và chúng ta cũng có cái giá trị tham chiếu, chúng ta có đánh giá được cái chỉ số dp trên dt bằng cách là chúng ta sẽ đo cái thời gian tăng vận tốc từ 1 m trên giây đến 3 m trên giây, và nếu mà chúng ta có P2 trừ P1 thì tương đương với là 32 trên T, thì chúng ta sẽ ra cái tỷ số dp trên dt, và cái giá trị bình thường của nó với những trường hợp bình thường thì sẽ là trên 1200 m/ngân trên giây, và những trường hợp giảm nặng đó là dưới 500 m/ngân trên giây. Một cái thông số mà gần đây những cái chúng ta sử dụng nhiều hơn để đánh giá về chức năng tâm thu thất trái, và nó sẽ phản ánh sớm hơn cái sự thay đổi trong tâm thu thất trái, đặc biệt ứng dụng trong một số những cái hoàn cảnh bệnh lý, thí dụ như là bệnh nhân bị ung thư và có điều trị hóa chất hoặc xạ trị ung thư chẳng hạn. Có những trường hợp chức năng tâm thu thất trái khi mình đánh giá bằng EF nó chưa giảm, thì tuy nhiên thì cái sức căng của thất trái đã giảm và đã bắt đầu giảm, và chúng ta có thể phát hiện sớm những cái sự thay đổi đó để có thể tiên đoán và điều chỉnh cái phác đồ điều trị cho người bệnh. Thì cái Doppler đánh giá cái phương pháp mà đánh giá sức căng của thất trái này, thì chúng ta sẽ có sức căng đánh giá theo chiều dọc, theo chiều chu vi và theo chiều ngang. Thế tuy nhiên thì hiện tại chúng ta mới đã áp dụng trong khuyến cáo, chúng ta mới áp dụng chủ yếu là sức căng theo chiều dọc để mà đánh giá sức căng cho người bệnh. Thế thì đánh giá cái sức căng tổng theo chiều dọc thì chúng ta sẽ sử dụng để đánh giá cái chức năng tâm thu toàn bộ của thất trái, và chúng ta sẽ đánh giá cái thay đổi một cách tương đối của cái chiều dài của sợi cơ tim giữa thì tâm thu và cuối thì âm chương, và chúng ta sẽ lấy cái giá trị sức căng tổng đó bằng dựa trên 3 cái mặt cắt tiêu chuẩn từ mỏm, tức là mặt cắt 3 buồng, 2 buồng và 4 buồng. Đây là hình ảnh một người bệnh được chúng ta đánh giá sức căng, tức là trên chức năng tim EF về cả tách côn và Simpson thì hoàn toàn trong giai đoạn bình thường. Tuy nhiên khi chúng ta đánh giá sức căng thì chúng ta thấy rằng là nó vẫn có cái sự khiếm khuyết ở một phần ở cái vùng vách liên thất vùng đáy, và dẫn đến cái sức căng tổng theo chiều dọc là có giảm nhẹ là trừ 18,3%. Một số những cái điểm lưu ý khi mà chúng ta sử dụng đánh giá sức căng để mà đánh giá chức năng tâm thu thất trái thì chúng ta sẽ nó có một số ứng dụng để đánh giá sức căng. Thứ nhất chúng ta sẽ dựa vào cái biểu đồ hình mắt bò, chúng ta thể biết được là cái thay đổi về sức căng này nó nằm trong cái bệnh cảnh nào. Thí dụ như là cái sức căng càng tốt khi mà toàn bộ nó sẽ là màu đỏ, và cái màu nó càng nhạt, tức là cái sức căng nó càng bị giảm. Và thí dụ trong một số những hoàn cảnh bệnh lý đặc biệt, bệnh lý nhất định, thí dụ như trong là bệnh cơ tim nhiễm bột chẳng hạn, thì chúng ta sẽ thấy là sức căng nó sẽ bảo tồn ở vùng mỏm tim, thế còn ở các vùng khác thì nó sẽ giảm rất là nhiều. Hoặc là trong những tình trạng bệnh lý mạch vành do thiếu máu cơ tim cục bộ thì cái sức căng nó sẽ giảm ở cái vùng động mạch vành bị giảm tới máu, hoặc là trong bệnh tăng huyết áp hoặc trong bệnh cơ tim phì đại thì chúng ta cũng có những cái đặc điểm sức căng đặc thù để chúng ta có thể phân biệt giữa các trường hợp. Thứ hai nữa là đấy, như tôi nói, tức là chúng ta sẽ phát hiện được những cái rối loạn chức năng tâm thu thất trái dưới lâm sàng, tức là bệnh nhân chưa hề có triệu chứng gì nhưng đã phát hiện sự giảm sức căng và có thể giúp định hướng điều trị. Và thứ ba đấy là chúng ta sẽ đánh giá là cái sự thay đổi về cái vận động vùng, tức là cái sức căng đó ở cái vùng nào nó sẽ giảm nhiều hơn so với các vùng còn lại để mà chúng ta thể đánh giá. Tuy nhiên cái sức căng này thì nó sẽ phụ thuộc, nó sẽ có một số những cái phụ thuộc nhất định. Thứ nhất là sức căng nó sẽ tùy thuộc vào cái từng cái hãng máy cung cấp, người ta sẽ đưa ra cái giá trị tham chiếu giới hạn bình thường. Vì vậy nếu ở trên một người bệnh mà chúng ta đánh giá sức căng thất trái của bệnh nhân trước sau điều trị hoặc trong quá trình theo dõi thì tốt nhất là chúng ta nên làm trên một hệ thống máy duy nhất. Đấy, bởi vì chúng ta đổi giữa các hệ thống máy nó sẽ có cái sự sai lệch về giá trị sức căng trong cái giới hạn bình thường hay là bất thường. Thứ hai nữa là nó rất phụ thuộc vào cái tay nghề của người làm, tức là với những trường hợp mà chúng ta đã phải làm nhiều ca, người ta ước tính là phải trên 50 ca chúng ta đã làm sức căng thì cái độ mà nó ổn định và nó đồng nhất giữa các ca thì nó sẽ đạt được tốt hơn khi mà chúng ta chỉ làm case by case. Thế nên là chúng ta cố gắng trong thành lâm sàng thì chúng ta có thể áp dụng nhiều hơn khi mà chúng ta làm thì nó sẽ thành một cách thường quy. Và một điểm nữa đó là khi mà đánh giá sức căng thì chúng ta sẽ cần phải có một cái, cũng là một cái viền nội mạc nó cũng phải rất là rõ, như vậy là chúng ta cũng không được lấy nó bị ngắn quá so với cái vị trí mỏm thất trái thì sẽ đánh giá không chính xác, tức là chúng ta sẽ mất cái vùng mỏm. Đấy là những cái thông số mà để chúng ta đánh giá về mặt chức năng tâm thu trái một cách tổng thể. Thế còn trong trường hợp mà bệnh nhân có rối loạn vận động vùng khu trú thì chúng ta cũng có đánh giá chức năng thất trái theo vận động vùng. Thì chúng ta sẽ có cái phần khuyến cáo mà để đánh giá theo cái vùng tưới máu chi phối của động mạch vành, và dựa trên 3 cái mặt cắt là mặt cắt 2 buồng, 3 buồng, 4 buồng thì chúng ta sẽ chia thành các vùng vận động thành tim thành 16 hoặc là 17 vùng. Và chúng ta sẽ đánh giá xem là cái vùng nào mất vận động thì để đánh giá chức năng thất trái. Và trong trường hợp này chúng ta sẽ sử dụng một là phương pháp Simpson, hai là đánh giá sức căng, và thứ ba là chúng ta sử dụng phương pháp 3D để có thể đánh giá được cái chức năng vận động thất trái theo vận động vùng. Phần cuối cùng mà tôi muốn trao đổi đó là cái đánh giá chức năng thất trái dựa trên phương pháp 3D, và phương pháp này cũng đã được đưa vào khuyến cáo của Hội siêu âm tim Hoa Kỳ năm 2015 trong cái việc khảo sát chức năng tâm thu thất trái, với những cái ưu điểm là như chúng ta đã trao đổi, tức là nó sẽ đánh giá được toàn thể cái cấu trúc của thất trái và chức năng toàn thể của thất trái. Vì thất trái nó có cấu trúc là dạng như là một hình viên đạn. Thế nên là và nếu mà chúng ta có cái phương tiện, tức là có một cái máy công cụ 3D ở tại cái phòng siêu âm của chúng ta có thể làm một cách rất là nhanh chóng, và có thể là 9 thông số ở trên kia chúng ta có thể gộp vào đây rất nhiều thông số, mà chỉ cần một cái lát xử lý cắt thì chúng ta có thể thu được rất là nhiều những cái thông tin trên người bệnh. Đây là tôi minh họa đánh giá chức năng tâm thu thất trái 3D trên bằng đầu dò 3D thành ngược trên máy Philips Epic CVX. Thì ngoài ra chúng ta có thể làm trên máy GE hoặc là trên máy Siemens, nếu mà có đầu dò 3D thành ngược chúng ta đều làm được. Và cái quan trọng nhất thì khi mà những cái đầu dò cái thế hệ người đã phát triển cái thế hệ đầu dò thì người ta sẽ phát triển ra là cái độ phân giải của nó rất là tốt, người ta sẽ cố gắng là đẩy cái độ nét và có những cái công cụ để nó thúc đẩy nó tốt hơn nữa cái viền nội mạc để mà chúng ta có thể xác định rõ cái viền nội mạc. Trong đó thì để mà chúng ta đánh giá được chức năng thất trái chúng ta sẽ cần phải acquire một cái hình full volume, tức là ở mặt cắt 4 buồng từ mỏm chúng ta sẽ lấy, tùy chúng ta muốn khảo sát chỉ có thất trái hay cả thất trái và nhĩ trái, chúng ta sẽ lấy tối đa cái cấu trúc 4 buồng đó để mà khảo sát được toàn bộ. Tuy nhiên có một số điểm lưu ý, chúng ta sẽ phải cố gắng là thu nhỏ cái rẻ quạt một cách tối đa để mà chỉ lấy đúng cái cấu trúc chúng ta cần khảo sát, đồng thời là điều chỉnh cái độ depth, độ sâu của cái đầu dò cũng vừa đủ. Thí dụ chúng ta sẽ lấy hết đến các tĩnh mạch phổi đối với nhĩ trái nếu chúng ta muốn khảo sát cả nhĩ trái và thất trái, để làm sao khi mà chúng ta đưa lên chúng ta thu được một cái tần số nó không quá thấp, bởi vì nếu mà tùy theo hãng máy, nếu cái tần số nó quá thấp chúng ta sẽ không thể nào đánh giá được, nó không đủ dung lượng để đánh giá được cái cấu trúc 3D. Và trên máy Philips thì thông thường nó khuyến cáo là trên 16, mà nếu mà tốt nhất ý, là trên 20 Hz thì chúng ta sẽ đánh giá là rất là tốt. Và trên đó thì chúng ta chỉ cần, sau khi chúng ta lấy hình ảnh 4 buồng từ mỏm đẹp và chúng ta đã thu nhỏ cái rẻ quạt, cũng giống như là điều chỉnh cái độ đép, thì chúng ta chỉ cần ấn vào nút full volume, sau đó thì nó sẽ có một cái nút hỗ trợ, đó là nút để tăng cường cái độ phân giải lên, là cái nút HMQ. Đấy thì nó sẽ, sau đó chúng ta sẽ thu được cái hình động như thế này. Sau khi thu được qua một cái hình động như này rồi, chúng ta có thể thu trong vòng 2 hoặc 3 chu chuyển tim, và chúng ta sẽ có thể làm live, hoặc là chúng ta có thể làm trên QLab sau khi mà offline. Làm live cũng rất là nhanh, chúng ta sẽ chọn vào cái hình full volume này và chúng ta sẽ ấn vào cái nút Dynamic Heart Model DHM ngay trên màn hình, và chúng ta sẽ đợi trong vòng 1 phút thì máy nó sẽ tự động xử lý cho chúng ta các thông số. Thế thì sau 1 phút thì máy nó sẽ tự viền nội mạc và nó cũng sẽ cho ra 3 cái hình ảnh của mặt cắt 4 buồng từ mỏm, 3 buồng từ mỏm và 2 buồng từ mỏm. Đấy, và họ sẽ, và sau đó thì sẽ generate ra được cả cái thể tích thất trái cũng như là nhĩ trái, với cái đường viền thay đổi về thể tích của nhĩ trái và thất trái. Chúng ta có thể chọn thất trái không, hoặc là nhĩ trái, hoặc là thất trái và nhĩ trái trong cả một cái đường biểu diễn đó. Và phía bên phải thì chúng ta sẽ có rất nhiều những cái thông số nó sẽ hiện ra đồng thời. Đấy, chúng ta có thể để xem được cái vận động riêng rẽ của thất trái. Và các thông số mà chỉ bằng đấy các thao tác, chúng ta có thể thu được các thông số thể tích thất trái ở cuối tâm chương, cuối tâm thu trên 3D, phân suất tầng máu thất trái. Sẽ đánh giá được cả cái thể tích tống máu, tức là cái mà chúng ta phải đo đạc cả đường ra thất trái, chúng ta phải đo đạc cả VTI, chúng ta mới đánh giá được. Thì ở đây nó sẽ cho ra luôn được cái thể tích tống máu, cũng như là chỉ số tim nếu mà chúng ta sẽ nhập cả vào chiều cao và cân nặng của người bệnh vào. Và chúng ta còn ngoài ra còn tính được cả cái chỉ số khối của thất trái, nó cũng là một cái yếu tố để đánh giá xem là bệnh nhân có tình trạng phì đại thất trái hay không, dựa trên cái giá trị tham chiếu, giá trị bình thường của nam và nữ. Ngoài ra thì nhĩ trái cũng sẽ đánh giá được cái phân suất tống máu của nhĩ trái, cũng như là sẽ có được cái giá trị của cái chỉ số về thể tích nhĩ trái. Khi mà chúng ta viền nội mạc tốt thì chúng ta có thể nhìn thấy được rất là rõ. Đấy là những cái mà lợi điểm mà cái phương pháp 3D mang lại khi mà chúng ta khảo sát cái chức năng tâm thất trái một cách toàn diện, và có thể là làm tương đối nhanh, và chúng ta có thể cho ra rất nhiều những thông số thay vì chúng ta phải đo rất nhiều bước qua các bước như chúng ta đã trình bày ở phía trên một cách truyền thống mà chúng ta đã làm rất nhiều năm. Và trong khuyến cáo năm 2015 của Chuyên Hoa Kỳ thì họ cũng đã đưa ra những cái giá trị tham chiếu trên 3D, siêu tim 3D để đánh giá về chức năng thất trái, cũng như là chỉ số thể tích cuối tâm chương và cuối tâm thu thất trái, để chúng ta có thể tham chiếu xem là bệnh nhân của chúng ta có trong giới hạn bình thường hay không. Và để kết luận thì chúng ta thấy là cái thất trái bình thường thì nó là một cái hình viên đạn như này. Thế nhưng trong thực tế chúng ta sẽ gặp rất nhiều những bệnh nhân với những cái bệnh lý khác nhau, và cái thất trái nó có những cái hình ảnh biến dạng. Thí dụ như bệnh cơ tim giãn, hoặc là bệnh nhân có thể có phình vùng mỏm, hoặc là bệnh nhân có thể bệnh Takotsubo, hoặc là bệnh cơ tim phì đại. Trong tất cả trường hợp đấy chúng ta đều phải khảo sát chức năng tâm thu thất trái. Mỗi bệnh nhân chúng ta đều phải khảo sát chức năng tâm thu thất trái. Và với mỗi khi mà cái quả tim bình thường này thì nó sẽ dễ hơn. Còn khi mà những quả tim nó có những hình dạng biến dạng như này thì những cái phương pháp đơn lẻ về mặt 2D đôi khi nó sẽ không đảm bảo hết được chúng ta để khảo sát một cách toàn diện và đánh giá được một cách chính xác chức năng tâm thất trái. Và trong trường hợp đó, nếu mà chúng ta có 3D thì chúng ta sẽ giúp được cái phương pháp rất nhiều. Và đặc biệt 3D nó cũng sẽ bị một cái hạn chế, đó là mặc dù là đầu dò người ta đã phát minh ra để mà có độ phân giải cao nhất có thể, và người ta vẫn tiếp tục hoàn thiện cái thế hệ đầu dò sau. Thế nhưng mà vẫn có những trường hợp cái nội mạc nó không thể rõ để chúng ta có thể ghi hình được, hoặc là nhịp tim bệnh nhân không đều. Thì trong trường hợp đó thì chúng ta chưa có, nhưng mà khuyến cáo tiếp theo đó là chúng ta có thể dùng các chất cản âm tim trái, tức là chúng ta có thể tiêm cản âm để tăng cái viền nội mạc lên, và chúng ta sẽ có thể khảo sát được một cách chính xác. Đấy là bài trình bày của tôi. Xin trân trọng cảm ơn sự chú ý lắng nghe của quý đồng nghiệp và các bạn. I finish.
Very nice. Thank you so much. Cảm ơn. Any questions for Dr. Lee? Oh, very good. Well, thank you so much, Baksili. We appreciate it. Next up, we will have a lecture from Dr. Nina Rashedi. She is the Echo Lab Director at Northwest Hospital, part of the University of Washington system in Seattle. And she is going to address LV diastolic function assessment, talking specifically about parameters that work and maybe some that don't work. Presentation.
LV diastolic dysfunction refers broadly to abnormalities in myocardial relaxation, compliance, and filling. And it really, echo plays a central role in evaluation of LV diastolic function. My objectives for the next 15 minutes are to review the concepts of diastolic function, discuss simple approach to assessing presence or absence of diastolic function, grading of diastolic function, and what to do in those cases that are exceptions, such as left bundle branch block, mitral annular calcification, AFib, pulmonary hypertension, and also speak briefly on some of the nuances of left atrial strain and diastolic stress echocardiography. In our basic echo and basic parameters that we use to assess diastolic function, the four major parameters are the mitral inflow Doppler, mitral annular tissue Doppler velocity, right ventricular systolic function, and left atrial volume index. The top row here is the mitral inflow, and the bottom row is our medial tissue Dopplers. Mitral inflow is preload dependent, and the mitral E prime, the bottom row, is indicator of myocardial relaxation. As you can see in the top row, the E velocity increases with progression of diastolic dysfunction. So in these cases, and even though we normally use four main parameters in assessing diastolic dysfunction, most of the time we use the mitral inflow velocity and mitral annulus E prime velocity. And using these two, we can assess the diastolic function and filling pressures in almost 80 to 90% of the cases. So let's talk about tissue Doppler. Basically, for assessing medial tissue Doppler, we place the pulse rate tissue Doppler on the medial annulus of the mitral valve. And if the E prime is more than 7, likely you have normal diastolic function. And if the E prime is less than 7, so if the medial E prime is less than 7, likely you have diastolic dysfunction. Also, we do get tissue Doppler involving the lateral annulus of the mitral valve. And normally the lateral is about 25% higher than the medial. But we need to use this with caution, as there's definitely exceptions in this case. The third parameter are your pulmonary pressures and TR velocity of more than 2.8. It really increases your probability of having diastolic dysfunction. And the fourth parameter, and the one that is the least useful, I would say, meaning that it is least specific, is the left atrial size, which we measure using biplane apical views, and we exclude the left atrial appendage. If the volume is more than 34, then that increases probability of diastolic dysfunction. We want to really use caution in using E prime or the tissue Dopplers in cases such as mitral annular calcification, primary pulmonary hypertension, Holcomb pacemakers, one motion abnormalities in that area, and atrial fibrillation. One thing to note is we also measure E to E prime, which is basically the E velocity using the mitral inflow, the E wave, and basically divided by the tissue Doppler medial E prime. And this reflects the left-sided filling pressures. It is normal in patients with normal diastolic function and impaired relaxation, but it does increase progressively with progressive diastolic function. Normal E to E prime is less than 14. So E to E prime of more than 14 is associated with increased filling pressures, and you certainly have diastolic dysfunction in that case. American Society of Echo has two major algorithms for assessment of diastolic function. One basically starts with, if the left ventricle appears normal, then you basically just have to decide, is this normal or abnormal diastolic function? But if the EF is low, or there's myocardial disease such as left ventricular hypertrophy or marked strain abnormality or dilatation, then you have to assume that there is diastolic dysfunction, and then you proceed with grading the dysfunction. Again, the parameters, I have listed the parameters that go into normal versus abnormal diastolic function. So let's just look quickly at this example. We have our mitral inflow pattern at the top and our medial E prime at the bottom. Mitral inflow E to A is 2, but our medial E prime is 12. So that is nice, and it's a good velocity, and our E to E prime is normal filling pressures. So overall, this would be a normal diastolic function, this is the first algorithm that is stated by the ASC, by the American Society of Echo, looking at patients with normal LVEF. And then the second one is the one that basically says if a patient has low EF or has myocardial disease, then you go with the other parameters to grade the diastolic dysfunction using E to A first. So in this case, if we were just to look at this, this is our mitral inflow pattern, and E to A is 0.6. If we just had this, then likely this would be grade 1 diastolic dysfunction. This is an 83-year-old woman with shortness of breath and hypertension. We see that she has thickened myocardium. Her blood pressure is high at 164/78. Her mitral inflow pattern on the top right shows an E to A ratio of 1.5. Looking at the bottom middle, we see that her medial E prime is low at 5, and her filling pressures are high at 30, with an elevated TR velocity. So this patient likely has diastolic function, and based on these parameters, it would be grade 2 or pseudonormalization. Pulmonary veins have not really made it into the algorithms, but we can use these as complementary data for assessment of diastolic grading in healthy patients, such as the one on the left. Systolic weight is less than diastolic with grade 2. It is higher, and then with grade 1, systolic is higher, and then with grade 2 and 3, you have lower systolics again. So I think it's really useful in those patients with impaired relaxation because you have a higher systolic than diastolic. All in all, diastolic grading is a probability game, and the more variables that you have, the more likely you will have diastolic dysfunction. So far, the lessons we've learned is to best check medial E prime velocity first to be sure about abnormal myocardial relaxation. So if the medial E prime velocity is less than 7, then you can assume the patient has diastolic dysfunction, and then you go on to your mitral inflow and start grading the dysfunction. And then you may not have to use all the 4 parameters in assessing diastolic function in most cases. In patients with mitral annulus calcification, we may not be able to use our tissue Doppler so well. So in these cases, like this one, in a patient, 80-year-old who has mitral annular calcification and has had a TAVR, we cannot really count on the medial E prime so much. So we actually use our E to A ratio for assessment of diastolic dysfunction. And in this case, she has grade 1. And you look at her pulmonary vein pattern, her systolic is more than diastolic, which really does help, and her TR velocity is not that high. In a case of left bundle branch block, same thing. We cannot count on our tissue Dopplers, and we go with our E to A ratio. Same thing with pulmonary hypertension. Because of the RV increased pressures, we cannot count on our tissue Dopplers, so we really use our E to A for grading of diastolic dysfunction. And how about the cutoff for E to E prime or filling pressures in patients with AFib? It actually, for AFib, we only use the medial E prime because of limited data, but as opposed to sinus rhythm, that the cutoff is 14. For atrial fibrillation, E to E prime cutoff is 11. So if the E to E prime is more than 11, then the patient has elevated filling pressures. So looking at this 93-year-old with shortness of breath and atrial fibrillation, looking at her E to E prime, it's 20, more than 11. So she does have diastolic dysfunction, elevated filling pressures. And then, some of the nuances that hopefully will be coming into the next set of guidelines for diastolic function are LA strains, and really LA strain helps differentiate between normal versus grade 2. You're going to start hearing a lot about this. It's a much better parameter than left atrial volume index. It's much more standardized and easier to measure. Some food for thought here. We have in our mitral inflow pattern, we have a mid diastolic mitral flow that's called the L wave. And once we see the L wave, it's because of delayed relaxation of the heart, and this is associated with increased filling pressures. So you have a 75-year-old with dyspnea. We look at her mitral inflow pattern. She has an increased L wave. She has an L wave in there. So you can assume she's going to have either grade 2 or 3 because of increased filling pressures. So more pearls, mitral inflow and annular velocities are key. Left atrial volume can be increased in normal settings. E to E prime does not work for those exceptions, such as MAC, left bundle branch block, pulmonary hypertension, you can use E2A for this assessment. And then L wave indicates increased filling pressures and markedly delay in relaxation. We have, some of the newer things are diastolic stress testing, which is basically we use the same parameters that we use to assess diastolic function, but we get them at baseline and peak exercise. You can use supine bike or treadmill for this. And you want to wait just a little bit after exercise so that the E2A won't be so fused from the tachycardia. So we're basically using the same parameters for assessment of diastolic stress echo. So in these cases, we have filling pressures that go up with exercise. If it goes up more than 15, then you do have diastolic dysfunction with exercise. So here we have a patient who, at rest, at the top row, you see a normal E2A inflow pattern. The filling pressures are normal. E2E prime is 10 and your medial E prime is 8. So right now you have normal diastolic function. You make this patient exercise, and basically what you see is that their filling pressure doesn't increase much, and her the TR velocity doesn't go up much. And basically this is a patient who has a normal diastolic exercise testing. So who benefits from this? These are patients with exertional dyspnea, but normal resting echo, especially grade 1, or indeterminate filling pressures. And here we have 2 patients with grade 1 diastolic dysfunction and normal filling pressures at rest. So the top left, you see that the E2A is 0.5. You have normal filling pressures, and when you exercise the patient on the left, you basically see that the filling pressures don't change much. On the right side, you have the same thing, except that at rest you have your grade 1, but when you exercise the patient, the E2E prime significantly increases to 20, and you can see that the patient does have increased filling pressures with exercise. Left atrial strain is used in patients with normal filling pressures at rest, but increased filling pressures with exercise have left atrial strain of less than 33%. And the latest paper out of JACE had shown that left atrial strain of less than 33% predicts increased filling pressures with exercise. Diastolic stress echocardiography has been around for about 2 decades, but it's starting to really be used across the country and across all the, across the globe in the echo labs. Just wanted to thank you so much again for inviting me to this conference. And attached is my Twitter handle. Please feel free to reach out if you have any questions, and I look forward to meeting you all in the future.
Do you have any question? Do you have question from the audience? So nobody asked questions, so we thank you, Dr. Nina Rashidi, and we move forward to Dr. Tomio Chen with the topic evaluation of right ventricle with cases. Thank you.
Tôi là Tomio Chen. Tôi không rành tiếng Nhật nhiều, mà tôi phải nói trong tiếng Anh. Xin lỗi. So I just want to say thank you so much to the moderators and the event organizers for inviting me to give this talk. Today I want to talk about the echocardiographic evaluation of the right ventricle. Again, my name is Tomio Tran. I am a general cardiology fellow at the University of Washington. I'm in my final year of training, and it is an honor to be here today. I do not have any financial relationships or disclosures. So for the objectives today, I'd like to discuss the anatomic challenges of imaging the right ventricle. I would like to review the right ventricular size measurements, as well as review the measurements of the right ventricular function. And I would like to present clinical cases of right ventricular evaluation at the end of this talk. So what are the difficulties with imaging the right ventricle? Well, as you can see from this picture, while the left ventricle is cylindrically shaped, and which provides easy measurements, the right ventricle is shaped like a crescent and kind of wrapped around the left ventricle. The retrosternal position of the RV, it limits the acoustic windows that we can obtain with ultrasound, as you can frequently get shadowing by the sternum and the ribs. When we are looking at the right ventricle, there is a lack of anatomic landmarks on ultrasound, which can make reproducibility quite difficult. And lastly, there's a lack of studies for reference ranges when compared to the left ventricle. By the American Society of Echocardiographic Guidelines, these are all of the acoustic windows that are recommended to obtain various images of the right ventricle. For today's talk, since we're just talking about size and function, I'm limiting our images to these three, which are the apical forechamber, the focused apical forechamber over the right ventricle, as well as the modified apical forechamber. As you can see, the right ventricle the size is sensitive to the angle of acquisition. So if we are looking at this plane here, labeled with 1 and the asterisk, this is the plane that we are hoping to achieve, where the dimension of the right ventricle is largest. However, you can see that if we rotate this plane more and more, we foreshorten the right ventricle. So as you can tell, it's very difficult for physicians and sonographers to obtain the ideal right ventricular image. When we're discussing the size of the right ventricle, most people will describe it qualitatively, and that is in relation to the left ventricle. We would say that normally the right ventricle should be smaller than the left ventricle, with the apex that is more basally located than the left ventricular apex. We'd say it's mildly dilated if it looks visually enlarged, but is still less than the left ventricular area. And it would be moderately dilated if the right ventricular chamber is equal to the left ventricular chamber. And it'd be severely dilated if the right ventricle is larger than the left ventricle. However, the point of this talk is to really say that we should be quantitatively measuring the right ventricle, as this produces better inter-rater reliability and reproducibility. So when we're talking about the size, we frequently use these three measurements. So within the RV focused apical forechamber, we can measure the basal diameter, which is RVD1, the midventricular diameter, RVD2, and then the longitudinal length, which is RVD3. And this corresponds to normal values are less than 42 millimeters, 36 millimeters, and 86 millimeters, respectively. In our laboratory, we frequently just report the basal diameter, which is RVD1, given the poor reproducibility with RVD2 and RVD3. In terms of the thickness of the ventricle, this is best obtained in a subcostal view, where we're looking at the inferior wall of the right ventricle, and we would place an M-mode tracing over the inferior wall and measure the thickness in end diastole. A normal value corresponds to equal to or less than 5 millimeters. There are many methods to evaluate right ventricular function. Likewise, to the size, we can do this qualitatively, where we just compare to the left ventricle, but we have a myriad of different ways that we can measure this quantitatively. And that includes tricuspid annular plane excursion, or TAPSE, tissue Doppler, fractional area change, or FAC, right ventricular index of myocardial performance, or RIMP, longitudinal strain, and 3D ejection fraction. As far as the qualitative measurement, this is very similar to what I described in the size measurements. So we just visually compare this to the left ventricle. Let's say if the left ventricle has mild dysfunction, therefore an ejection fraction of 40 to 50%, then and the right ventricular systolic function looks similar, we would describe that as mild. Likewise, for moderate, corresponds to a 30 to 40%, and severe is less than 30%. But again, we can be more granular with the details and use quantitative measurements. Our first quantitative measurement, and probably the easiest one to obtain, is the TAPSE. And this is obtained by placing an M mode over the lateral tricuspid annular plane, and we measure the longitudinal displacement of the annulus during systole. This is angle dependent. We really want to be in line with that longitudinal motion with our M mode cursor. And this is a very simple measure, and it's very easy to reproduce. However, this really only measures the longitudinal displacement of a single segment, which is the basal segment. And we're using that as a surrogate marker for the entire right ventricular function. A normal value is greater than or equal to 16 millimeters. Similarly, we can do this with tissue Doppler as well, where we place a tissue Doppler pulse wave over the lateral tricuspid annulus, and we measure the velocity during the systole. Very easy to obtain. It's very reproducible. And just like TAPSE, it is angle dependent. The disadvantages of this is that, again, we are really only measuring one segment in longitudinal motion and using that as a surrogate marker for the entire right ventricle. You can see the tracing here. So during systole, we have the annulus that is moving towards the probe, and we are measuring this S prime velocity up here. So that is the tissue Doppler value that we hope to use. A normal value is greater than or equal to 10 centimeters per second. The RIMP, also known as the Myocardial Performance Index, or the TAE index, is something that we don't use very frequently in our lab because it is fairly, there are a lot of variables to obtain here. And essentially, we are just measuring the isovolumic contraction time plus the isovolumic relaxation time and dividing that by the ejection time. There's two ways we can do this. We can do this with a pulse wave Doppler or a tissue Doppler. It's a very reproducible method. However, the disadvantages are that this is unreliable with elevated right atrial pressure and irregular RR intervals. As you can see, or as you can imagine, we are frequently interested in right ventricular function when the right ventricle is abnormal. So frequently, these patients have elevated right atrial pressures. They also may have arrhythmias. So as such, the ASE does not recommend this as a sole measure of right ventricular function. Therefore, we do not frequently do this in our laboratory. Fractional area change, however, is a very easy thing to measure. Essentially, we are measuring a two-dimensional ejection fraction. So we take the end diastolic diameter, end diastolic area in the RV-focused apical four-chamber view, and we also measure the end systolic area, and then we just measure that change. So it's the end diastolic area minus the end systolic area divided by the end diastolic area, then you multiply that by 100% to get the percentage. A normal value is greater than or equal to 35%. This shows pretty good correlation with an ejection fraction as obtained by magnetic resonance imaging, or MRI. However, the disadvantage is that this really simplifies a very complex 3D structure since we are just in one two-dimensional plane. This shows fair inter-observer reliability. However, it is not as good as the TAPSE or the RVS prime in that regard. But we do, in our laboratory, perform this on every echo study. Right ventricular longitudinal strain is very interesting. And just like LV strain, this employs speckle tracking, which is just artifacts within the myocardium and measures that movement during systole. This is more of a global measurement. It is not angle dependent, and it does measure multiple segments of the right ventricle. Again, just like the fractional area change, this really oversimplifies a complex three-dimensional structure. In addition, every program has its own proprietary algorithm, and this limits comparison between different laboratories or even different softwares. There's also an issue with lack of reproducibility because this takes significant processing after we obtain our echocardiographic images. And these reference ranges are also not validated. Therefore, this is not recommended for routine clinical use. Right now, this is used for research purposes and in very experienced laboratories. A normal value is less than or equal to negative 20%. So the more negative, the better. Then I really wanted to talk about three-dimensional echocardiography. So the reason why we really like this is that the 3D volumes are closer to MRI than two-dimensional volumes, but this still underestimates when compared to MRI. The benefit of this is that this includes the right ventricular outflow tract in terms of the size and the systolic function, which we do not get with any of the other measures. The major drawback is that this is very dependent on image quality. Once we move from two-dimensional to three-dimensional imaging, the imaging quality does drop off pretty significantly. So we have to have fairly pristine two-dimensional images. This can also be very costly in terms of time because this requires post-imaging processing. This is also not recommended to be routinely used clinically unless we're in very experienced laboratories. And we do frequently use this in our lab. A normal ejection fraction is greater than or equal to 45%. And then in terms of volumes, a normal end diastolic volume indexed to the body surface area is 87, less than or equal to 87 in males and less than or equal to 74 in females. Additionally, we want to obtain all of these other parameters that I did not talk about, and this includes right atrial pressure, right atrial size, intraventricular septal flattening, as this can indicate pressure and volume overload in the right ventricle, as well as tricuspid and pulmonic valve function, because this can give you the etiology of right ventricular dysfunction. Pulmonary artery systolic pressures are important to obtain, as well as intracardiac shunting. However, given the time allotted for this talk, I cannot spend too much time talking about these. These are reference values obtained by the ASC quantification guidelines published in 2015, and this is just a summary of everything I talked about. So I'd like to discuss some cases. So in case one, this is a 43-year-old woman with pulmonary arterial hypertension. with a baseline pulmonary artery systolic pressure of 70 millimeters mercury. This patient is on therapies for her pulmonary hypertension. In the first image here, we see that this is an MO through the lateral tricuspid annulus. And so we were measuring a TAPC here. And just by this number, the TAPC is quite normal, 1.9 centimeters. However, when we perform 3D echocardiography and image processing on this, we see that the end diastolic volume is 86 millimeters indexed to the body surface area, which is dilated. And then the ejection fraction is about 25%. I hope you can appreciate how much processing that this takes, because we have to align the diastolic and systolic measurements in multiple planes to be able to get this. So this can be a fairly time-intensive endeavor. In our second case, this is a 60-year-old male with hypoxia and chest pain who was found to have a very large saddle pulmonary embolus in their main pulmonary artery. Based on the tricuspid regurgitation jet, the pulmonary artery systolic pressure is around 60 millimeters mercury. In this image here, which is a modified right ventricular focused apical four-chamber, we can see that the apex is actually contracting quite well. However, there is hypokinesis or akinesis of the free wall of the ventricle. And then when we perform a fractional area change, this calculates to be 20%, which is severely reduced. And interestingly, you can see that when you trace this patient actually displays a McConnell sign that you can see on the fractional area change quite nicely. So this patient was consulted on by the pulmonary embolism team for discussion of thrombolytics. Eventually, they decided that because the patient appeared clinically well, they can just anticoagulate and not give thrombolytics, and this patient did well. In our final case, this is a 52-year-old man, with history of methamphetamine use and deep vein thrombosis, who was presenting with dyspnea and lower extremity edema. The patient had a severe acute kidney injury, so they could not perform a CT angiogram of the pulmonary arteries to look for pulmonary embolism. What we found is that there were significant tricuspid regurgitant velocities with a pressure gradient of 58 millimeters mercury. And the basal and longitudinal diameter were significantly elevated. The basal diameter, which corresponds to RVD1, measures about 6 centimeters. So this is a severely dilated right ventricle. I hope you can appreciate on the non-contrasted images, we do not get clear images of the right ventricle. However, our very astute sonographer used affinity contrast. And as you can see here, that there's a very large thrombus near the right ventricular apex that is freely mobile. On the short axis views, you can see that this is a D-shaped septum, which shows flattening during systole and diastole. That indicates severe right ventricular pressure and volume overload. Because of these findings, this was discussed with the pulmonary embolism team, and given the patient's severe acute kidney injury, they thought that a CT pulmonary angiogram would be too risky in terms of causing contrast-induced nephropathy. So they thought that with all of these high-risk features, they would give thrombolytics to the patient. And so they did, and the patient actually did quite well, and they discharged from the hospital. So in summary, the right ventricle is a complex structure that provides challenges for image acquisition and measurements. We should employ quantitative methods for size and function measurements, because this increases reproducibility and allows us to compare serial echocardiograms. And there is no single method that can adequately describe right ventricular function. In general, we would like to use multiple measures. 3D echocardiography and strain are both promising methods for the future. Right now, these are in development and under research, and really only used by very experienced laboratories. But we hope that this will become the standard in the future, as we do think that this provides us with the best global measures of the right ventricle. Here are my references. And I just want to say, Gamang, thank you very much for attending my talk, and thank you again to the event organizers and for inviting me here. If you have any questions, please feel free to email me here. I've left my address on here. And if possible, please email me in English, as my Vietnamese is not very good. So thank you very much.
Comprehensive lecture on showing how to evaluate the right ventricle with many interesting cases. I would like to ask questions from the audience. Dr. Lee, you have a question.
Thank you, Dr. Hoài. Thank you, Dr. Tomio Chen, for the excellent presentation. I'm very interested in the topic of right ventricle echocardiography, and I would like to have two questions for you. Could I?
Dr. Tomio Chen will answer the questions from the audience through email. Yes. So next speaker.
We have the pleasure of welcoming Dr. Marta Alhama Boloto. She is at Harborview Medical Center in Seattle, where she is the Associate Echo Lab Director, but she is also an expert in cardio-oncology, and we're very happy that she can speak on myocardial strain imaging in this session.
Hello, my name is Marta Alhama. I'm a general cardiologist and echocardiographer at the University of Washington in Seattle, and it's my pleasure to be with you today again, reviewing this topic, Guide to Myocardial Strain Imaging. I have no disclosures. So myocardial strain is an index of deformation. It was first developed to get a better understanding of the pathophysiology of myocardial diseases, and then was found to have very high sensitivity to detect LV dysfunction. There are different kinds of strain that we can measure. Here you have 3 of the 4. GLS in red, global longitudinal strain, measures the shortening and lengthening of the myocardium. So during systole, the myocardium will shorten, therefore it's a negative number. In red, in blue, you have global circumferential strain that is also negative in systole because the cavity is smaller during contraction. And then in orange, you have global radial strain that is positive because measures the thickening of the myocardium and therefore is a higher number during systole. Now, global circumferential strain and global radial strain are used mainly for investigational purposes. They are still not reliable enough and reproducible enough for clinical practice, but GLS is a more robust parameter that has many different clinical applications. And from now on in this talk, when I say a strain, I mean GLS measured by echocardiography. When a strain was developed, it was mainly derived from tissue Doppler velocity maps, where velocity was transformed into a strain and a strain rate measurements. And basically what we were doing is measuring the velocity difference between 2 points in the myocardium divided by the distance between the 2 points, which basically was set about 1 centimeter. Because the data was based on Doppler velocities, it depends on the angle of incidence of the Doppler. So it was very important to be well aligned with the motion of the myocardium in order to obtain accurate numbers. Nowadays, however, we measure strain with a speckle tracking. So this is much more accurate because it is based on gray scaled digital images, and it doesn't depend on the angle of incidence as with tissue Doppler. Basically here what we are doing is identify speckles within a region of interest. Speckles are basically generated by the interaction between the myocardial fiber and the ultrasound beam. And the matching algorithm and the tracking algorithm will track those region of interest speckles throughout the cardiac cycle, looking for the best match. With this technique, a strain is calculated as the difference in length or distance divided by the original length, and is expressed as a percentage. Normal strain numbers are -18, and the more negative, the better the systolic function. Now, one of the things we said at the beginning of the talk is that a strain has very high sensitivity to detect LV dysfunction, much more than LV ejection fraction. We've been using LV ejection fraction as a way to measure LV systolic function, and we know that in the general population is a very robust parameter that correlates with outcomes. But ejection fraction does not detect small changes in LV systolic function. This has been studied in many different ways. One of the studies in the panel in your left shows that the variability of LV ejection fraction compared by different methods, 2D, 3D, with and without contrast with echo, is approximately 10%. The other study that you guys have there in your right measures the inter-observer variability of different LV function measurements, 2D and 3D ejection fraction by echo, ejection fraction by cardiac MRI, and GLS by echo. And one can see that the highest variability is seen with 2D ejection fraction. The lowest variability is seen with ejection fraction by cardiac MRI, followed by GLS with echo. And our third best option is 3D ejection fraction. So to detect small changes in LV function, ejection fraction is not the right parameter, and that's why GLS has a significant clinical utility in certain patients. Where this has been used the most is in cancer patients as a way to detect early cardiac dysfunction before symptoms occur. Again, there are many studies looking into that. This is one of many where breast cancer patients with normal ejection fraction and normal GLS at the beginning of therapy were followed during their cancer treatment. And they saw that GLS offered the best added value to any other clinical parameter and echocardiography parameter to predict the development of heart failure and reduction of ejection fraction, with a really good sensitivity and a specificity of 95% to predict ejection fraction reduction of about 10%. The data in the cancer patient population is so strong that actually has made it to the guidelines. These are the 2014 American Society of Echocardiography guidelines, one of the first developed in this matter, where they define cancer treatment-related cardiac dysfunction as a reduction of 10 absolute points in ejection fraction below normal when compared to baseline, but also as a relative change in GLS of 15% when compared to baseline. So one of the things that the ASC guidelines mention is when we see this, we need to repeat the echo in about 2 to 3 weeks to confirm the change. But if we confirm the change, we can say with a significant amount of certainty that the patient may have developed subclinical LV dysfunction. Now, we know that GLS is sensitive to detect small changes in LV systolic function. We also know that this may be very helpful to predict further LV function deterioration in cancer patients. But how do we apply this in the clinical setting? Is this useful in any other way? This is one of my patients from clinic. Is a young man with acute leukemia who has received induction chemotherapy with cardiotoxic agents. In the upper row, you have the pre-chemo echocardiogram with an ejection fraction of 70% and a GLS that is normal, minus 24%. And after the induction chemotherapy, we perform another echocardiogram. He's asymptomatic, and we see that the ejection fraction has dropped 10 points, but it's still within normal limits, so we cannot diagnose cardiac cancer treatment-related cardiac dysfunction based on the definition we just mentioned. But what is more concerning is that his GLS has worsened very significantly. Now it's abnormal, minus 15%, and there is a almost 40% relative change. So what do we do now? Well, first we need to confirm the findings, and we perform another echocardiogram 2 weeks after this one that confirmed the changes. And second, is there any therapy we can give this patient, or is there any therapy we should give this patient to prevent further deterioration? This has been looked at very recently in the SUCOR trial that included patients on anthracycline and other risk factors with normal ejection fraction, and they randomized them to do different arms. The hypothesis of this study is that GLS strain cardiac therapy may prevent further cardiac dysfunction in cancer patients. And they basically started beta blockers or ACE inhibitors if they have heart failure symptoms or significant ejection fraction reduction, if they were in the LVEF arm, or if they had significant changes in the GLS, if they were in the GLS arm. And they titrated these medications to maximum tolerated doses or to target doses. They followed them while they were continuing their cancer treatment, and they saw that in those patients treated according to the GLS, they had less heart failure and less cardiac dysfunction based to their cancer treatment, with a number needed to treat of only 13 patients to avoid one event. So what was also very important is that we were able to prove that GLS not only helps to identify these patients in early stages, but we also can identify a very good window of opportunity to start heart failure therapies in order to prevent further cardiac deterioration and also to help the patients complete the cancer treatment safely. So we've seen that is helpful in cancer patients, and is probably where there is more evidence and is more established in clinical practice, the use of GLS. How about other patient populations? So another one that I think is quite helpful is in those patients with LV wall thickness, increased LV wall thickness of unknown etiology. Strain can help us to differentiate between hypertensive cardiomyopathy and other causes of LV wall thickness, of increased LV wall thickness. For example, in panel A, we have a patient with hypertrophic cardiomyopathy with significant worsening in the strain that affects only the septum. In panel B, we have a patient with Fabry disease that characteristically affects the strain in the inferolateral wall. But where a strain is probably more helpful just based on the prevalence of the disease is in patients with cardiac amyloidosis. So this is another of our clinic patients. Is a lady with multiple myeloma. In echo has a quite significant LV wall thickness. And then in the strain, we have this very characteristic pattern with abnormal global longitudinal strain, but apical sparing or cherry on top. This is very characteristic of cardiac amyloidosis. There was nothing else on this patient's echocardiogram that helped us differentiate this from other causes of hypertrophy, such as hypertensive cardiomyopathy or hypertrophic cardiomyopathy. So as you may be aware, cardiac amyloidosis is an infiltrative disease, it significantly has a significant worse prognosis compared to other causes of increased LV wall thickness, and there is a specific treatment for that. So it's important that we can recognize these patients as early as possible, and a strain can help with that. In normal patients, there is always an apical to basal strain difference that is about 2%. but this is exaggerated with cardiac amyloidosis. If it's 8% or more, that is suggestive of cardiac amyloidosis. There are different scores that have been developed, such as the relative regional strain ratio that takes into account the sum of apical strains divided by the sum of basal and mid strains. If this ratio is 1 or higher, this is quite suggestive of cardiac amyloidosis. Similar with the ejection fraction to strain ratio, when it's higher than 4.1, is also suggestive of cardiac amyloidosis. But if you want to remember something, is this specific bull's-eye chart pattern with cherry on top of apical sparing suggestive of cardiac amyloidosis. Other clinical applications, well, strain has been used with investigational purposes, looking at the left atrium and right ventricle strain as a way to measure those chambers' function. But where we have more data and where we could potentially apply this clinically earlier than in other chambers is in patients with aortic stenosis. Well, first, there is a really well-known association between aortic stenosis and cardiac amyloidosis in this study, where they look at the prevalence of cardiac amyloidosis in patients referred for TAVI for their severe aortic stenosis. About 16% had TTR cardiac amyloidosis. And this can help to guide not only the treatment for aortic stenosis, but as we said before, to give patients the specific treatment to address their TTR. Outside of this association, it has been seen that in patients with abnormal GLS who have asymptomatic severe aortic stenosis or moderate aortic stenosis, they tend to develop symptoms earlier in their stage of disease, and they have higher mortality than those patients with a normal GLS. So some have proposed that maybe we can re-stratify these patients and reclassify them according to the GLS, so they may benefit from early valve replacement compared to those with normal GLS. So we have reviewed the main clinical applications of GLS. Now let's talk very briefly about some of the things we have to take into account when we are processing these images. These two papers by Negishi and Collier are really good reads. They cover this topic extremely well with a lot of graphic material and videos that you may find helpful. The first step is make sure that we have high quality images. We're gonna need 3 apical LV views of the 4, 2, and 3 chambers. And we have to focus on optimizing the endocardial as well as the wall visualization. Make sure that we are seeing the apex well, that there is no foreshortening. So here you have 3 examples. Panel A shows an optimal acquisition where we see the apex and the endocardium really well. B is an okay acquisition. We may be able to process, maybe rejecting a couple of segments with some artifact in the apex. And panel C, where we all would agree that is suboptimal for a strain analysis because we don't see the endocardium and we are missing many segments. Once we have an adequate image quality, then we have to make sure the region of interest that we are analyzing is also adequate. So it has to include the myocardium, but it cannot be too thin or too wide. If it includes the pericardium, as you see there in panel A, you are going to worsen the GLS falsely. Also make sure it's not tracking other structures, such as the papillary muscles, as you see in panel B and C. And then identify your landmarks. So we mentioned the apex before, but also the mitral annulus. It's not uncommon that the post-processing algorithms go below the mitral annulus. It has to go above. And also sometimes they go very deep into the aortic root, as you see there in panel E. And we have to adjust. So it just goes into the LVOT without going deep into the aortic root. So in the center in green, you have an adequate image quality picture. You also have an adequate region of interest that includes the apex. It doesn't include the pericardium. It's about the mitral annulus, and it's probably going to be a very accurate strain analysis in that particular patient. And then finally, we have to evaluate the tracking quality. This can be particularly challenging in patients with irregular heart rate. And actually, if it's really irregular, we may not be able to process. If you have segments that have very abnormal strain waveforms, as you said there, see there in panel B, only affecting that segment, it may be helpful to compare with the wall motion. Wall motion and longitudinal strain are not the same, right? But if you have a normal wall motion and you just have one segment that is off, then go back to the tracking and see what is happening with that segment. So in that particular example, the apical anterolateral segment is tracking the pericardium. When we adjust, as you see in panel C, all the curves in panel D are more homogeneous. Now, many say this is too difficult for a BC Echo Lab. We don't have the time to strain, but actually this has been also looked at. This study looked into how much it takes to train people to do this and how long it takes to process images. So they took 3 novice group of people, cardiology fellows, cardiac sonographers, and students that were not familiar with ELS. They training with a specific model, and then they have them analyze 100 patients over 3 months, and they compare their numbers with the one of experts to assess for competency. What they saw is that by the time that they achieve 50 analysis, they are very similar to the expert competency, and the learning curves are very similar to the 3 groups. And they also saw that with training, they are able to shorten the amount of time required for analysis of these images, about 60 seconds per patient, very similar to what the experts do. So in the right patients, is doable even in the BCS Echo Lab. And if you apply this in the right patients, thinking into the clinical implications is definitely something that is worth it to perform. So with this, I finish my talk. I hope that you like the topic, that you found this helpful. I just want to emphasize a few take-home points. First, a strain, and especially global longitudinal strain, is a measurement of myocardial deformation that has high sensitivity to detect LV systolic dysfunction. It can help monitoring cancer treatment patients to diagnose cardiotoxicity at early stages, so we can start cardioprotective therapy. It can also help to differentiate other kinds of cardiomyopathy, such as cardiac amyloidosis and potentially stratified aortic stenosis patients. And it's easy to learn, it's rapid to implement in a BC Echo Lab, but it is key to check adequate image quality and post-processing to assure accurate strain measurements. Thank you very much for your attention. Please don't hesitate to contact me if you have any questions.
For a very excellent presentation about guide to myocardial strain imaging.
Hello. My name is Janie Savla, and I'm currently an acting assistant professor at the University of Washington. I'd like to thank you for welcoming me to give a talk today on cardiomyopathies with increased wall thickness. I have no disclosures relevant to today's talk. Just to go over some objectives of today's talk. First, we'll talk about measurements of left ventricular wall thickness. Then we'll move on to a differential diagnosis of increased left ventricular wall thickness. And finally, we'll talk about disease-specific features. So beginning with echocardiographic measurements of left ventricular wall hypertrophy. There are multiple ways to measure the LV wall thickness on an echocardiogram. The most common measurements are performed off of M mode or 2D measurements, though 3D measurements can also be performed. Measurements should be performed at end diastole, in which the frame before the mitral valve closure or the frame in which the ventricle is at its largest is selected. The posterior wall is measured in the peristernal long axis or in the peristernal short view at or just immediately below the level of the mitral valve leaflet tips, which is approximately at the junction of the basal and the mid-inferolateral segments. The septal wall is measured at the boundary between the basal and mid-anteroseptal segments. All 3 methods of measuring wall thickness on echocardiogram have significant advantages. M-mode and 2D measurements have great spatial resolution, while all three versions of the measurement have great temporal resolution. Interestingly, both M-mode and 2D measurements make geometric assumptions, which is not needed for 3D measurements. And all of these measurements are a bit dependent on the person taking the measurements. All three methods also have disadvantages. So M-mode measurements can be somewhat limited when there's an asymmetric disease process happening, as they represent a single line through the ventricle. The measurements can also have some variability and are operator dependent. And the picture on the right of the screen depicts that measurements can be taken at different locations in the heart, which sometimes can make those measurements inconsistent between different providers. Also, it can sometimes be difficult to ensure that you're measuring in the exact correct plane when you're using M-mode measurements. In terms of the disadvantages of 2D measurements, oftentimes we are using measurements that are not in the recommended locations. For example, measurements are typically being made in the 4-chamber view at the thickest part of the ventricle, rather than a standardized location for measuring. And with 3D measurements, oftentimes overestimation can be an issue. Moving on, we'll briefly talk about a differential diagnosis of left ventricular hypertrophy. So there are a number of conditions that are associated with left ventricular hypertrophy. All of these conditions have their own definitions, and they all lead to different versions of LV wall increase. So for example, obesity is defined as having a BMI greater than 30, and oftentimes can result in increased LV mass due to changes in hemodynamics, metabolics, and inflammatory changes that are seen in this disease state. Hypertension is a common cause of increased wall thickness. It's typically defined as having a systolic blood pressure greater than 130 or a diastolic blood pressure greater than 180. It results in pressure overload that leads to concentric hypertrophy. Something similar can be seen in folks that have severe aortic stenosis, where the pressure overload leads to concentric hypertrophy. This differs from conditions like aortic regurgitation or mitral regurgitation, in which the issue is really volume overload, which can result in an eccentric hypertrophy. There are also conditions or diseases of the myocardium, such as hypertrophic cardiomyopathy, which is often defined as having a wall thickness greater than 15 millimeters in one or more segments without any other associated explanation, such as hypertension or aortic stenosis. And this is a genetic condition that often leads in asymmetric hypertrophy. There are also a number of other sort of genetic conditions or infiltrative disorders that are associated with left ventricular hypertrophy. Sometimes those conditions can also have other anomalies associated, such as systolic dysfunction or valve dysfunction. And there are over 40 different conditions that fall into this category. And finally, there's a variant of normal, which is an athlete's heart. And that's usually an individual who's training or participating in high intensity activities for greater than 10 hours a week for over 10 weeks. And depending on the type of activity they're participating in, they can be making use of isometric or isotonic muscle contractions, which can result in hypertrophy, which can either be concentric or eccentric. We'll move on to talking about disease-specific features. Hypertensive heart disease is quite common, and it's characterized by LV hypertrophy, diastolic dysfunction, ascending aortic dilatation, aortic valve sclerosis, mitral annule calcification, left atrial enlargement, and or atrial fibrillation. It's typically defined as having concentric left ventricular wall thickness with a non-dilated chamber. And generally, it's very symmetric. So this involves the basal posterior wall in addition to all of the other segments. And typically the measurement is greater than 11 centimeters. So this image is a real life echo from a patient that I saw yesterday who has hypertensive heart disease. and the wall thickness, which can be difficult to ascertain without a measurement in this study, was about 1.2 to 1.3 centimeters in both of these segments. Hypertrophic cardiomyopathy is defined as having unexplained LV hypertrophy. It is typically thought of when the hypertrophy is greater than 15 millimeters. It's a fairly common disease with a prevalence of 1 in 200 to 1 in 500. It's considered a disease of the sarcomere, with 50 to 80% of all genetic mutations occurring in myosin binding protein C, or MYH7. It's associated with a number of abnormalities, including asymmetric hypertrophy of the left ventricle. It typically is associated with normal LV systolic function. Typically, diastolic function is impaired. Some patients can have a dynamic subaortic LV outflow tract obstruction, and this condition can also be associated with mitral regurgitation. There are multiple patterns of left ventricular hypertrophy and hypertrophic cardiomyopathy, and these are typically identified on the 2D imaging planes. Although in the peristernal long axis view, we should be paying attention to the posterior basal wall, especially between the papillary muscle and the mitral annulus, as it's typically spared in folks with hypertrophic cardiomyopathy and thickened in patients with cardiomyopathies from other causes like hypertension and infiltrative cardiomyopathy. So similar to the picture that we saw before and some pictures that I'll show you later. And then 2D guided M-mode tracings can be particularly helpful for measuring the septal wall and the posterior wall using both the peristernal long and peristernal short axis views, but care must be made to make sure that you're avoiding inclusion of the RV trabeculations in the septal wall thickness. The picture on the left of this screen shows the different patterns of left ventricular hypertrophy and hypertrophic cardiomyopathy. The first image is of the reverse curve phenotype, which typically results in a septal or a mid-septal LVH pattern, and the LV will take look like a crescent in that particular phenotype. The most common phenotype that we're seeing is image number 3, which is the sigmoid septal pattern of hypertrophy, where there's a prominent basal septal bulge, and that often results in an ovoid LV cavity shape. And finally, another variant that we are seeing and recognizing in more and more is the apical hypertrophy, in which the LV cavity can appear like an ace of spades. So just to give you some real life examples, this is a patient with sigmoid septal HCM. And typically in this condition, the peristernal long axis view can help define the relationship between the pattern of septal hypertrophy and the LV outflow tract. This is the reverse curve phenotype of HCM. And here you can see that the LV has more of a crescent shape. Sometimes what we can see, which is a normal variant, is a septal knuckle, and that typically can occur in older individuals. And that is not considered a pathologic or phenotype such as HCM, but is most likely due to increased tortuosity of the aorta, resulting in more acute angles between the basal septum and the aortic root. And so care has to be made to make sure that we're not dealing with just a variant of aging, and that we are actually indeed dealing with hypertrophic cardiomyopathy. And finally, this is a picture of someone who has apical HCM, where you can see that the LV cavity has that ace of spades appearance. Another important feature of hypertrophic cardiomyopathy can be the LV outflow tract obstruction. Patients can be phenotyped into 3 different buckets. The first is the folks with non-obstructive hypertrophic cardiomyopathy, which means that there's no outflow tract obstruction seen at rest or with provocation. And we use a cutoff of 30 millimeters of mercury for that. There are folks that have obstructive HCM, where they develop a resting gradient greater than 30 millimeters of mercury. And there are those that have latent obstruction or provocable obstructions, in which they can mount gradients greater than 30 millimeters of mercury, but it's often mounted with exercise or other maneuvers. In those patients that have LV outflow tract obstruction, systolic anterior motion of the mitral valve results in a mid-systolic closure and coarse fluttering of the aortic valve leaflets, and this is often associated with mitral regurgitation. And oftentimes the obstruction is dynamic and occurs in late systole and is altered by loading conditions. So it can appear different echo to echo depending on the patient's loading conditions. And on this image on the left, I'm showing you a picture here where we can see some systolic anterior motion of the mitral valve, where we can see that the mitral valve sort of bends towards the septum. In terms of the Doppler evaluation of LV outflow tract obstructions, this can help determine the presence, location, and degree of this obstruction. Typically, pulse wave Doppler is performed from the apex and moving slowly towards the base with progressive recordings at each step. And CW from the apical approach typically shows a late peaking jet with a high velocity. So here on the left, you see an image of that. Outflow tract obstructions and mitral regurgitations can often both be present and difficult to separate. There are some things that can help you separate those two different waveforms. The first is that the mitral regurgitation typically starts earlier and ends later in systole, and it has a very high velocity all throughout the ejection period. So it has more of that curved shape because of that. And it typically is higher velocity than the LV outflow tract obstruction velocities. And then LV outflow tract obstructions typically start later in systole. So we think of this as a phenomenon of late systole, and it typically peaks at the end or near end ejection. So you can see here, we sort of see a late peaking a jet, which helps us determine that this is an LV outflow tract jet. We can also assess for latent obstruction on our transthoracic echoes. It's helpful when patients have a PVC. This often results in an increased degree of obstruction on the post-PVC beat due to increased contractility. We can also employ tactics like Valsalva, which help increase obstruction by decreasing preload. The caveat to Valsalva is that sometimes it can be difficult to perform simultaneous echo measurements while a patient is performing a Valsalva maneuver because of the change in the cardiac position and how the lung can interfere with our imaging when the patient performs this maneuver. So it does take some practice to get this. So on the left of the screen, I'm showing you an image from the same patient that I showed with the last slide, in which they're performing a Valsalva. And on the last slide, their gradient was under 30 millimeters of mercury. And here we can see that it is over 30. So this person has a latent obstruction. If Valsalva is difficult to perform, a different approach is to do this post-exercise. That's the optimal time to assess for a latent obstruction. And dobutamine is not recommended as an agent to try to elicit latent obstruction, as obstruction can be elicited in individuals who have normal LVs. A number of our restrictive cardiomyopathies can also result in left ventricular hypertrophy. And these conditions are typically defined as having a non-dilated, thick-walled left ventricle with normal function and abnormal diastolic function. Sometimes we can also see RV, free wall thickening, biatrial enlargement, moderate pulmonary hypertension, and elevated RA pressures. Just a couple examples of these types of cardiomyopathies. Amyloid, which is pictured on the left of this screen, typically presents as having a speckled myocardium on echocardiogram, which you can see in this image. It can also affect the systemic valves, the conduction system, and the coronary microvasculature. Hemochromatosis is another condition that we think of that's often associated with conduction disease, in addition to a dilated or restrictive cardiomyopathy. And then Anderson-Fabry's disease can result in symmetric or asymmetric left ventricular hypertrophy, conduction defects, and late aortic root dilatation. This image on the left is now a patient with Anderson-Fabry's disease. In addition to these features, these patients can sometimes also present with a hyperechoic endocardium, which is actually seen in this image, particularly on the septal wall. So in conclusion, measurements of LV wall thickness should be performed between the basal and mid segments at end diastole. The differential for LV hypertrophy is broad, but knowledge of the basic pathophysiology and associated echo findings can help narrow the differential. Just to use some of the examples that we talked about that are fairly common, hypertensive heart disease is associated with concentric hypertrophy, and other echo findings known to be related to hypertension, such as aortic dilatation. Hypertrophic cardiomyopathy should be considered when the hypertrophy cannot be explained. There is asymmetric hypertrophy, particularly segments measuring greater than 15 millimeters and sparing of the posterior wall. And there are many other disease states associated with LV hypertrophy. Unique features like a speckled myocardium or hyperechoic endocardium can help you narrow the differential. Well, I appreciate your time and attention, and I hope that if you have any questions that you are able to reach out to me through the conference organizers. Thank you again for the opportunity to spend some time with you today.
Presentation. Next speaker, I would like to introduce Dr. Gary Huang. You all know Dr. Gary Huang from last year. He also took part in our National Heart Conference. This year, Dr. Gary Huang will speak about echocardiography pitfalls in the evaluation of mitral and aortic prosthetic valves. Thank you.
Hi everyone, my name is Gary Huang, and today I will discuss the echocardiographic pitfalls in the evaluation of prosthetic aortic and mitral valves. So I'll start off by discussing the 2D echocardiographic assessment of prosthetic aortic and mitral valves and pitfalls. And then I'll discuss aortic valve prosthesis and pitfalls, and then mitral valve prosthesis and pitfalls. So for 2D echocardiographic assessment of prosthetic valves, we have to look at the motion of the cusps, the leaflets, or the occluder. We should then assess for the presence of calcification or any abnormal structures on the various components of the prosthesis. And then we need to look at the valve sewing ring integrity and motion. So this is an example of a bileaflet mechanical valve. This is a stented bioprosthetic valve, and then a transcatheter bioprosthetic valve. And this is just an example of a TEE, transesophageal echocardiographic assessment of a normal mechanical bileaflet mitral valve. So this is an example of a 2D image, 3D image, inflow color Doppler, and 3D color Doppler. And this is that assessment with the valve open and closed. And this is how it looks like in real time. So this is, again, an example of TEE assessment of a bileaflet mechanical valve opening and closing. You can see color Doppler here as well. One of the biggest problems in assessing prosthetic valves is artifacts. Prosthetic materials cause numerous ultrasound artifacts, and the biggest problems are the acoustic shadowing, reverberations, refraction, and mirror artifacts from these valves. And multiple and sometimes off-axis views must be used when assessing these valves to overcome these problems. And because of the bright echogenic material of the prosthetic valves, at lower gain settings, the valves are better visualized. This is an example of a mechanical valve. You can see the metal leaflets here, annular stent, and the sewing ring. This is just a zoomed up view of the sewing ring. And so the artifacts of a mechanical aortic valve include acoustic shadowing and reverberations, which you can see with both 2D TTE and TEE. And it's shown here with the yellow arrow with a peristernal long axis view here. And in apical 4-chamber view here, you can see significant shadowing. And the posterior portion of the valve appears shadowed by TTE, whereas the anterior aspect of the valve, here, here, and here, is shadowed on TEE. You can see the clicks of the valve opening and closing as well. The artifacts of a mechanical mitral valve are similar. You see significant acoustic shadowing and reverberation artifacts. The left atrial side of a prosthetic mitral valve is obscured from shadowing from the TTE approach. You can see here significant shadowing, and here as well. And so it's difficult to assess for regurgitation, thrombus, pannus, or vegetation in these assessments. However, TE, here, you can get a much better view of the left atrium, here and here, with the valve opening and closing. These are the components of a bioprosthetic valve. So you can see the stents, and then followed by the polyester ring and stent posts. And here you can see the stent here, silicone base ring, the polyester covering as well, and then the pericardium covering that. And then these are the transcatheter aortic valves. So this is an Edwards sapien and a core valve here. So for stented valves, stented bioprosthetic valves, the ultrasound beam should be aligned parallel to flow to avoid shadowing artifacts of the stents and the sewing ring. So these white arrows are just pointing to acoustic shadowing from the valve. These white arrows here are pointing to the struts of the valve, and the sewing ring is right here. And again, these are the struts and significant acoustic shadowing. Not quite as significant as mechanical valves, but still present. Microbubbles and cavitations are often seen in prosthetic valves by echo, and they're rounded, strongly echogenic, fast-moving echoes. And they are usually present during closing or opening of a mechanical valve, usually mitral. It's of unclear significance, but they can be mistaken for vegetation or thrombus, leading to additional unnecessary tests. Similarly, we can also see strands, which are thin, mildly echogenic filamentous structures, and these strands move independently from the valve, and they're located upstream to the valve, very similar again to vegetation location. And they can be observed in mechanical and bioprosthetic valves. And similarly, they're of unclear clinical significance. Right, next, and where I'll focus most of my time, are Doppler echocardiographic pitfalls. And so when you're assessing for valve hemodynamics, you have to assume that all normal functioning prosthetic valves have some degree of obstruction just because of the prosthetic material in the valve. And all mechanical prosthetic valves have built-in prosthetic regurgitation or washing jets, which are thought to reduce the likelihood of thrombus formation. So this is an example of washing jets. You can see here, very mild regurgitation jet back into the left atrium here. However, periprosthetic regurgitation, which is regurgitation outside of the valve, which you don't see here, is always pathologic. And the hemodynamics, the parameters are different based on the prosthesis type and size, so it's very important to assess each individual prosthetic valve. So next, let's look at prosthetic aortic valves. And whenever you're assessing a prosthetic aortic valve, you should be looking at these parameters. So peak velocity, mean gradient, prosthesis continuous wave jet contour. You should take a look at the acceleration time, the Doppler velocity index, or the DVI, the effective orifice area, and the indexed effective orifice area, and regurgitation, if it's there, where it's coming from, and how severe it is. So measuring the peak velocity and mean gradient is often very difficult, especially if you're trying to measure the highest velocity and peak gradient. There are a variety of views you can use. They include suprasternal notch view, the right supraclavicular view, right parasternal view, subcostal, and apical views. And so if the peak velocity and or mean gradient is lower than what you'd expect, then you should interrogate the aortic prosthesis with CW Doppler from multiple windows. And typically the apical, the right parasternal, or the suprasternal notch views most frequently give you the highest velocities. And these are just spectral Doppler images showing that concept. So this patient has a bileaflet mechanical aortic valve, and it's being assessed with CW Doppler. So from the apical window, you see a peak velocity of 2.9 meters per second and mean gradient of 21 millimeters of mercury. And this is from the apical window. From the right parasternal window, you see a peak velocity of 4.4 meters per second with a mean gradient of 43 millimeters of mercury. So it goes to show how important it is to use multiple views because you can get a significantly higher velocity and gradient. Other components that are important to assess is the continuous wave jet contour and the acceleration time. So whenever you have a rounded jet contour or an acceleration time greater than 100 milliseconds, then it's consistent with pathologic obstruction. If you have a pointed jet contour and a jet acceleration time less than 100 milliseconds, then it's either normal, functional obstruction, or pathologic regurgitation. Any valve that has a high peak velocity and mean gradient doesn't necessarily mean it's obstructed. It can be non-obstructed due to what we call functional obstruction and pathologic regurgitation. And anytime a peak velocity and mean gradient across a prosthetic aortic valve is normal, it doesn't necessarily mean that valve is normal as well. It could be obstructed if it's in a low flow state. As far as measuring the acceleration time, you should place one caliper inside the opening click to the peak velocity. And so again, acceleration time is time from the onset of flow to maximal velocity. These are some examples of jets showing a patient with normal aortic valve, and this is a patient with an obstructed prosthetic aortic valve. You can see the acceleration time for the normal patient is short and a low velocity and a triangular contour of the jet, whereas this patient has a prolonged acceleration time, very high velocity, and the contour is rounded. So with these prosthetic aortic valves, we should also look at the Doppler velocity index or the dimensionless index. And so this index is equal to the velocity at the LVOT divided by velocity through the prosthetic valve, which is also similar to the VTI in the LVOT divided by the VTI of the prosthesis. And it's a really good number to look at because it's independent of flow conditions and it's independent of the prosthesis size. So normal values, surgical aortic valve should be greater than 0.25 and TAVR should be greater than 0.5. So it's the same patient. You can see here that the DVI is 0.4 or greater than 0.25. Short acceleration time, low gradients and velocities. Whereas this patient has a prolonged acceleration time, rounded jet contour, high velocity, high mean gradient, low DVI, and high acceleration time. And so this is obstructed versus a normal valve. And next, we have the effective orifice area, which is crucial in the evaluation of a prosthetic aortic valve. And it's calculated using the continuity equation. So the LVOT diameter is measured in mid-systole from the parasternal long axis view in a zoomed mode from inner edge to inner edge. And the cross-sectional area is calculated using this diameter and the VTI through the LVOT, which gives you stroke volume. and then you divide that by the VTI through the prosthetic valve using CW, and then you get the prosthetic aortic valve area. The indexed aortic valve area is basically just the EOA divided by the body surface area. And the index number is essential for differentiating pathologic versus functional obstruction, for example, high flow, pressure recovery, or patient prosthesis mismatch, which I'll talk about soon. As far as numbers for what makes a mechanical and biologic aortic valve abnormal is you have high peak velocity, high mean gradient, low DVI, small effective orifice area, rounded jet contour, and greater than 100 milliseconds. Potential pitfall is oftentimes when we look at these prosthetic valves, we assume that if the mean gradient and peak velocities were high, then the valves are abnormal and we don't need to look at anything else. Well, in this case, the other parameters are necessary. For example, I just mentioned DVI, effective orifice area, acceleration time, etc. And that's because the peak velocity and mean gradients are more affected by flow, including if a patient has concomitant significant aortic regurgitation compared with the other parameters. Another pitfall is if something doesn't add up. For example, if the peak velocity is high, the DVI is low, but the contour of the jet is triangular and acceleration times less than 100 milliseconds, then perhaps you're putting the sample volume for the LVOT assessment in an incorrect location. Similarly here, if you have a high peak jet velocity and rounded contour, high acceleration time, but DVI is greater than 0.3, then again, perhaps your sample volume is incorrectly placed. So you have to adequately place the pulse wave sample volume when you're assessing these valves. And so the sample volume should correctly be in the blue, or 0.5 centimeters from the prosthesis. If the sample volume is in the yellow, or the region of flow acceleration, then it's definitely inaccurate. It would overestimate the peak velocity and the VTI and have a number that's incorrect. So again, accurate assessment of the LVOT diameter, mid-systole from the peristernal long axis view, from inner edge to inner edge. And it's important to measure this directly, to measure this well, because this number is squared when you're looking to use it in an EOA calculation. So another potential pitfall is not taking pressure recovery into account. So the CW Doppler may lead to an overestimation of gradients and underestimate the effective orifice area. Most commonly, this occurs with small bileaflet mechanical valves and small aortas. And when you do have pressure recovery, then you may need to further assess the valve with TEE, catheterization, and or CT imaging. Patient prosthesis mismatch occurs when the effective orifice area of the prosthesis is too small when you're comparing it to the patient's body size. And it results in abnormally high gradients, for example, gradient greater than 20 millimeters of mercury. And it's determined by the indexed effective orifice area, and a severe patient prosthesis mismatch if it's less than or equal to 0.65 centimeter squared over meter squared. So this occurs more often in smaller prosthesis, but it can occur with any prosthetic size. And severe patient prosthesis mismatch has been associated with worse outcomes. Some pitfalls are this patient prosthesis mismatch is oftentimes overestimated in obese patients, and a low flow state may actually lead to an underestimation of patient prosthesis mismatch. All right, lastly, I'll discuss prosthetic mitral valves. It's a little more straightforward than the aortic valve, but right off the bat, the potential pitfall is you're not assessing the patient's blood pressure and heart rate. And you have to actually look at these values and incorporate them into the assessment initially. And also, you should be looking at the left and right ventricles and left atrium as well. And the peak early diastolic velocity, or the E velocity. There's prosthesis dysfunction of some sort, either obstruction or regurgitation if the value is greater than 1.9 meters per second. We should also focus on the mean gradient, pressure half time, VTI ratio, effective orifice area, pulmonary artery systolic pressure, and regurgitation. So if you recall, for the aortic prosthesis, DVI, which is equal to VTI through the LVOT over VTI through the prosthesis, the lower the ratio, the more obstructive the valve. While in this case, for mitral prosthesis VTI ratio, it's flipped. So it's VTI through the prosthesis over VTI through the LVOT. So the higher the number in this case, the more abnormal the flow, either significant obstruction or regurgitation. And the number cutoff is 2.2. So VTI ratio greater than or equal to 2.2 indicates prosthesis dysfunction. Pressure half time is also important to measure, and pressure half time greater than 130 milliseconds most likely indicates pathologic obstruction. If it's less than that, it could be normal functional obstruction or pathologic regurgitation. Anytime the pressure half time is less than 130 milliseconds and the VTI ratio is greater than 2.2, then it most likely indicates pathologic regurgitation. And one of the pitfalls is that the mitral prosthesis effective orifice area has to be calculated using the continuity equation and not the pressure half-time method. And another potential pitfall is that the continuity equation is not valid in patients with significant aortic regurg or mitral regurgitation. And here's our some Doppler parameters of the prosthetic mitral valve. And you can see here, suggestive of significant stenosis, are high peak velocity and mean gradients, high ratio of VTI through the prosthetic mitral valve over VTI of the LVOT, small effective orifice area, and high pressure half time. And so we, in these cases, we have to assess for possibilities of increased flow, increased heart rate, or a patient prosthesis mismatch, which are all potential downfalls, potential pitfalls if you miss it. When you're assessing mitral regurgitation, you should be integrating a variety of approaches to assess mitral regurgitation because it's much more difficult to assess compared with native mitral regurgitation. And one of the biggest problems is the acoustic shadowing, which is more of an issue for prosthetic mitral valves compared with aortic valves. So you can see here significant shadowing of the regurgitation jet in the peristernal long, as well as the apical four-chamber views. Lastly, these are just some videos showing that. So you can see here, just play all of them. You can see a two-chamber view on TTE showing significant shadowing of the left atrium, so the jet's basically impossible to see. Whereas on TEE, you can see the left atrium very well and significant mitral regurgitation coming up this way. Okay, that's all I have. Thank you very much. Please feel free to email me at garysh123@hotmail.com and follow me on Twitter at Gary S. Huang. Thank you so much again for your attention.
We're very appreciative that Dr. Huang is able to give us that talk on prosthetic valves. I'd next like to introduce Dr. Hete Bahairu. She is our Cardiac Advanced Imaging Fellow at the University of Washington in Seattle. And she has been studying with us, but previous to that, she has trained at UCLA and then spent a year examining echocardiography and the chance to increase the use of echocardiography in Ethiopia. And she has some wonderful insights about that. But today, we have asked her to address stress echocardiography, particularly in the severity of valve diseases.
My name is Atabahiru. I am an advanced cardiac imaging fellow at the University of Washington, and I will be discussing stress echocardiography in the assessment of severity of valve diseases. I will start with an overview of the topic and delve into applications of exercise and/or pharmacological stress echo for the different valvular heart diseases, including aortic valve disease, mitral valve disease, and prosthetic valve disease, and end with a summary of the topic. So an overview, there are three major clinical indications for stress echocardiography in native valve disease. And these include asymptomatic severe valve disease, symptomatic non-severe valve disease, and valve disease with low flow state. And the major goal of stress testing in valvular heart disease is basically to clarify disease severity and also help guide indication and timing for intervention. This is a nice diagram, basically giving a pretty good summary of what parameters we need to focus on when we're doing a stress testing to assess severity of valvular heart disease. And as you can see up top, you have two major categories. First one, you may have a disease state where the severity does not match with the symptoms. And in the second category, you may have asymptomatic but moderate to severe valvular heart disease. And in both instances, when you're doing stress testing, you're looking at symptoms, you're looking at high-risk features, including change in blood pressure, and how well the patient tolerates exercise, and some of the specific parameters that are important at the valve level. You're looking at changes in mean pressure gradient, for instance, for aortic stenosis, a change in 18 to 20 millimeter mercury, and mean pressure gradient is significant change, and in mitral stenosis, a mean gradient, diastolic gradient greater than 15 to 18 millimeter is also considered severe disease. And in mitral regurgitation, a change in effective regurgitation orifice area of greater than 10 to 13 millimeter is considered significant change in severity. What about at the ventricle level? You're at this, the ventricle, you're looking at contractility reserve, and that is primarily assessed with left ventricular ejection fraction, change less than 4 to 5%, or in global longitudinal strain, less than 2% are both considered low or lack of adequate contractile reserve. Change in stroke volume is also important to assess. Less than 20% is considered inadequate augmentation in stroke volume. And in patients where you're also suspecting ischemia as part of the etiology of the valvular disease, or potentially contributing to symptoms, looking at wall motion abnormality is important. LV dysynchrony, RV dysfunction are all important parameters to pay attention to. What about additional hemodynamics? LV filling pressure, increasing that, or pulmonary hypertension, particularly in the severe range greater than 60 millimeter mercury, are also important parameters. And why are these, the cumulative assessment using these parameters helps one, match symptoms with whether the valvular heart disease is actually contributing to symptoms, and helps risk stratification, both pre and post intervention, and ultimately help guide decision-making as far as timing for surgery and when it's safe to just closely follow up the patient. So to summarize, basically the information from the diagram: an asymptomatic severe valve disease, you're eliciting symptoms, especially in sedentary patients. You're assessing hemodynamic consequences of exertion, such as hypertension, arrhythmia, pulmonary, hypertension, etc. And in symptomatic non-severe valve diseases, you're trying to delineate whether the valve disease is actually severe, and you're also assessing dynamic changes in severity with that may be more apparent with exercise and potentially regrade the disease severity. And in valve diseases with low flow, you're determining the severity of valve disease based on flow dependent changes, and that comes with stress. So to delve into some of the particular valve diseases, aortic valve is one of the major ones that we do stress testing for. Asymptomatic severe aortic stenosis. If patients have severe aortic stenosis but claim to be asymptomatic, stress testing could be helpful. And this is to unmask symptoms, especially if they're sedentary and they're not exerting much, and unmask high-risk features like hypotension, arrhythmia, wall motion abnormalities, and symptoms or other hemodynamic changes indicate worse prognosis. And as far as, based on current guidelines, in asymptomatic severe aortic stenosis, stress testing is safe with the appropriate physician supervision, and that's class 1 recommendation. And it can provide valuable prognostic information. And it's very important to note, if patients have severe aortic stenosis and are symptomatic, then stress testing is contraindicated. And this is why it's very important to get really good clinical history in someone with severe aortic stenosis and make sure that they're truly asymptomatic before deciding on a stress test. And for aortic stenosis, you can use treadmill stress testing, supine, bicycle, or dobutamine. Dobutamine protocol, especially for low flow, low gradient, you start at 5 and it increase up to 20 microgram per kg per min. You acquire pre and post imaging, aortic valve, CW through the aortic valve, LVOT, PW. This allows you to also measure your stroke volume, LVOT diameter, pulmonary artery systolic pressure, so using UTR jet, and LV ejection fraction. And it's very critical to use the same imaging window with highest velocity at baseline for post-exercise hemodynamics also, so that you have matching, ideal for validity purposes. And strain imaging could also help with prognosis. So what are some things, important parameters to look at? An increase in mean aortic pressure, 18 to 20 millimeters mercury is very significant increase. A decrease or no change in left ventricular ejection fraction, again, indicates a limitation of LV functional reserve. And induced pulmonary hypertension greater than 60 millimeter mercury, and strain imaging also helps with assess contractile reserve. This is an image basically showing someone with asymptomatic severe aortic stenosis, pre and post imaging. Like I mentioned, patient is asymptomatic, as you can see from the GLS and the left ventricular ejection fraction. You don't have very significant change between rest and exercise images, indicating of reduced exercise contractile reserve. The third row shows aortic valve area not changing much pre and post exercise, and you have filling pressures increasing from 22 to 35 E to E prime. And what basically this shows is that there was a significant hemodynamic change in with exercise, no significant change in the valve area, and also no significant change in the parameters that assess contractile reserve. And this is a patient that could potentially has significant hemodynamic changes that are all prognostic markers. And based on that, the current recommendation is that it's a class 2B recommendation for aortic valve replacement in asymptomatic patients with severe AS, and an increase in mean gradient with exercise of 18 to 20. And in those patients who may not have that delta in their mean gradient, but still develop low contractile reserve, pH with exercise, and increased filling pressures, closer clinical and echocardiographic follow-up is very important for these patient population. What about low flow, low gradient aortic valve disease? I feel like this is one of the areas that we tend to use stress echo to help with clinical management. First, definition of low flow, low gradient. You have an aortic valve area of less than 1 or index 0.6 centimeter square per meter square, and mean gradient less than 40, and your ejection fraction is less than 50%. This is image of aortic stenosis in a low flow state, low flow, low gradient aortic stenosis, pre and post exercise. As you can see from the top images, patient's stroke volume at rest is 53, ejection fraction is 40%, mean pressure gradient of 29, and the aortic valve area of 0.7. And with the dobutamine stress protocol, stroke volume went up to 73, which is adequate augmentation, greater than 20%. Their ejection fraction went up to 50, mean pressure gradient went up to 52, and aortic valve area stayed pretty much the same, less than 1 centimeter square. And this is basically indicates that with appropriate augmentation in stroke volume, then you have appropriate the mean pressure gradient being greater than 40 is in line with the severity of the aortic stenosis by valve area. So this is true severe aortic stenosis. So the second case, also a patient with an ejection fraction less than 50%, stroke volume went up from 34 to 46. Adequate response to the dobutamine stress test. Ejection fraction went up 5 to 10%, mean pressure gradient 12, and pretty much stays the same, and the aortic valve area increased from 0.8 to 1.2. So this is the classic case of pseudo-severe aortic stenosis, where you have an increase in valve area, but your mean pressure gradient stays the same or less than 40% with an appropriate augmentation in stroke volume. So pseudo-severe aortic stenosis. What about the third scenario that you could run into? So this is a case where you have no significant change in stroke volume from baseline to post-exercise, where you know, in this case, stroke volume went up from 51 to 57, ejection fraction pretty much stayed the same, less than 4 to 5%, and the mean pressure gradient 27 to 30, also not very significant, valve area also less than 1. And in this situation, you have what's considered an intermediate valve severity, because not having the adequate stroke volume still doesn't necessarily rule out severe valve disease, true severe or pseudo severe. And so you run into a situation where you may need to use other imaging modalities, such as calcium scoring, to help delineate the severity of the valve disease better. So just to quickly summarize using this diagram of what I've explained so far. So classical low flow, low gradient aortic stenosis, the parameters are listed above. Dobutamine stress echo, if you have an augmentation of stroke volume greater than 20%, that's adequate flow reserve. And then you look at your pressure gradient. If it is above 40 and valve area remains less than 1, then that you have true severe, that's an indication for surgical or transcatheter intervention. But if you have pressure gradient staying less than 40, so not in a severe range, but in valve area improving to above 1, then you have pseudo-severe aortic stenosis. So you focus on medical management, heart failure therapy. And in patients with Stroke volume, low function flow reserve, less than 20% augmentation in stroke volume, then you're in the indeterminate phase, and you could get a calcium score if you have a calcium score greater than 2000 or greater than 1200 for females and males and females respectively, then that's considered true severe AS, and you can consider surgical intervention. What about paradoxical low flow, low gradient aortic stenosis? The main difference between this one and the low flow, low gradient is the ejection fraction being greater than 50% in paradoxical, but with the stroke volume index still low, less than 35. And this is just, quickly go over this algorithm of someone with paradoxical low flow, low gradient aortic stenosis. You first assess, measurement error, assess for symptoms, and if they're symptomatic, you ask for other diagnosis such as hypertension. If that's, if they're hypertensive, you treat their hypertension, you reassess the parameters again. If they don't have hypertension and you're concerned about, it being a true aortic stenosis, then you rule out pseudo-severe or severe aortic stenosis, pseudo-severe aortic stenosis with calcium scoring or with dobutamine stress echo. And if it is true severe, then you consider surgical catheter treatment. And if in cases of pseudo-severe, then you basically do the same thing for the low flow, low gradient state of following them closely and optimizing their heart failure therapy. What about severe aortic regurgitation? Onset of symptoms is very important for aortic regurgitation in terms of timing of intervention. Asymptomatic severe aortic regurgitation, exercise stress testing is primarily to help with symptom assessment. And it's important to understand that, you cannot really do, accurate hemodynamic assessment of with aortic regurgitation with exercise, because with exercise you have shortened diastole, so that limits your quantification of AR severity. So look at contractile reserve with ejection fraction, strain, PSP, whether you have presence of MR, and all of those could help with prognostication. Okay, so next is the mitral valve disease severity. In asymptomatic severe mitral regurgitation, exercise echo may provoke symptoms and be useful to assess also the systolic pulmonary artery pressures response, and this, for risk stratification purposes. And stress test is reasonable in symptomatic patients with moderate MR. So asymptomatic severe mitral regurgitation, you do it to elicit symptoms, and in patients with moderate MR, it's still reasonable to do. And in this situation, you can actually assess whether the severity is worsened with exercise. And some of the parameters to pay attention to: if MR severity increases by greater than or equal to 1 grade, PSP increases by greater than 60, absence of contractile reserve, increment in global longitudinal strain by 2%, RV dysfunction. All of these are important markers of worse prognosis. So this is an image of pre and post mitral valve stress test for mitral valve regurgitation. So in this patient, you have EF not changing much. The JLS also pretty much the same, pre and post, indicating decreased cardiac contractility reserve. You have a significant increase in the pulmonary artery systolic pressure, and a significant change in the MR based on color and mode and color Doppler. So these are parameters that you need to obtain as part of your stress testing protocol. So in primary MR, if the MR is not severe at risk, just like I explained, you obtain those parameters and assess the severity of the disease and also symptoms. And in secondary MR, it's important sometimes it may be caused by ischemia, if it's an ischemic MR, and worsening of the MR with exercise test, in addition, plus or minus other ischemic changes that you may see is indicative of worse prognosis in this patient. So what about mitral stenosis? Asymptomatic severe mitral stenosis, valve area less than 1 centimeter square based on the ASC guidelines and less than 1.5 based on the ACC AHA guideline is considered severe. And in asymptomatic severe mitral stenosis, exercise stress test is recommended for symptom assessment. So asymptomatic severe MS. And in asymptomatic moderate mitral stenosis, in addition to symptoms, you could also assess other hemodynamic parameters that could help you regrade someone or consider intervention. And this is particularly important for patients who are planning pregnancy or major surgery in terms of risk stratification. So non-severe, what about in the non-severe mitral stenosis with symptoms? Assessing with stress testing, you assess for increase in mean gradient greater than 15. With exercise, you could also do the butyramine, greater than 18 for the butyramine, and also assessing their systolic pulmonary artery pressure greater than 60 are important parameters to consider. So this is just a diagram showing pre and post of things that you look at. You're looking for as far as mean gradient, CW through the mitral valve, CW through the tricuspid valve for the PSP estimation, and pressure half time for valve area calculation. Briefly going through a prosthetic valve, overall it's similar to native valve assessment. Stress test is valuable tool for the evaluation of prosthetic valve hemodynamic function, and it may be useful when there is, particularly when there's a discordance between patient symptoms and the hemodynamics that may be the prosthetic valve hemodynamics. Exercise or low dose dobutamine protocol can be used to assess severity of prosthetic valve disease. Again, similar to native assessment, and I've included this diagram as far as with low dose dobutamine protocol and what's the algorithm that's used for prosthetic valve disease in the parameters, and also this one for review. In the interest of time, I will not delve into them further, but I've included them. But overall, it's pretty much similar to native valve assessment for a lot of these parameters. So in summary, stress testing is an important tool to assess severity and symptoms of native and prosthetic valvular heart disease, and it could be very helpful and essential to guide timely and appropriate interventions and prognosis of valvular heart disease and progression, and also understanding which protocol to use is very important. So this concludes my presentation. Thank you for the invitation. Have a nice day.
Thank you, Dr. E.T. Bahiru, for the very comprehensive lecture about stress echocardiography in the assessment of severity of valve disease. Next speaker, I would like to introduce Dr. Giáp Thị Minh Nguyệt from Vietnam National Heart Institute, who will present the topic pre-operation and post-operation echocardiography interesting cases.
Kính thưa ban chủ tọa đoàn, kính thưa tiến sĩ Hoài và giáo sư Kirkpatrick, kính thưa quý vị đại biểu, em xin trình bày bài siêu âm tim trước và sau phẫu thuật. Hiện nay tại Viện Tim Mạch thì bên cạnh điều trị nội khoa và tim mạch can thiệp thì đơn vị phẫu thuật đã đạt được những bước tiến rất mạnh mẽ và nhanh chóng. Số lượng bệnh nhân hàng năm được phẫu thuật tại viện lên tới hơn 2.000 và 3.000 người với mặt bệnh rất phong phú. Đó là bệnh van tim do thấp, bệnh van tim do thoái hóa, bệnh tim thiếu máu cục bộ, các bệnh lý tim bẩm sinh và rất nhiều mặt bệnh khác. Sau đây em xin trình bày một số ca lâm sàng mà chúng em đã gặp trong thời gian ở gần đây. Bài trình bày của em bao gồm 4 ca lâm sàng. Thứ nhất là u nhầy nhĩ trái, thứ hai là viêm nội tâm mạc ở bệnh nhân có máy tạm nhịp vĩnh viễn, thứ ba là bệnh nhân còn ống động mạch và thứ tư là một bệnh nhân hẹp hở van hai lá hậu thấp. Ca lâm sàng đầu tiên u nhầy nhĩ trái, bệnh nhân nữ 58 tuổi vào viện ngày 30 tháng 8 năm 2022, tiền sử khỏe mạnh, vào viện với lý do khó thở và gan to. Điện tâm đồ chỉ thấy nhịp nhanh xoang, khi xâm thành ngực thì thấy có khối ở trong nhĩ trái. Khối này kích thước lớn khoảng 5 cm, rất di động, hở hai lá nhẹ, chức năng tim và kích thước buồng tim bình thường, áp lực động mạch phổi tâm thu tăng nhẹ. Đây là hình ảnh siêu âm tim của bệnh nhân, có thể thấy một khối đậm âm rất là lớn ở trong lòng nhĩ trái. Cùng ở mặt cắt này khi đặt lóp le màu thì chúng ta thấy là cái khối này di động rất là mật độ đậm độ tương đối đồng nhất, di động nhiều, tụt và xa vào thất trái trong thời kỳ tâm trương, có một chút hở hai lá. Tuy nhiên ở trên siêu âm thành ngực thì không rõ là cái khối này cuống ở đâu và bản chất có bám vào van hai lá hay không. Do đó bệnh nhân được tiến hành làm siêu âm tim qua thường quản. Ở mặt cắt này thì chúng ta thấy là khối u ở trong lòng nhĩ trái kích thước lớn, tuy nhiên không hề có liên quan gì đến tổ chức vòng van. Trong các chu chuyển tim thì các khối này di động rất là nhiều, khối xa hẳn vào trong bùn thất trái làm cản trở đường vào của thất trái trong thời kỳ tâm trương. Tiếp tục xoay đầu giò ở mặt cắt hai buồng nhĩ thì có thể thấy để đi tìm chân cuống của khối u thì thấy là khối u này đậm độ tương đối đồng nhất, có nhiều thùy và có cuống nhỏ bám vào vách liên nhĩ. U không hề liên quan đến tổ chức vòng van hai lá. Sau đó bệnh nhân đã được điều trị mổ cấp cứu. Khi mổ ra thì tổn thương trong khi mổ là khối u nhầy có cuống nhỏ bám vào vách liên nhĩ kích thước 4 đến 5 cm. Khi bệnh nhân được phẫu thuật cắt bỏ toàn vẹn khối u, không sót mảnh u và không nhỏ lại vòng van hai lá. Đây là một trường hợp u nhầy nhĩ trái điển hình. U nhầy nhĩ trái là một khối u bản chất u nguyên phát ở tim, là loại u lành tính hay gặp nhất, thường gặp ở nữ giới, tuổi trung niên và ở bệnh nhân này thì không hề có tổn thương khác như là tổn thương da, tổn thương hệ tiết niệu sinh dục, không có yếu tố tính chất gia đình. Như vậy là đây là một bệnh nhân u nhầy nhĩ trái đơn thuần. Sau đó bệnh nhân đã được mổ cắt u nhầy và đây là cái hình ảnh khối u nhầy nhĩ trái trong khi đang phẫu thuật, cái khối u rất là lớn. Thì u nhầy nhĩ trái là một khối u bản chất tương đối lành tính, có thể có cuống hoặc là có chân, thì đa số 75% là có cuống dài. U có thể là dày dính, có thể có nhiều khối, có thể mủn nát, và nếu như u có nhiều thùy và mủn nát thì đấy là những cái yếu tố dễ gây tắc mạch cho bệnh nhân, và đấy là cái yếu tố cũng đồng thời là khiến cho bệnh nhân là phải có xem xét cái chỉ định mổ cấp cứu. Khi làm giải phẫu bệnh bằng hai phương pháp NE và PSS thì cho kết quả như sau. Tế bào u hình thoi hoặc là hình sao, bào tương chia nhánh phân nhỏ đứng ở trong mô đệm nhầy, chảy máu, nhiều mạch máu giãn rộng trong lòng huyết khối. Ngoài ra có rất nhiều đại thực bào, lympho bào và tương bào, không thấy ác tính. Như vậy đây là một trường hợp u nhầy nhĩ trái điển hình, và sau khi mổ thì bệnh nhân đã có một quả tim bình thường với cấu trúc và chức năng tim hoàn toàn bình thường. Ca lâm sàng thứ hai em xin trình bày đấy là một trường hợp viêm nội tâm mạc nhiễm khuẩn ở bệnh nhân có máy tạm nhịp vĩnh viễn. Bệnh nhân nam 74 tuổi vào viện ngày 14 tháng 4 năm 2002, lý do vào viện là sốt nhẹ và mệt. Bệnh nhân được đặt máy tạm nhịp 10 năm do hội chứng suy nốt sang, sau đó được thay máy một lần do máy hết pin. Vào viện thì các xét nghiệm bi lăng viêm tăng nhẹ, cấy máu thì âm tính. Đây là hình ảnh X quang tim phổi của bệnh nhân ạ. Có dây điện cực và có máy tạm nhịp. Khi làm siêu âm tim thành ngực thì có thể thấy một khối rất là lớn ở trong buồng nhĩ phải gắn vào điện cực. Tuy nhiên ở trên siêu âm tim qua thành ngực thì không thể xác định được là khối này có liên quan đến cái đến tổ chức van ba lá hay không. Thấy là khối này di động rất là nhiều xa vào buồng nhĩ bằng buồng thất phải trong thời kỳ tâm trương, khối di động theo chu chuyển tim. Ở mắt cắt 4 buồng trong mỏm thì thấy là van ba lá hở nhẹ, và ngoài ra thì cũng không thể thấy được rõ hay không là có hay không tổ chức xùi van ba lá. Sau đó thì bệnh nhân được tiến hành tiếp tục làm các thăm dò siêu âm tim thành ngực ở các mặt cắt khác, thì có nghi ngờ là khối xùi bám vào tổ chức dây điện cực ở trong buồng tim phải. Tiếp tục tìm thăm dò ở mặt cắt 2 buồng nhĩ ở mặt cắt dưới mũi ức thì thấy là có một số vị trí bộc lộ rõ ra là có dây điện cực và có tổ chức xùi lớn bám ở đầu dây. Nhưng tuy nhiên van ba lá vẫn không quan sát hết. Sau đó bệnh nhân được tiến hành siêu âm tim qua thực quản. Ở trên siêu âm tim qua thực quản thì thấy rõ là khối xùi bắt nguồn từ dây điện cực đi từ tĩnh mạch chủ trên. Khối xùi rất là lớn, kích thước 3 cm và di động mạnh. Đây là hình ảnh siêu âm tim 3D của bệnh nhân, có hình ảnh khối xùi rất là lớn. Bệnh nhân được mổ với tổn thương khi mổ là khối xùi rất là lớn bám vào dây điện cực ở trong buồng nhĩ phải, van ba lá thanh mảnh hở nhẹ không có xùi. Bệnh nhân được mổ rút lại dây điện cực và đặt lại máy tạo nhịp ở dưới thượng tâm mạc. Đây là hình ảnh siêu âm tim của bệnh nhân khi bệnh nhân mổ. Thì đây là cái khối xùi rất là lớn và có thấy dây điện cực của bệnh nhân. Đây là hình ảnh khối xùi khi mổ ra, nó tương đương với, nó rất giống với hình ảnh siêu âm tim qua thực quản 3D. Ca lâm sàng thứ 3 là một trường hợp có ống động mạch. Bệnh nhân nam 27 tuổi vào viện ngày 19 tháng 8 năm 2022 với lý do là sốt kéo dài. Trên lâm sàng bệnh nhân có biểu hiện nhiễm trùng rõ, có tiếng thổi ở tim, bi lăng viêm tăng rõ và cấy máu ra vi khuẩn điển hình của viêm nội tâm mạch nhiễm khuẩn, đấy là liên cầu. Bệnh nhân được siêu âm tim, kết quả siêu âm tim là còn ống động mạch sân trái phải, có nhiều xùi trong thân động mạch phổi, van động mạch phổi thanh mảnh không có xùi, hở chủ nhiều, xùi van động mạch chủ, hở hai lá nhiều và tăng áp động mạch phổi nhiều. Đây là hình ảnh siêu âm tim của bệnh nhân ở mặt cắt trục dọc vành ức trái. Thì đây là trường hợp mà buồng thất trái giãn và van hai lá vẫn tương đối thanh mảnh, nhưng mà có dấu hiệu gián tiếp, đấy là dấu hiệu rung lá trúc van hai lá, gợi ý là hở chủ nhiều. Khi thăm dò ở mặt cắt trục ngắn cạnh ức thì có thể thấy rõ hình ảnh còn ống động mạch với dòng khảm màu. Đây là ống động mạch sân trái phải, dòng màu đi từ động mạch chủ xuống vào thân động mạch phổi. Van động mạch phổi ở trường hợp này có thể quan sát thấy vẫn thanh mảnh và không có xùi. Thăm dò tiếp theo được thực hiện ở mặt cắt trên hõm ức, thấy là đây là một cái ống động mạch khá lớn. Kích thước ống động mạch vẫn là sân trái phải, tuy nhiên ống động mạch cái kích thước gần bằng với cả động mạch phổi. Trên mặt cắt 5 buồng từ mỏm thì có thể thấy tổ chức xùi rất là lớn bám ở lá van của van động mạch chủ. Khối xùi lớn và di động nhiều về phía đường ra thất trái, tức là phía có dòng rối. Tiếp tục thăm dò bằng siêu âm Doppler màu thì thấy là dòng màu rộng lớn và có lan đến gần mỏm tim, gợi ý là hở chủ nhiều. Khi thăm dò hở hai lá và hở ba lá thì thấy là van hai lá, van ba lá tương đối thanh mảnh, hở hai lá nhiều, hở hai lá cơ năng do giãn vòng van, hở ba lá nhiều cũng do giãn vòng van. Khi nhìn quan sát lại hình ảnh siêu âm tim 2D thì thấy là trong lòng động mạch phổi giãn và trong lòng động mạch phổi có những tổ chức đậm âm bám ở trong lòng thân mạch phổi cùng ở chỗ mà có dòng màu phụt vào. Đây chính là tổ chức xùi. Trong khi đó van động mạch phổi thanh mảnh và không có xùi. Tổn thương khi mổ đó là ống động mạch có xùi thân động mạch phổi, van động mạch chủ 3 lá van, tổn thương xùi lớn van động mạch chủ và tiêu lá van, hở 2 lá nhiều do giãn vòng van. Sau đó bệnh nhân được phẫu thuật lấy xùi thân động mạch phổi, thắt ống động mạch phía động mạch phổi, thay van động mạch chủ cơ học số 23 và sửa van 3 lá, sửa van 2 lá. Đây là tổn thương khi mổ, có tổn thương xùi van động mạch chủ và thủng van động mạch chủ do viêm nội tâm mạc nhiễm khuẩn. Sau đó bệnh nhân được thay van động mạch chủ cơ học thì van động mạch chủ cơ học hoạt động bình thường và ca lâm sàng cuối cùng là một bệnh nhân hẹp hở van 2 lá do thấp. Thì khác với ở các nước Âu Mỹ, hiện tại các bệnh lý van tim hậu thấp vẫn là bệnh lý hay gặp ở Việt Nam. Em xin giới thiệu về một trường hợp hẹp hở 2 lá do thấp điển hình. Đây là một bệnh nhân nữ chưa có tiền sử gì đặc biệt vào viện vì khó thở và phù. Khi làm siêu âm tim thì ở mặt cắt trục dọc cạnh ức thì đã thấy là ở trên mặt cắt này nhĩ trái giãn, trước buồng tim trái, buồng tim phải kích thước tương đối là bình thường. Thấy van 2 lá nó không giống với van 2 lá thành mảnh bình thường mà là van dày vôi co rút và lá van không mở hết, lá van mở hạn chế, có dấu hiệu là hình ảnh gậy hockey. Đây là hình ảnh van tim do thấp điển hình với các tổn thương như sau: dây chằng co ngắn này, bờ van dày này, lá van dày và van có những nốt vôi lớn, đồng thời là van đóng không kín, mở không hết và đóng không kín. Khi dùng Doppler màu vào thì thấy là có dòng màu rất là lớn đến ở đằng sau van, ở thí tâm thu. Khi quan sát van 2 lá mặt cắt trục dọc thì thấy là van mở không hết và cái lỗ van mở ra giống như hình miệng cá chép. Hình ảnh tổn thương điển hình của bệnh lý van 2 lá hậu thấp. Đây là hình ảnh siêu âm tim 3D của bệnh nhân với bờ van dày, mép van dính và van mở hạn chế, diện tích van nhỏ. Khi đặt Doppler màu vào qua van thì sẽ thấy có dấu hiệu ngọn nến, tức là gì? Tức là sau van 2 lá có một dòng chảy tâm trương, đây là dòng rối qua chỗ hẹp, do vậy đấy là dòng rối, dòng tăng sáng. Khi thăm dò bằng Doppler màu thì thấy là sau van 2 lá có dòng rối tâm trương, tức là dòng chảy rối qua một vị trí hẹp, và ngược lại khi ở thời kỳ tâm thu thì thấy có dòng rối này là thể hiện dòng hở 2 lá, rất là lớn, dài, và vận tốc tăng, khảm màu sáng và lan đến tận trần nhĩ trái, đến tận các tĩnh mạch phổi, gợi ý là có hở 2 lá nhiều. Đây hình ảnh Doppler liên tục qua van 2 lá bị hẹp thì thấy là ngoài cái chênh áp tâm trương thì có dấu hiệu gián tiếp của hở 2 lá nhiều, đó là phổ Doppler đặc và tăng sáng. Van 3 lá tổn thương không có gì đặc biệt, hở 3 lá nhẹ vừa. Tổn thương sau khi mổ là van 2 lá dày vôi do tổn thương thấp, van 3 lá hở nhẹ vừa, không có huyết khối tiểu nhĩ trái và nhĩ trái. Sau đó bệnh nhân được thay van 2 lá cơ học, và đây là cái van 2 lá khi mổ. Tổ chức van rất là dày, bờ van dày vôi. Bệnh nhân được thay van 2 lá cơ học, chức năng tim buồng nhĩ trái đã nhỏ lại, chức năng tim bình thường và với chênh áp của van là bình thường. Tất cả những bệnh nhân này đều đã được phẫu thuật và hiện tại kết quả theo dõi rất là tốt. Thì phần trình bày của em xin kết thúc ở đây ạ. Em xin cảm ơn ban chủ tọa đoàn ạ.
Cảm ơn thạc sĩ bác sĩ Giáp Thị Minh Nguyệt đã trình bày 4 ca lâm sàng rất là hay, phản ánh các mô hình bệnh tật tại Viện Tim mạch Việt Nam cũng như là tại Viện Tim mạch cũng như là tại Việt Nam. Chúng ta thấy là vẫn còn tồn tại rất là nhiều bệnh nhân với các bệnh lý van tim, các bệnh lý tim bẩm sinh và đến muộn với những biến chứng như là xùi, rồi viêm nội tâm mạc nhiễm khuẩn và rồi những trường hợp là khối u tim, vân vân. Tôi xin trân trọng cảm ơn bác sĩ Nguyệt với những nội dung rất là hay và hình ảnh siêu âm minh họa rất là hấp dẫn. Tiếp tục chương trình chúng tôi
Those were wonderful cases. Thank you very much. Well, it's now my pleasure to introduce Baxi Yin. We had the pleasure of hosting Baxi Yin at our institution to learn about congenital heart disease in adult patients. And it was truly a pleasure to be able to interact and discuss the differences and similarities of adult congenital heart disease in Vietnam and in the United States. And we have subsequently had the opportunity to have some online webinars between our different countries that have been very fruitful for both of us. And so we're very happy to be able to welcome her to the podium to discuss adult congenital heart disease cases with echocardiography. Baxi Yin.
Thank you, Professor Kirkpatrick. Xin phép chủ tọa đoàn, xin phép em xin báo cáo cho cái ca. Đây là một cái bài cuối cùng ạ. Thì sau đây thì là tôi xin trình bày 2 ca lâm sàng về một cái loại tổn thương mà chúng ta không thường gặp, nhưng mà cho nên là rất là hay bị chẩn đoán nhầm ạ. Và qua những ca lâm sàng này chúng ta thấy cái vai trò của siêu âm tim trong cái việc chẩn đoán các cái bệnh lý tim bẩm sinh. Thì đây là ca thứ nhất, đấy là một bệnh nhân nữ 28 tuổi có tiền sử tim bẩm sinh từ nhỏ, nhưng mà chưa điều trị gì. Bệnh nhân khó thở khi gắng sức cho nên là vào viện khám lâm sàng thì thấy nổi lên cái tình trạng là bệnh nhân có tím môi đầu chi, SpO2 là 83%. Về huyết động thì cũng không có gì đặc biệt, ngoài ra là nghe thấy một cái tiếng thổi tâm thu cạnh ức bên trái. Các cái xét nghiệm cận lâm sàng thì trên điện tâm đồ chúng ta sẽ thấy cái hình ảnh là có tăng gánh thất phải. Ở trên phim X-quang thì thấy là có bóng tim to và có vẻ như là có giãn buồng nhĩ phải. Như thế này là chúng ta sẽ thấy là có vẻ như là có một cái vấn đề gì đó của bên tim phải, có sự tăng gánh của bên tim phải. Thế thì trên cái siêu âm tim qua thành ngực thì bệnh nhân này có nhiều bản siêu âm tim, trong đó thì đây là những cái hình ảnh mà chúng tôi đã thu thập được. Thì ở trên cái mặt cắt trục dọc cạnh ức trái thì cũng không có gì đặc biệt lắm, có vẻ như có một chút dày của tâm thất phải. Sau đó thì ở cái mặt cắt, đây là mặt cắt trục ngắn cạnh ức, thì chúng tôi thấy là chúng ta sẽ thấy là có cái động mạch phổi giãn và có cái van động mạch phổi dày, và ở trên siêu âm Doppler liên tục thì chúng ta thấy một cái chênh áp rất là cao. Từ đây chúng ta sẽ thấy là có trường hợp là hẹp khít van động mạch phổi và giãn thân động mạch phổi. Thì điều này có vẻ cũng phù hợp với cái những cái xét nghiệm khám cận lâm sàng và cho chúng ta thấy là có cái tình trạng tăng cánh của thất phải. Tiếp theo đây là ở cái mặt cắt, một cái mặt cắt trục ngắn khác, thì chúng ta phát hiện ra là bệnh nhân này có hở van ba lá nhiều và có giãn các cái buồng tim phải. Và chúng ta cũng đo được một cái chênh áp rất là cao qua cái van ba lá với cái vận tốc khoảng độ 6 m trên giây. Sau đó thì ở cái mặt cắt 5 buồng từ mỏm thì chúng ta sẽ quan sát thấy là dường như là có một cái khiếm khuyết ở cái vị trí mà ở phần vách liên thất, ở giữa cái van ba lá và van hai lá. Chúng ta nhìn kỹ đây, chúng ta thấy dường như là có một cái khiếm khuyết. Tuy nhiên là ở trên siêu âm Doppler màu thì chúng ta không nhìn rõ cái sân này. Vậy đây có phải một cái trường hợp thông thất trái nhĩ phải hay không? Cũng chính từ những cái hình ảnh siêu âm nó cũng không rõ ràng như vậy, cho nên là bệnh nhân cũng có 3 cái bản siêu âm tim với các cái kết quả khác nhau. Các cái bản siêu âm tim thì đều đồng thuận là có hẹp khít van động mạch phổi và có một cái chênh áp cao giữa thất phải và nhĩ phải. Một cái bản siêu âm thì chẩn đoán là thông liên thất với cái dòng chảy quạt ngược vào trong nhĩ phải. Rồi 2 bản siêu âm khác thì có kết luận là thông thất trái nhĩ phải. Có một bản siêu âm thì nói đến thông liên nhĩ. Thế vậy thì cái điều gì đã làm cho có những cái kết quả khác nhau như vậy? Thì có lẽ là do những cái hình ảnh siêu âm trên thành ngực nó không phải là lúc nào nó cũng giúp chúng ta trả lời đầy đủ. Thế bệnh nhân cũng đã được chụp CT, thì trên CT cũng đồng thuận cái chuyện là có cái tình trạng là giãn cái thân động mạch phổi, và đây là hậu quả của cái hẹp khít van động mạch phổi. Tuy nhiên thì cũng trên CT thì không xác định được cái sân giữa thất trái với nhĩ phải. Do đó thì bệnh nhân đã được làm siêu âm tim qua thực quản. Thì đây là hình ảnh siêu âm tim qua thực quản. Ở cái mặt cắt 4 buồng tim chúng ta thấy là đây là buồng nhĩ phải giãn rất là lớn ạ. Và chúng ta nhìn thấy là đây là có hở van ba lá nhiều thì rõ ràng. Và đồng thời chúng ta thấy một cái sân đi qua vách liên nhĩ giữa buồng nhĩ phải và nhĩ trái, và đây là sân phải trái ở trong thời kỳ tâm trương. Thì có vẻ như đây là cái trường hợp của một cái mở PFO do cái tăng áp lực ở trong cái buồng nhĩ phải này. Đây là chúng ta đo, chúng ta cũng thấy là một cái chênh áp cao giữa thất phải và nhĩ phải với cái vận tốc là khoảng độ 5 m trên giây. Sau đó thì ở cái mặt cắt trục ngắn ở trên siêu âm tim qua thực quản thì ở cái mặt cắt này chúng ta quan sát được khá là thuyết phục, thấy một cái dòng chảy đi từ phía thất trái sang nhĩ phải ở phía trên của cái van ba lá này. Đồng thời thì chúng ta sẽ thấy là đây cái dòng chảy là hướng từ thất trái sang bên nhĩ phải. Đồng thời chúng ta cũng thấy là từ phía chỗ đóng của van ba lá thấy một cái dòng hở van ba lá. Thì hai cái dòng này nó gộp với nhau và nó có thể làm cho tưởng tượng là có thể là cái dòng hở ba lá nó nhiều hơn. Đồng thời cũng nhìn thấy là van động mạch phổi mở dạng vòm có cái dòng rối để chứng tỏ có hẹp khít van động mạch phổi. Như vậy là ở cái siêu âm tim qua thực quản với mặt cắt trục ngắn này chúng ta đã phát hiện ra là ngoài cái chuyện hẹp van động mạch phổi chúng ta cũng khẳng định được là có một cái sân mà nó đi từ thất trái sang nhĩ phải. Thì đây là một cái bệnh cảnh mà chúng ta thi thoảng chúng ta mới gặp nhưng mà rất là hay bị nhầm với là thông liên thất. Và đây là cái bệnh cảnh thông thất trái nhĩ phải mà người ta gọi là Gerbot defect bằng trên tiếng Anh. Đây là chúng ta sẽ thấy cái hình ảnh rõ là có cái dòng sân như này, và đo trên 2D thì cái khuyết này chỉ khoảng độ 3 mm thôi. Thế vậy là bệnh nhân này đã được chẩn đoán là thông thất trái nhĩ phải, hay là còn gọi là Gerbot defect ở trên bằng tiếng Anh, và có hẹp khít van động mạch phổi, có PFO và có hở van ba lá nhiều, và bệnh nhân đã được mổ, được phẫu thuật, và những cái kết quả phẫu thuật thì cũng cho thấy là cái chẩn đoán này là chính xác, và kết quả phẫu thuật thì tương đối là tốt. Thế thì thông thất trái nhĩ phải là gì? Chúng ta cùng xem qua trên y văn. Thì đây là cái hình ảnh của cái giải phẫu. Chúng ta nhìn thấy cái vách liên nhĩ và vách liên thất bình thường, và chúng ta thấy là van hai lá sẽ bám cao hơn với van ba lá. Và ở cái khoảng cách giữa của van hai lá và van ba lá này chúng ta có một cái vách, đó là vách nhĩ thất. Và nếu mà có cái khiếm khuyết xảy ra ở cái vị trí này thì có thể xảy ra cái sự thông thương giữa thất trái và nhĩ phải. Nó sẽ nằm trong cái bệnh cảnh của thông thất trái nhĩ phải. Thì đây là cái tổn thương đã được mô tả từ khá là lâu rồi. Lần đầu tiên được mô tả từ những năm 1857 cơ. Sau đó thì lần đầu tiên được phẫu thuật thành công là từ năm 1956 ở bệnh viện Đại học Pennsylvania. Và sau đó thì một loạt những cái bệnh nhân được phẫu thuật thành công đầu tiên và được báo cáo năm 1958 bởi Frank Gerbot ở Đại học Stanford. Và chính vì vậy cái tổn thương này được đặt tên của vị bác sĩ này, tức là gọi là Gerbot defect. Về giải phẫu thì với cái loại mà bệnh nhân mà chúng ta vừa mới thấy thì đấy là cái thể trực tiếp thông thất trái nhĩ phải trực tiếp, là có cái tổn thương ở vách nhĩ thất này và có cái dòng sân đi từ thất trái sang nhĩ phải. Nhưng mà ngoài ra thì có những cái thể mà là thể gián tiếp, đó là cái thông thương này nó sẽ đi từ thất trái sang thất phải với cái khiếm khuyết nằm ở phía dưới của van ba lá, nhưng mà sau đó có cái tổn thương của van ba lá, cho nên là cái dòng chảy nó vẫn là đi từ thất trái sang thất phải, sau đó qua van ba lá để vào nhĩ phải. Thì đây là cái loại thông thất trái nhĩ phải gián tiếp. Còn một cái loại nữa mà cũng được người ta cũng ghi nhận được, đấy là cái loại trung gian, tức là cái thông giữa thất trái và nhĩ phải này bao gồm cả cái khiếm khuyết ở phía trước và phía trên và phía dưới của cái van ba lá. Về nguyên nhân thì có thể là bẩm sinh hoặc là mắc phải. Với những cái phương tiện chẩn đoán hình ảnh ngày nay thì người ta ngày càng phát hiện ra nhiều những cái trường hợp mà có cái khiếm khuyết, có cái tổn thương mắc phải, có thể là do viêm nội tâm mạc nhiễm khuẩn, hoặc là do chấn thương tim, hoặc là do có những cái phẫu thuật thủ thuật mà nó có động chạm đến cái vùng vách nhĩ thất này, ví dụ như thay van hai lá, sửa van ba lá, các cái thủ thuật như là đốt nút nhĩ thất vân vân, hoặc là sinh thiết nội mạc cơ tim. thì nghĩa là cái tổn thương này nó có thể là bẩm sinh hoặc là mắc phải. Thế thì về sinh lý bệnh thì chúng ta sẽ thấy rõ là có cái sự chênh lệch áp lực giữa thất trái và thất phải, nhưng mà cái chênh lệch giữa thất trái và nhĩ phải thì lại còn cao hơn nhiều. Chính vì thế cho nên là cái đặc trưng của cái tổn thương thông thất trái nhĩ phải này nó sẽ gây ra một cái sân trái phải với vận tốc rất là cao, thì đấy là một đặc trưng của nó. Và vì là cái dòng sân này với cái vận tốc rất là cao đi từ thất trái vào nhĩ phải, và nó làm cho tăng cái thể tích của nhĩ phải, thường là sẽ có giãn thất phải, giãn nhĩ phải và có thể là có suy tim phải. Về những cái đặc điểm siêu âm tim thì những cái dấu hiệu để nhận biết cái tổn thương này đó là có giãn nhĩ phải, có giãn của thất phải và có một cái sân trái phải vận tốc rất là cao, thông thường là sẽ là trên 4 mét trên giây ở trong thì tâm thu. Một số những cái dấu hiệu gợi ý để phân biệt với các cái tổn thương khác, ví dụ như thông liên thất, thì đó là thông thường cái sân này sẽ là không điển hình, tức là nó sẽ không giống những cái trường hợp mà thông liên thất thông thường mà chúng ta dễ phát hiện được. Và cái sân này thì có thể là có quan sát thấy vẫn còn sân ở trong thời kỳ tâm trương. Nếu mà thông liên thất thì thông thường ấy thì là chỉ có sân ở thời kỳ tâm thu thôi và không có trong thời kỳ tâm trương, do là cái chênh lệch về mặt áp lực giữa thất phải và thất trái thì nó không còn. Tuy nhiên là với cái thông của thất trái nhĩ phải này thì ở thì tâm trương nó vẫn còn sân, tuy nhiên là nhỏ thôi. Thế ngoài ra thì sẽ không có các cái dấu hiệu của tăng áp lực mạch phổi nặng, vốn là hay bị nhầm với cái tổn thương như thế này, bởi vì là nhiều khi cái dòng chảy từ thất trái sang nhĩ phải trong thời kỳ tâm trương làm cho người ta nhầm tưởng với là đấy là cái dòng của hở van ba lá, và đo thấy một cái vận tốc rất là cao với cái chênh áp rất là cao thì tưởng đó là tăng áp lực động mạch phổi. Thế để chẩn đoán phân biệt thì nó sẽ thông thường là hay bị nhầm nhất là với thông liên thất. Thì cái sự giống nhau là đấy là đều thấy một cái tiếng thổi tâm thu rất là lớn ở cạnh ức trái và có một cái sân trái phải trong thì thời kỳ tâm thu trên siêu âm. Tuy nhiên là có một số cái dấu hiệu khác, đó là thông thường nó sẽ có giãn, bao giờ là nó cũng có một cái dấu hiệu là giãn nhiều của nhĩ phải và thất phải. Nếu mà là có cái thông thất trái nhĩ phải, nhưng mà đối với thông liên thất thì thông thường là nó sẽ không có giãn nhĩ phải và thất phải, trừ khi là có tăng áp lực động mạch phổi nặng. Và một cái đặc điểm nữa là nếu mà có ở trong những cái trường hợp mà thông liên thất ấy, thì mà có tăng áp lực mạch phổi ấy, thì áp lực mạch phổi càng cao thì cái vận tốc, cái chênh lệch về mặt áp lực giữa thất trái và thất phải càng thấp, tức là cái sân của cái thông liên thất trong các trường hợp mà tăng áp lực động mạch phổi nặng nó vận tốc nó thấp đi thôi. Thế cho nên là những cái trường hợp này, những cái trường hợp mà chúng ta sẽ thấy là thông liên thất mà tăng áp lực mạch phổi nặng thì cái chênh áp giữa cái sân này vận tốc nó phải thấp, chứ nó không thể nào cao giống như cái thông giữa thất trái và nhĩ phải được. Thế một cái trường hợp nữa có thể nhầm đấy là vỡ phình xoang van Sava, nó giống nhau là nó cũng mình cũng quan sát một cái sân trái phải, tuy nhiên thì thường là dễ phân biệt hơn, do là trong các trường hợp mà vỡ phình xoang van Sava ấy thì sẽ là có cái tiếng thổi liên tục, sân thì sẽ là sân liên tục chứ không phải là sân trong thời kỳ tâm thu giống như cái tổn thương thông thất trái nhĩ phải, và thường là chúng ta sẽ quan sát được thấy cái vị trí phình của xoang van Sava. Một loại nữa là có thể nhầm với lại hở van ba lá tăng áp lực mạch phổi nặng, do là cái dòng chảy đi vào trong nhĩ phải với vận tốc cao làm cho chúng ta dễ bị nhầm đấy là một cái dòng hở van ba lá nhiều. Nó sẽ giống nhau là cũng nghe thấy một cái tiếng thổi tâm thu, thấy có nhĩ phải giãn và một cái dòng rối vận tốc cao ở trong nhĩ phải. Tuy nhiên để phân biệt thì chúng ta có thể thấy rằng thường là cái tiếng thổi tâm thu này nó sẽ nhẹ nhàng hơn, chứ nó không thô ráp như là cái tiếng thổi tâm thu của cái thông thất trái nhĩ phải. Và bằng cái siêu âm tim hoặc là qua thành ngực hoặc là qua thực quản, chúng ta sẽ phân biệt được cái vị trí xuất phát của cái dòng rối đấy. Thì với cái trường hợp là hở van ba lá thì cái dòng rối đấy nó phải xuất phát từ cái điểm đóng của van, chứ không phải là xuất phát từ vách nhĩ thất như là với cái thông giữa thất trái và nhĩ phải. Ngoài ra thì chúng ta đo tính cái áp lực động mạch phổi qua hở phổi thì cũng thể phân biệt được là áp lực phổi có thật sự là tăng hay không, hay là bị nhầm lẫn giữa cái dòng cái sân của thất trái nhĩ phải với lại sân của hở van ba lá. Thế thì với những cái tổn thương như thế này thì điều trị như thế nào? Thì đây là một cái nghiên cứu mà họ đã thu thập số liệu của 6 bệnh nhân. Thực ra cái số lượng bệnh nhân thì người ta thấy là cái tổn thương này gặp không nhiều. Ở trong khoảng 400 ca thông liên thất thì chỉ thấy có 6 ca bệnh nhân thông thất trái nhĩ phải. Những cái tuổi phát hiện thì từ 4 đến 19 tháng tuổi, người ta thấy cái kích thước lỗ thông thì khoảng độ 4 đến 8 mm và hầu hết thì đều kèm theo những cái dị tật tim bẩm sinh khác. Thì người ta thấy là cái đặc điểm siêu âm tim chung của những cái loại tổn thương này là gì? Đó là có nhĩ phải giãn và có một cái sân thất trái nhĩ phải vận tốc rất là cao, chênh áp rất là cao. Và cái sân trái phải này thông thường ở trẻ nhỏ thì nó sẽ gây ra các triệu chứng là làm giảm gắng sức, làm chậm lớn và suy tim. Và với cái phương pháp điều trị thì người ta thấy rằng là cái phẫu thuật đóng lỗ thông là khá an toàn, bởi vì cái tổn thương này xa các cái đường dẫn truyền và các cái bệnh nhân đều không bị ảnh hưởng đến cái nhịp tim khi mà sau khi phẫu thuật. Và sau khi phẫu thuật thì kết quả rất là tốt, không có sân tồn lưu và không có hở van ba lá đáng kể, và dẫn đến cái kết luận là với cái loại tổn thương này thì đây là một cái tổn thương khá là hiếm gặp, nhưng mà cái kết quả phẫu thuật thì tương đối tốt, và một số trường hợp thì người ta cũng đã sử dụng các dụng cụ và có thể biết được cái tổn thương như thế này. Tiếp đến là một cái ca lâm sàng thứ hai, thì đây là một cái bệnh nhân nam tuổi trung niên 52 tuổi, tiền sử thì không như ca trước là có bệnh tim bẩm sinh từ trước, đây là một ca hoàn toàn khỏe mạnh. Lúc mà đầu mà vào bệnh viện địa phương là do sốt và có sưng đau khớp mắt cá chân và khớp gối, và bệnh nhân này được cấy máu thì ra là tụ cầu vàng, thì nghĩa là bệnh nhân có cái tình trạng là nhiễm khuẩn huyết. Thế khi mà làm siêu âm tim thì người ta phát hiện ra là một cái chẩn đoán là thông liên thất, và bệnh nhân này đã được chẩn đoán là thông liên thất nhiễm khuẩn huyết tụ cầu vàng. Bệnh nhân này được điều trị bằng kháng sinh và sau đó thì bệnh nhân cũng hết sốt. Tuy nhiên là cái tình trạng lâm sàng thì nó không khá hơn, bởi vì là bệnh nhân vẫn có các cái triệu chứng của khó thở khi gắng sức và xuất hiện phù, có vẻ như là những cái triệu chứng của suy tim phải. Ngoài ra thì sau đó thì bệnh nhân đã được từ bệnh viện địa phương thì đã được chuyển lên bệnh viện tim mạch. Thì ở viện tim mạch thì cũng thấy là có một cái tình trạng khó thở khi gắng sức, và nghe tim thì thấy một cái tiếng thổi tâm thu 4/6, tức là thổi tâm thu rất là lớn ở cạnh ức trái, đồng thời lại thấy là có gan to và phù chi dưới, có nghĩa là có một cái tiếng thổi tâm thu có vẻ như là thông liên thất thật, nhưng mà lại thấy là có cái dấu hiệu của suy tim phải. Thế thì trên điện tâm đồ thì cũng không rõ lắm cái dấu hiệu của tăng cánh thất phải hay là tăng cánh thất trái, thấy có cái block nhĩ thất. Trên điện tâm đồ thì trên cái xét nghiệm máu thì chỉ có cái men gan thì cũng hơi tăng một chút. Thì kết quả siêu âm tim lần 1 thì cũng trả lời là có thông liên thất, kèm theo là có hở van ba lá nhiều, giãn nhĩ phải thất phải và suy chức năng tâm thu thất phải, thì có vẻ phù hợp với lâm sàng. Thế tuy nhiên là cái áp lực mạch phổi thì không phải là quá cao, tức là chúng ta sẽ thấy có những cái điều nó không hợp lý lắm ở đây, tức là đây là một cái trường hợp thông liên thất mà lại có suy tim phải mất rồi, thì thông thường nó sẽ phải gặp trong cái bệnh cảnh của Alzheimer, tức là phải có tăng áp lực mạch phổi nặng. Thế nhưng mà đây cái áp lực động mạch phổi thì lại không phải là cao lắm, tức là nó không giải thích, nó không phù hợp lắm giữa các những cái kết quả của siêu âm tim với nhau. Chính vì vậy thì bệnh nhân cũng đã được làm lại siêu âm tim. Thế thì đây là cái hình ảnh siêu âm tim của bệnh nhân. Thì trên mặt cắt chụp dọc này thì chúng ta cũng không phát hiện được cái điều gì đặc biệt lắm. Và đặc biệt là chúng ta cũng không nhìn thấy cái lỗ thông liên thất ở cái vị trí này, không thấy cái sân ở cái vị trí mà chúng ta hay nhìn thấy đối với các trường hợp mà có phần quanh màng hay là thông liên thất của phần dưới van động mạch chẳng hạn, chúng ta cũng có thể nhìn thấy mặt cắt chụp dọc này, thì ở đây không thấy. Thế sau đó thì ở trên cái siêu âm tim đây, ở cái mặt cắt này mà chúng ta có thể nhìn thấy nhĩ phải và thất phải đây ạ, thì chúng ta thấy rõ ràng là có cái tình trạng hở van ba lá nhiều và có giãn của nhĩ phải và thất phải. Nhưng mà ở đây chúng ta cũng không nhìn thấy cái sân gì mà đi qua cái vách liên thất ở đây cả. Thì ở trên cái hình ảnh này chúng ta cũng thấy cái giãn nhĩ phải và thất phải, đồng thời là nếu mà ước tính cái áp lực mạch phổi qua phổi hở phổi thì chúng ta không thấy cái tình trạng áp lực mạch phổi nó cũng không có cao, nó chỉ tăng nhẹ đến vừa thôi. Như vậy là đây là một cái trường hợp mà có tăng áp lực mạch phổi vừa mà nghe thấy một cái tiếng thổi tâm thu rất là lớn ở cạnh xương ức. Thế sau đó thì bệnh nhân này, đây vẫn là trên cái bệnh nhân này mà chúng ta làm cái hình ảnh cái siêu âm ở chụp ngắn đây ạ. Thì chúng ta thấy là có vẻ như là có một cái dòng rối có hướng từ thất trái, và nó nằm phía trên của cái van ba lá. Đây chúng ta thấy nhìn thấy cái van ba lá, lá vách ở đây, và đây là cái dòng rối này nó đi nằm ở phía trên van ba lá. Thì đây có vẻ như là cái trường hợp là cũng là một cái trường hợp thông giữa thất trái và nhĩ phải với đầy đủ những cái đặc điểm của nó, tức là có một cái luồng thông sân, cái vận tốc nó rất là cao, nó nằm và có cái tình trạng giãn của cái nhĩ phải, cái luồng sân này nó nằm ở phía trên của van ba lá. Và đây là cái mặt cắt tiếp theo ạ. Thì ở mặt cắt này chúng ta thấy có vẻ rõ hơn cái sân đó, thì chúng ta nhìn thấy có cái khiếm khuyết ở cái vách nhĩ thất. Đấy. Nó nằm ở phía trên của cái van ba lá. Đó. Và cái sân này nó đi vào trong nhĩ phải. Thì với cái hình ảnh siêu âm tim qua thành ngực như vậy thì có vẻ như là nó cũng đã khá là rõ ràng, và chúng ta sẽ thấy là có cái khiếm khuyết ở đây ạ. Và cái này nó có vẻ là cũng rất là khá là cái luồng sân này, cái đường kính của nó cũng khá là lớn. Và trên hình ảnh động thì chúng ta có thể thấy là cái vị trí này nó trông nó cũng không được gọn gàng lắm. Như là những cái ca bẩm sinh kia thì chúng ta đo được là đây là cái vận tốc rất là cao, vận tốc gần 5 mét trên giây qua cái sân này. Thì đây là một cái trường hợp cũng có thông thất trái nhĩ phải, có hở van ba lá nhiều, giãn nhĩ phải và có suy thất phải. Thì bệnh nhân này đã được điều trị nội khoa tình trạng suy tim phải, sau đó đã được phẫu thuật vá cái vách nhĩ thất và đặt vòng van ba lá cho cái kết quả tốt. Thì như vậy là có thể thấy là đây là một cái trường hợp thông thất trái nhĩ phải mà xảy ra sau một cái đợt mà nhiễm khuẩn huyết, thì có vẻ như là bệnh nhân này là một cái trường hợp mà thông thất trái nhĩ phải, mắc phải. Tức là khác với ca số 1 có tiền sử là tim bẩm sinh từ trước, tuổi thì trẻ hơn. Và cái tổn thương thì chúng ta cũng thấy là có vẻ như đấy là một cái vơ bốt mà là bẩm sinh. Còn trường hợp này thì bệnh nhân không hề có cái tiền sử bệnh tim bẩm sinh trước đó, tuổi thì trung niên và xảy ra sau một đợt sốt và được cấy máu ra tụ cầu vàng thôi. Thì đây là một cái trường hợp mà có thông thất trái nhĩ phải, mắc phải. Thì chúng ta có thể thấy là như vậy là cái tình huống này có vẻ như cũng không phải là quá hiếm gặp. Thì để kết luận cho cái bài trình bày hôm nay thì chúng ta qua 2 ca lâm sàng thì chúng tôi sẽ có một số kết luận sau đây. Thứ nhất là cái tổn thương thông thất trái nhĩ phải thì là một cái tổn thương không thường gặp và rất là dễ bị nhầm với thông liên thất, mà cũng có thể là do dễ bị nhầm như vậy mà có thể là làm cho cái tỷ lệ phát hiện nó sẽ thấp đi. Cái tổn thương này có thể là bẩm sinh hoặc là mắc phải. Một số cái đặc điểm để gợi ý chẩn đoán đó là có cái tình trạng là giãn thất phải và nhĩ phải, giãn nhĩ phải rất là rõ ràng ở trên siêu âm, có dòng rối với cái sân trái phải không điển hình và đặc điểm là có vận tốc rất là cao và không có các cái dấu hiệu của một cái tình trạng tăng áp lực mạch phổi nặng mà để giải thích được cho là tại sao lại có giãn nhĩ phải thất phải, và hoặc là có thể bị nhầm cái tình trạng này với lại hở van ba lá. Và khi mà kết hợp giữa các cái thông tin về lâm sàng với nhau và các cái thông tin về mặt siêu âm với nhau thì cái sự kết hợp giữa các cái phương pháp siêu âm và qua thành ngực hoặc là qua thực quản và sự kết hợp các cái mặt cắt khác nhau thì sẽ giúp cho chúng ta chẩn đoán xác định, và cũng không phải là khó khăn lắm để chẩn đoán những cái tổn thương như vậy ạ. Đấy, xin phần trình bày của em đến đây xin là hết. Xin cảm ơn sự chú ý lắng nghe của chủ tọa đoàn và các đại biểu.
Xin trân trọng cảm ơn bác sĩ Trần Hải Yến đã có bài trình bày về 2 ca lâm sàng rất là hay về bệnh lý thông thất trái nhĩ phải, và trong nhiều trường hợp của chúng ta cần phải quan tâm để phân biệt với các cái bệnh tim bẩm sinh khác. Các quý đồng nghiệp có câu hỏi gì cho 2 bài trình bày của 2 báo cáo viên bác sĩ Yến và bác sĩ Nguyệt không ạ?
Very good. Are there any questions from the audience or comments? Very good. Well, I think this has been a very successful session. We have seen many different aspects of echocardiography in clinical practice. I think we have learned so many practical things that will help us in the care of our patients. Sometimes we don't have all of the resources to use all of the things that we learned, but I think the principles and the other things that we can take from this session will help us as we think through how to make sure that our patients receive the best care that we can possibly provide for them. And I just want to say to everyone, it's been a true pleasure for me to be able to participate. And it is always a pleasure to come to Vietnam. It's been too many years during the COVID pandemic that I haven't been able to come and be with you in person. But this has been a fabulous Congress in a beautiful, beautiful setting. And I really have appreciated this opportunity. So it is my sincere thanks to all of you, and particularly the conference organizers, for this opportunity.
Thank you very much, Professor James Kirkpatrick, for organizing the session and for inviting all the excellent speakers from America, from the United States. And we hope that next year we will have more conference with more wonderful topics. And Professor James Kirkpatrick is very wonderful friends of Vietnam and wonderful leaders, and he helped us a lot. And on behalf of the Vietnamese Society of Echocardiography and of Vietnam National Heart Institute, I would like to give our sincere thanks to you for your effort to help